Good morning, everyone. For welcome to our continued online medical education series in head and neck. We are in. So we had a wonderful session on the 11th October. We are to the second. So today we welcome all the participants as well as the faculties from Australia as well as our own national faculties. So I would like to thank each and everyone for taking time out and participating in this meeting. So we have made some few changes in.
Hello.
Dr. Robinson and Dr. Lowe will speak, after which Professor Elliott will do his talk on palm. So to moderate today's session, we have my colleague, Dr. Samskriti, and a very good friend of mine who is an ENT trained head and neck surgeon. She has done a fellowship.
Hello. Akshay. Akshay.
Good number of publications. Yeah.
Oh, sorry. I couldn't hear you. I didn't know whether I was out or you were out.
Yeah, Akshay, the audio is a bit poor from your end.
Samskriti, over to you.
Okay, thank you. Thanks, Akshay and team. You guys have really put together a brilliant webinar series with really brilliant minds across the world. Without wasting much time, we'll go to our next speaker, Dr. Devendra Chokar, who needs no introduction. We all know him well. His topic for today will be predictive analysis of postoperative hypocalcemia following thyroid surgery. Over to you, sir.
Thank you. Thank you, Vishal, Akshay, again for inviting me for this talk. I'm going to share my screen now. Akshay, have you enabled me? It still says host is disabled. Akshay, can you allow me to share my screen? Otherwise, you can play it from your end. Your co-host now. I'll try and share my screen now. Yeah. Can you see my screen, Akshay?
Yeah.
Yeah. Okay, I'll just make it full screen. Give me a minute. So good morning or good afternoon, good evening, depending on which part of the world you're in. And from India, greetings for the festive season. The topic given to me today is predictive analysis of postoperative hypocalcemia following thyroid surgery. How do we limit the risks? Now, the ATA guidelines over the years has been trying to decrease the extent of surgery that we do in an effort to limit the complications. And very often we talk of injuries to the nerves, the recurrent laryngeal and the external branch of the superior laryngeal. But more importantly, or equally important, is the development of hypocalcemia. If you look at the recent meta-analysis by Kim, the incidence of hypocalcemia varies widely. Transient hypocalcemia varies anywhere from 3 to 82%, on an average 28%. Symptomatic is around 12%. It varies from 0 to 50 in various publications. And permanent, thankfully, is a little lower. It's about 2.2% and varies from 0 to 14%. Hypocalcemia varies widely. The symptoms of hypocalcemia vary widely. It may be mild, where we experience tingling or numbness, muscle cramps, and the classic Shostak's and Torsu sign. or it can go to severe hypocalcemia if untreated and undiagnosed, and can have respiratory and respiratory and cardiac problems. And hence, it is very important for us to predict which individuals will develop hypocalcemia in an effort to start replacement early, in an effort to reduce the symptoms that the individual will develop, reduce his hospital stay, and hopefully reduce testing and thereby reducing the cost. If you look at literature again, the analysis from Kim, he says that there are various predictors of hypocalcemia. There are various predictors of hypocalcemia, right from biochemical, and you can group them as biochemical, surgical, patient factors. So we'll today talk on the first two, the biochemical and the surgical factors, because these are the ones that we can modulate, we can change in an effort to get our patients normocalcemic. The third we can do very little about. So for the talk, we're going to look at three things. We're going to look at what are the predicting factors, mainly these things: vitamin D, calcium, and PTH levels. We look what is the literature talk about prophylaxis. Can you just start the patient following total thyroidectomy on prophylaxis? Just start him on calcium and vitamin D and see what happens. And more importantly, as all of us are surgeons, we look at what surgical steps or tips we can do to prevent patients from getting hypocalcemia. First, let us look at the biochemical predictors of hypocalcemia. We start from preoperative, but let us not go too much into literature for preoperative. There's a lot of literature on normalizing the calcium and vitamin D levels, and it is only prudent to correct the calcium and vitamin D level preoperatively. You don't need literature to tell you that. You need to correct physiology as much as possible, because thyroid surgery is rarely an emergency unless you have compromise of the upper aerodigestive tract. Thyroid surgery is rarely an emergency. So of course you must correct. You don't need evidence for that. Correct the calcium and vitamin D levels preoperatively. Let us look at what literature talks about predicting postoperative hypocalcemia. And one of the indicators of postoperative hypocalcemia is measurement of calcium in the postoperative period. Now, when to measure this calcium is a matter of debate, and the timing varies, but generally it is 12 to 18 hours following surgery. People have looked at the calcium, and in this study, they looked at a change of 1.4 from pre to post-op. However, when they looked at 1.1 as the cutoff, a decrease by 1.1 milligram per DL, the sensitivity increased at the cost of specificity. So they took the cutoff as 1.1. So if the calcium decreased from pre-op to post-op levels more than 1.1, you had a very high chance, or the individual had a very high chance of developing hypocalcemia. Various other studies have looked at the same, and the larger the decline in calcium levels post-operative, the larger the chance that the patient will develop hypocalcemia. And some studies have reported that a decline of more than 2.3% carries a high sensitivity of predicting hypocalcemia. Some studies have looked at the calcium slope and said that more than the negative calcium slope, that is the decline, if you have a positive calcium, which rarely occurs, following our total thyroidectomy, but if you have a positive calcium slope, then the chances of excluding hypocalcemia are very high, and the negative slope does not have a very high predictive value. So the literature is, there's a debate in literature regarding the calcium slope and the sensitivity of predicting hypocalcemia by looking at the decrease in calcium level post-operative. The same is true for parathormone, and we all know the half-life of parathormone is 3 to 5 minutes. So a decline after surgery predicts hypocalcemia, and this is one of the retrospective analysis. 521 patients, they looked at a cutoff, and as I said, for calcium, even for parathormone, the timing of parathormone is a debate, but generally what is done is 4 to 6 hours or the first day post-operative, you do the parathormone level. In this study, they looked at a cutoff of 10 picogram per ml. Those patients who had more than 10 level, hardly anybody developed hypocalcemia. Only 7% reported symptoms, not hypocalcemia. They looked at symptoms. Only 7% reported symptoms, and none of them got permanent hypocalcemia. And if you had more than 15, then it was even better. Patients who were between 5 and 10, 44% reported with symptoms, while if it was less than 5, 56% reported with symptoms, telling us that again, just like calcium, even parathormone, the higher the decline, the higher the chance that the patient is going to develop calcemia. And the meta-analysis that I was just referred to in my first slide, the one from Kim et al., which was published in July of 2020 JLO, looked at a cutoff of 8 and said that if you had a PTH of less than 8, then the patient had a 5 times higher chance of getting biochemical hypocalcemia, and that is the time, and that is the patient you need to keep in the ward, monitor him, maybe start prophylactic calcium and vitamin D supplements. And we look at prophylactic calcium and vitamin D supplements. So parathormone level and calcium level, two things that have been looked at in literature early in the postoperative period to detect patients or to predict which patients are likely to become biochemical or symptomatic for hypocalcemia. Let us look at what can we do. People have also looked at, why don't we just give prophylaxis instead of predicting, just give prophylaxis. Just start the patient empirically on calcium plus vitamin D in combination. So this is the meta-analysis which has looked at, the first group is the calcium plus vitamin D group. The calcitrol group is the calcium plus vitamin D group. The second group is oral calcium group. And the third is the control. The patients in the calcium with vitamin D who started post-operative day 1 developed only 4% developed hypocalcemia, while the oral calcium group 19% developed calcemia. Those who were not treated, 31% developed calcemia. When they looked at sorry, I can't move. Okay, when they looked at calcium plus vitamin D versus no treatment at all, calcium plus vitamin D, of course, was significantly better. When they looked at calcium plus vitamin D in combination versus calcium alone, again, calcium plus vitamin D did better than giving calcium alone, suggesting that if you need to give prophylaxis, it is better to give calcium and vitamin D in combination early in the postoperative period. Again, another RCT, another meta-analysis of 10 RCTs, more than 1,500 patients, looking at calcium supplementation for reducing hypocalcemia. Calcium supplementation did reduce biochemical hypocalcemia, but did not have an impact on decrease in the need for IV calcium or permanent hypocalcemia. While a combination of calcium and vitamin D reduced both the need for IV calcium and biochemical hypocalcemia, but again, did not have an effect on the permanent hypocalcemia, suggesting that if you need to start supplementation, start with calcium and vitamin D. Let us next come. So we looked at predictive factors. We looked at giving prophylaxis with calcium and vitamin D. If you have to give calcium and vitamin D. Now let's come to the most important factor, that is what you will do on the surgical table. There has been a lot of debate on whether you need to look at all the parathyroids when you're doing a total thyroidectomy. Do you go hunting for them? The literature is divided. Some say that the lesser you identify, the better. This study from Sheehan looked at, if you identify 0 to 2, you had a lesser incidence of hypocalcemia than if you identify more parathyroids. But the literature regarding this is heterogeneous. We do not have an answer yet. But if I need to tell you that you don't go hunting around for parathyroid glands, make an effort to at least look at the superior glands, which are constant in position. If you can't see the inferior parathyroid glands, don't go hunting around for them. If you hunt around for parathyroid glands, you may damage the vascular blood supply. What you need to, however, do, and I'll talk about it a little later in my talk, is to, when you remove the specimen, you look at the thyroid gland to see whether you have done an inadvertent parathyroidectomy. So don't hunt around in the surgical field, but once you remove your thyroid, please examine it carefully and look whether you have removed any parathyroid. So that is the way you go about in looking for the parathyroids. Yes, you will have incidental parathyroidectomy, and the incidence varies from 2.3 to 21%. And it does, in literature, it shows that incidental parathyroidectomy increases the incidence of transient hypocalcemia, and 2 or more glands are excised, if they are excised, can also increase the chance of permanent hypocalcemia. This systematic review tells us that, of course, the incidental parathyroidectomy depends on the pathology. So if you have, a gross extracapsular extension, a large goiter, a Graves' disease, thyroiditis, then the chances of, injuring the parathyroid gland are more. Of course, the procedure extent is very extensive, such as bilateral central compartment dissection, then the chances increase. The good thing about incidental parathyroidectomy is that where the location of the parathyroid glands, only 2.2% or less than 10% are located intrathyroidal. Though there's a wide variation, but majority of them are located either close to the capsule or are extracapsular dissect or are extracapsular in location. And that gives us a plane to prevent incidental parathyroidectomy. So you will have incidental parathyroidectomy because some glands will be intrathyroidal and you can do nothing about it. You will excise it. So look at your specimen. If you identify a parathyroid gland, send it for frozen, send a bit, confirm it, and then you can reimplant it. But most of the parathyroids are located close to the capsule or extracapsular, giving you a good plane, which is subcapsular plane to dissect, ligate the vessels very close to the thyroid gland, and more importantly, you should know the anatomy. So you should know where your parathyroids are situated in relationship to the inferior thyroid artery, to the recurrent laryngeal nerve, and you should also use adjuncts. Now, one of the adjuncts used is a loop. I use it personally. Some people don't advocate loops, but it just gives you that much of an advantage in locating your parathyroid gland. So know your anatomy well, know the surgical plane of dissection, know where you need to take the blood vessels in order to prevent damage. Now, there is some debate on where do you ligate the inferior thyroid artery, and I usually suggest that you take it very close to the capsule and take all the branches so that you do not damage the blood supply to the parathyroids. And that is also shown in literature that if you selectively ligate the vessels of the inferior thyroid artery, it reduces the incidence of biochemical and symptomatic hypocalcemia as compared to truncal ligation. But there is no difference in permanent hypocalcemia, and this has some bearing on leaving the parathyroid gland in situ, and I'll talk about it when I talk about implantation of parathyroids. This is important because you have to decide, and how do you decide which parathyroid are you going to leave back in situ and which are you going to take out? And some people are very keen on auto-transplanting the parathyroid, and we'll talk about that a little later. So surgical steps, as I mentioned, inferior thyroid artery, ligate close to the capsule. There are other adjuncts apart from the loops. There are various other adjuncts to help you locate the parathyroid gland, and ultrasound, CT, MRI are not the real time. The two real time ones are autofluorescence, the near infrared, and giving Indocyanine green, that is giving some kind of a fluorescence, doing fluorescence imaging by injecting a dye. Let's look at near infrared light first, and it is because the parathyroids have have endogenous fluorophores which are not yet being characterized. They emit a fluorescent signal when exposed to near infrared light, and the intensity of parathyroid is much greater than the surrounding thyroid or even the background. So the parathyroids are easily identified, and there are studies to show that if you use near infrared light to locate the parathyroids, the incidence of hypocalcemia, biochemical hypocalcemia, is lesser than if you do conventional thyroidectomy. The incidence of inadvertent parathyroid excision is lesser, and the incidence of needing autotransplantation, and thus the incidence of needing autotransplantation, is also lesser. Some people have used so autofluorescence just tells you the location. It does not tell you whether the gland is vascularized or not. So you can use injection of a dye, the ICG, which looks at the vascularity of the parathyroid glands and tells you whether this is vascular or not, helping you to make a decision for autotransplantation. Well, does it? We'll see. So this is how it looks. This is the normal view. You get the infrared view where you locate the parathyroid, and then you inject a dye, which tells you that the gland is well vascularized. Let us look at the dye injection. The dye injection studies have looked at the greatest fluorescent intensity. So if you have a gland with intensity more than 150%, none of the patients developed hypocalcemia. If the intensity was less than 150%, the greatest intensity, then some of them did develop hypocalcemia. More importantly, they looked at the average fluorescent intensity of all the four glands and said that if you have it more than 109%, you do not develop hypocalcemia, as opposed to less than 109%, 30% would develop hypocalcemia. Now, this is telling you whether the glands are vascularized or not. The problem here is that there is no standardization as what is well vascularized and what is moderately well vascularized. It doesn't give you a numerical value. We don't know at what fluorescent intensity cutoff would you need to autotransplant, and hence this adjunct is not routinely used. It is still in the experimental stage. So we do not use this routinely. There's no numerical value, as I just said. Coming to autotransplant, as I spoke about a little earlier, the success of autotransplantation comes from our experience with the treating hyperparathyroidism, where if you have to do a 4 parathyroidectomy, you implant a part of the parathyroid into the sternocleidomastoid or the forearm, and then you do not develop the incidence of permanent hypoparathyroidism is extremely low. But this, which has been popularized in hyperparathyroidism, has not been very well studied in thyroidectomies, when the glands or the parathyroid glands are not hyperfunctioning but are normal, and we do not know whether they function. So the point I'm driving is, do not be overzealous in trying to take out the parathyroid from its normal bed and auto-implanting. Yes, we do not have evidence enough in total thyroidectomies. So how do you define which glands to transplant? So if you have a congested gland, usually that does not indicate that the vascularity is poor. You can do a prick test and look at decrease the congestion. Usually these glands will give you temporary biochemical hypocalcemia, but they'll return to normal. There is no way you can know whether the vascular supply has been damaged by looking at the color of the parathyroid gland, because if you damage the arterial supply of the parathyroid gland, it will only become slightly pale. You may not be able to detect it, as opposed to the venous congestion, which gives it a brownish or blackish color. But the teaching is to keep, if you have not plucked out the parathyroid gland, try to keep the parathyroid gland in situ. Do not be too keen on removing a discolored parathyroid gland unless it's absolutely black, or it's just come out of its place, or it's intrathyroidal and you've completely cut off the vascular supply. So be careful in which parathyroids, because we are not sure whether these parathyroids work as well as when they are left back in situ. So to conclude my talk, we looked at predicting hypocalcemia, calcium and vitamin D levels postoperative. Again, the sensitivity of these tests is not great, and hence not routinely done. Also, these studies have been done, in patients with benign diseases, where they want to discharge the patient early and follow it up in OPD. For us, cancer surgeons, where we do extensive bilateral thyroidectomies with neck dissections, usually the patients will stay with you for 5 days till the drains come out. So I'm not sure whether that is a good way. But yes, if you have just a goiter surgery and you want to send the patient home early, then you can look at calcium and parathormone level post-op and predict the patient, whether the patient needs to stay indoors or can be followed up in the outpatient department. Some talk on preloading and giving prophylactic calcium and vitamin D. Again, the problem here is monitoring it. If the patient has normal calcium and vitamin D levels preoperatively, loading it can lead to hypervitaminosis and hypercalcemia. There's a slight risk of doing that if you don't monitor it well, and hence not routinely practiced. There is, of course, a lot of literature that higher surgeon volume, the lower rates of hypocalcemia. As I said, surgical technique most important: intracapsular dissection, no truncal ligation, soft handling, adequate hemostasis. As I said earlier, don't go and search for all glands. Try and limit yourself to the upper glands. If you can't see the lower glands, don't go searching for it. Just look for the thyroid specimen that you excise and auto-transplant the gland which has been excised. Mere identification doesn't mean it is adequately preserved. And auto-transplantation, be very careful in which patients you're going to do auto-transplant. So with that, I thank the organizers for giving me the opportunity, and we can take some questions if there are any.
Thank you, sir. Thanks for such a comprehensive talk. We have 4 questions at right now.
Yeah.
The first question is by Yuso, who wants to know the role of preoperative calcium and calcitriol, whether they decrease rates of post-thyroidectomy hypocalcemia, and if you do agree to give these, what would be your protocol?
So there's a lot of talk on preoperative, and that's on the first slide, that normalization of preoperative calcium and vitamin D does have an influence of your postoperative hypocalcemia, but that is not rocket science. As I said, no thyroid surgery or very few thyroid surgeries, emergencies. So if your preoperative levels and physiology is not correct, then please do correct the physiology, correct the calcium levels, correct vitamin D, and you will have a lesser incidence of hypocalcemia if you follow the surgical steps correctly. Postoperative prophylaxis has shown that you can decrease the incidence of biochemical hypocalcemia and symptomatic hypocalcemia. But again, be careful if you're following this. I don't personally follow that because there is a slight chance that you will push the patient into hypercalcemia. So I follow, we do it post-operative calcium on the second day, and we take it from there because the nadir is reached anywhere from 24 to 48 hours to 72 hours following thyroid surgery.
Okay, thank you, sir. And one more question by Mayuri ma'am. She wants to know the TMH protocol for intra-op and post-operative PTH and calcium monitoring.
We don't do intraoperative PTH. One, it is not easily available. For total thyroidectomies, we don't do it as a routine. For parathyroid adenomas and surgery related to parathyroid, we do follow that routinely because that if it's a drop of more than 50% will tell you that you've done adequate surgery, but not for as long as thyroid surgery is concerned. No, we don't follow that. We follow postoperative calcium because most of our patients when who undergo total thyroidectomy are extensive also have a neck dissection in most of the cases, and hence they stay with us anyway from 5 to 7 days. The whole thought of doing early calcium or parathormone is to discharge a patient early on the outpatient on the first day or the second day, and then follow up in the outpatient, hoping that he doesn't develop hypocalcemia. No, we don't do it.
Okay, thank you, sir. And there are a couple of surgery-related questions. One of them is from Mayuri ma'am, who wants to know how do you identify parathyroid hormone in a central compartment specimen on the back table? And what is the role of frozen section in differentiating a node from a parathyroid gland?
Right. So parathyroid, you mean to say the parathyroid gland in the central compartment? A great question.
Yes.
Very difficult to identify a parathyroid gland if you're doing a central compartment. So the teaching here is when you medially rotate, or initially when you start your surgery and you start medially rotating a thyroid, you look at 1 centimeter from the inferior pole. The circle around 1 centimeter from the inferior pole is normally where your parathyroid gland is located. If you can see the parathyroid gland early, before you have started a dissection, before you have caused some blood spillage and to obscure the color of the parathyroid, if you see it early, clip it and take it laterally, so that when you do your neck dissection or when you do a central compartment dissection, you are aware where your parathyroid gland is. If you have not seen your parathyroid and it is in the thyrothymic ligament or lower in the central compartment and you've not seen it, then it becomes that much more difficult for you to identify it when you're doing central compartment. Once you remove your specimen, look for a parathyroid gland. If you can identify it, take a sliver of the gland, send it to the frozen section, and if it confirms it's a parathyroid that you've excised, then you can mince it and put it in the sternocleidomastoid.
Okay, sir, and then ma'am, Mayuri ma'am has another question for you. How do you do a parathyroid autotransplantation in robotic approaches, and what is your experience with it?
I have no approach with robotic surgery. I do not practice robotic surgery for thyroid as of now. So I have absolutely no experience with that.
Okay, sir, and one more question by Joshna Naidu. She wants to know, do you use, what is the role of gamma probe in identifying parathyroid gland?
Yeah, as I just said, there are various adjuncts in identifying the parathyroids, and some of them use the gamma probe by injecting a radiocolloid material and then taking the patient to the theater and looking at. But normally what is used is the near infrared and the autofluorescence, a combination of both. One is to look at the parathyroid glands, and the second is to give you the vascularity. But rarely used. A good surgical technique, the points that I just mentioned are usually good enough. If you have loops, it's great, are good enough in identifying. I'm not sure if any surgeon routinely uses the near infrared or the gamma probe in his routine practice.
Okay, thank you, sir. I'm combining 3 questions here.
Yeah.
One of them want to know what do you routinely give oral calcium prophylaxis irrespective of post-operative calcium and the PTH values? And what are the periods of should the calcium levels be checked during the post-operative period? And is there a standardized hypocalcemia treatment protocol?
Great question. So no, we do not give prophylactic. We check the calcium on the second day. If the calcium levels are below 8, then we start the patient on oral calcium and vitamin D. If the calcium levels are below 7, then we supplement the patient with the IV calcium and correct the calcium levels, and then shift on to oral calcium and vitamin D. We check it on the second day and subsequently on the fourth day again to see whether the calcium levels are stabilizing. There is no guideline to tell you how frequently or when you should test the calcium levels, but generally once you start supplementation, they will stabilize, and once it becomes above 8, you can safely discharge the patient.
Okay, sir, I think that's all the questions we have. Thank you, sir.
Right, thank you. I'll stop sharing my screen now. Give me a minute. Stop share.
Okay, we'll move on to the next talk, which is on indications of adjuvant therapy, which will be given by Dr. Ash Gargia, who is a senior staff specialist, endocrinologist, and also clinical lead for antenatal thyroid service at the Royal Prince Alfred Hospitals and also Bankston Hospitals. Over to Dr. Ash Gargia.
Great. Hopefully you can see the screen.
Yeah, we can.
So the outline of the talk will focus a little bit on each of these points. Firstly, the nomenclature and goals of postoperative radioactive iodine, the role of postoperative disease status assessment, specifically thyroid globulin, neck ultrasound, and/or diagnostic iodine whole body scan, and just look at some longer term outcome data utilizing those parameters. We'll then talk about the ATA and the NCCN guidelines regarding radioactive iodine based on risk stratification in relation to disease-specific survival and disease-free survival. A bit about the I-131 activity selection and preparation, thyroid hormone withdrawal versus recombinant TSH, empiric versus dosimetry on short-term success of remnant ablation and medium to long-term outcomes. And then finally, just follow up in relation to diagnostic iodine scans and radioactive iodine therapy for loco-regional recurrence and distant metastasis. And if we have time, isolated elevated thyroid globulin with no evidence of structural disease on imaging. Unfortunately, just with time constraints, I probably cannot talk about radioactive iodine refractory disease or redifferentiation therapy. So to keep things simple, this dates back at least a decade. Nomenclature and goals of postoperative radioactive iodine. Remnant ablation essentially means destruction of residual normal thyroid tissue to facilitate initial staging and follow-up. Adjuvant radioactive iodine therapy is primarily to destroy presumed residual or metastatic disease that is microscopic with the intention of staging, facilitating follow-up, and more importantly, improving disease-specific survival, decreasing recurrence and improving progression-free survival, and hopefully with a curative intent. And radioactive iodine therapy, this is for known residual or metastatic disease, where again, the hope is to facilitate staging, follow-up, possibly improve progression-free survival, and design for curative and or palliative intent. There are a number of factors that need to be considered in decision-making for adjuvant treatment. This was put together by American and European thyroid and nuclear medicine organizations last year. They came up with 9 principles. This was in accordance with the University Hospital of Martinique. And I've just pulled out 4 of these principles. That assessment of postoperative disease status is required to optimize proper patient selection for I-131 therapy. Postoperative disease status evaluation should be standardized and integrated into routine clinical care. The optimal patient selection for I-131 adjuvant treatment requires consideration and evaluation of multiple factors beyond postoperative disease status and risk stratification. And the optimal administered activity for adjuvant treatment cannot be definitely determined from published literature, and until definitive data are available, selection of the administered activity for adjuvant treatment should be based on multidisciplinary management recommendations. And just to point out that a shared decision-making process with the patient is critical, particularly when so little high-quality prospective evidence is available either for or against routine post-operative use of I-131 therapy. So typically, post-operative disease status assessment is performed 6 to 8 weeks post-surgery. Neck ultrasound does have some limitations, operator dependent. It has high sensitivity but suboptimal specificity. We know with thyroglobulin, it reaches its nadir by 4 weeks post-surgery. Between institutions and also in the literature, utilization of assays with variable sensitivity. Presence of thyroglobulin antibody can cause false negative and or false positive thyroglobulin measurements. Thyroglobulin is codependent on serum TSH. Depending upon the surgeon, if there's a larger remnant, it will influence the post-operative thyroglobulin. Based on literature, whether we utilize basal or stimulated needs to be clarified. And unfortunately, there is no specific threshold to distinguish adjuvant from therapy with radioactive iodine. Diagnostic iodine scan post-surgery plus or minus SPECT CT does have limitations with stunning, but this can be minimized by utilizing low activity I-131 or I-123. And diagnostic iodine whole body scans may be useful if extent of remnant or residual disease cannot be determined from surgical report or neck ultrasound, and it may contribute to risk stratification and staging, particularly if there's detection of unsuspected lymph node and or distant metastasis. So in the presence of a negative neck ultrasound in individuals with low to intermediate ATA risk disease, it's useful to know some of these clinical pearls, but patients with a stimulated thyroglobulin below 1 or an unstimulated serum thyroglobulin below 0.2 have very low rates of recurrent disease, less than 2%, despite not receiving radioiodine remnant ablation. Radioiodine remnant ablation and non-radioiodine remnant ablation treated patients with T1 or T2 disease without nodal involvement with an unstimulated serum thyroglobulin below 1 had no difference in recurrent disease, less than 0.5% over a 6-year follow-up. And from the Memorial Sloan Kettering Cancer Center, low-risk patients managed without radioiodine remnant ablation with T1 or T2 disease with no nodes, or if nodes were present, less than 5 lymph nodes in the neck, all measuring 1 centimeter with no extranodal extension, had a 5-year recurrence-free survival above 97%. This study from 3 years ago looked at post-operative thyroglobulin and stratified to less than 0.1, 0.1 to 1, or greater than 1 microgram per liter, and looked to see whether thyroglobulin can predict presence of disease following surgery utilizing neck ultrasound and post-treatment whole body scan. All patients had radioiodine remnant ablation. This was a combination of patients with low and intermediate risk disease, and with an unstimulated serum thyroglobulin of less than 0.1, we see 150 patients, about a half intermediate risk, and only 1 patient or 0.7% having evidence of disease post-operatively detected by neck ultrasound. We're seeing a higher percentage of patients with disease detected by neck ultrasound predominantly if the unstimulated serum thyroglobulin is between 0.1 and 1, and much higher percentage when the thyroglobulin is above 1. Conclusion from this paper was that if we decide not to treat all patients with detectable thyroglobulin and a negative neck ultrasound, we would be risk delaying the diagnosis of distant metastasis in less than 2% of cases, and to be specific, it was 1.4%. If we decide to treat all patients with detectable thyroglobulin and negative neck ultrasound, we would likely be over-treating 93% of cases. And so the recommendation of an alternative approach to monitor the trend of thyroglobulin in such patients with low-level thyroglobulin and negative neck ultrasound, and offer radioactive iodine in cases that showed a significant increase in thyroglobulin. We also know from other studies that there is a similar long-term outcome with early versus delayed ablation in appropriately selected low and intermediate risk of recurrence patients. And we also know that if we adopt active surveillance that the natural history of many thyroid cancers is stable or gradual decline in thyroglobulin levels without radioiodine remnant ablation. Some other clinical pearls: the negative predictive value of an undetectable stimulated thyroglobulin is close to 100%. Saying this, though, it's useful to keep in mind that someone who has intermediate risk of recurrence, that a basal or stimulated thyroglobulin below 1 is certainly reassuring, but it does not completely exclude the presence of small volume radioiodine avid metastases. And for someone who is high risk, a basal or a stim TG less than 1 does not rule out radioiodine avid metastatic disease and would not alter decision regarding RAI therapy. A basal or stimulated thyroglobulin above 10 is associated with an increased likelihood of persistent or recurrent disease, failing initial radioactive iodine therapy, having distant metastasis and disease-specific mortality. So this looks like a busy table, but essentially summarizes the ATA and the NCCN guidelines to determine who would benefit from radioactive iodine. And the data in the literature is pretty clear for those for whom not to give radioiodine remnant ablation and to who to give therapy to. It's the in-between that's less clear. But where radioactive iodine is probably not indicated would be those with intrathyroidal tumours, particularly micropapillary thyroid carcinomas that are unifocal and even multifocal, classic PTC 1 to 4 centimetre with no node, or even with microscopic metastases less than 5, maximum dimension up to 2 millimetre, with no extranodal extension or other high-risk features, particularly if the post-operative unstimulated serum thyroglobulin is less than 1. Probably for small tumours below 2 centimetres, even with microscopic extrathyroidal extension to perithyroidal adipose tissue, there is no clear-cut benefit in relation to disease-specific survival or disease-free survival with radioactive iodine, and minimally invasive follicular thyroid carcinoma and or less than 4 foci of vascular invasion, treatment is probably not warranted. We would consider radioactive iodine, though, if papillary thyroid carcinoma displayed an aggressive histology, being tall cell insular columnar Hopnell variant, or in the presence of lymphovascular invasion. Definite treatment with radioactive iodine where there's gross extrathyroidal extension, incomplete tumor resection, lymph node metastases above 3 centimetres with or without extranodal extension, known or suspected distant metastasis, follicular thyroid with more than 4 foci of vascular invasion, and from the NCCN, a post-operative unstimulated serum thyroglobulin above 5 to 10 micrograms per litre. It's the in-between group, the intermediate group, where we could consider radioactive iodine. So the presence of tumour above 4 centimetre, aggressive histology, lymphovascular invasion, clinical N1, N1B or more than 5 nodes, up to 3 centimetres, or post-op unstim TG less than 5 to 10. However, when we look at disease-specific and disease-free survival, certainly for the latter, we have conflicting observational data. We probably have some improvement in disease-specific survival for those aged above 55, particularly with bulky nodal disease. And we know that those with increasing number of larger and clinically relevant lymph node or extranodal extension, that there's an increased risk of persistent or recurrent disease, and these group of patients would benefit from RAI treatment. So in terms of activities and preparation, so for those patients who are selected to receive remnant ablation, typically using a dose of 30 to 50 millicuries, preparation can be with thyroid hormone withdrawal or recombinant TSH. Back in 2012, there were 2 large groups, one from France and one from the UK, reassuring us that regardless of the preparation and whether we use low or high dose, low being 30 millicuries or 100 millicurie, the success of remnant ablation assessed 8 months post therapy was no different. And these 2 groups have gone on to publish their 5 and 6 year follow-up data, showing that there is no difference between treatment arms, with 98% of patients demonstrating no evidence of disease after that time frame. The French group included predominantly patients with T1 disease with or without nodes, or T2 without nodes, and the high-low study from the UK incorporated patients with T1 to T3 with a quarter having T3 and N1 disease in 16% of patients. Using higher doses for adjuvant and treatment. Adjuvant for higher likelihood of residual disease based on operative pathology or pre-therapy radioiodine scan, and higher doses for patients with proven unresectable metastatic disease based on pathology and pre-therapy radioiodine scan. The data would indicate that empiric dosing is not inferior to dosimetry in terms of long-term disease-specific survival. Dosimetric methods, whole body or lesional, is generally reserved for patients with distant metastasis, particularly those with extensive lung metastasis, to limit toxicity to lung and potential long-term risk of pulmonary fibrosis. Elderly, where the recommendation is to avoid doses of 150 millicuries and above. Children, and also in the context of renal insufficiency. And typically where radioactive iodine therapy is implemented, preparation is with thyroid hormone withdrawal, partly due to the limitation of utilizing recombinant TSH as an indication for radioiodine remnant ablation only, at least in Australia. So the follow-up in response to treatment for those who have low to intermediate risk of disease, follow-up diagnostic iodine whole body scan has low sensitivity, particularly if the post-treatment whole body scan did not reveal uptake outside of the thyroid bed, along with follow-up undetectable unstimulated serum thyroglobulin and negative neck ultrasound. A diagnostic iodine whole body scan may be indicated in follow-up in 3 settings: if there is abnormal uptake outside the thyroid bed on post-treatment whole body scan, if there is a large thyroid remnant at the time of ablation, which may reduce visualization of lower uptake in other neck nodes, and if there is strongly positive thyroglobulin autoimmunity, where we would potentially be at risk of a false negative thyroglobulin, even in the presence of a negative neck ultrasound. In terms of additional radioactive iodine therapy, this can be repeated every 6 to 12 months as clinically indicated. It generally takes about 12 to 18 months for bone marrow recovery post-radioactive iodine. Extrapolating from patient response to treatment, we're familiar with the ATA guidelines, excellent response, biochemical incomplete, indeterminate and structural. And there's a proposed definition for patients treated with total thyroidectomy without radioactive iodine remnant ablation, and to point out in the excellent treatment group, perhaps utilizing a STIM-TG up to 2 as opposed to 1. In the biochemical incomplete group, perhaps utilizing a basal thyroglobulin above 5 rather than 1 and above, or a STIM above 10. And in the presence of an indeterminate response, perhaps using a 0.2 to 5 basal thyroglobulin or STIM of 2 to 10, slightly different to where patients have had a total thyroid and radioactive iodine treatment. Radioactive iodine therapy for lymph node metastatic recurrence and distant metastasis. There are at least 3 studies, and I've just pulled out 2 here, which indicate that radioactive iodine treatment for patients following reoperation for lymph node metastasis, that there was no difference in terms of structural recurrence-free survival. In the top graph from 2011 and more recently in 2018, p-value of 0.2 and 0.24. Surgery is still preferred for cervical lymph node metastasis, especially if amenable to surgery and bulky disease, with adjuvant RAI only employed if there is residual or metastatic radioactive iodine avid disease present or suspected. And utilization of radioactive iodine therapy for distant metastasis, uptake is required. 1/3 of patients, radioactive iodine treatment is highly effective, particularly in young patients, patients with small metastasis, where there is I131 uptake and well-differentiated malignancy. Refractory disease, unfortunately, in up to 2/3 of patients with distant metastasis, typically older patients with larger metastasis with positive FDG uptake and poorly differentiated tumor. Patients with radioactive iodine uptake, particularly if they obtain negative imaging study on follow-up, tend to do the best compared to those patients with distant metastasis with no radioactive iodine uptake. Pulmonary metastasis, particularly micrometastasis, defined as less than 2 millimeter, generally not seen on anatomical imaging. These patients generally have radioiodine avid avidity and can do quite well with repeated treatment every 6 to 12 months. Empiric doses can be chosen of 100 to 200 millicuries or 100 to 150 for patients over 70 to minimize whole body retention and radiation exposure to marrow. And in terms of macronodular metastasis, we can give repeated doses of radioactive iodine, but we would be guided by objective benefit on the basis of a reduction in the size of the lesions on cross-sectional imaging, decreasing thyroid globulin, but unfortunately in this group of patients compared to micrometastasis, remission is not common and survival remains poor, and that also applies to bone metastasis. What to do in the context of an elevated thyroid globulin with negative imaging? Empiric RAI of 100 to 200 millicuries is typically not routinely recommended. It may, however, aid in disease localization in up to 50% of patients and as therapy for non-surgical disease. Probably most compelling data in this context for pulmonary metastasis. The reason why it's not routinely recommended is because there is no evidence of improved survival. And particularly if the thyroid globulin is less than 10, a watchful waiting approach may be sufficient because thyroid globulin levels may decline without intervention in a significant number of these patients. And just to briefly touch on RAI toxicity, this is typically dose related. We are aware of early and late onset complications, that to do with sialadenitis, dry mouth, dental caries, nasolacrimal duct obstruction and dry eye. There's a lot of recent meta-analyses regarding fertility and AMH levels in women. We know about menstrual irregularities, increased risk of miscarriage out to 12 months post-radioactive iodine, and there's probably a slight increase hematological and salivary malignancy and breast cancer risk with cumulative doses in women. So to summarize, the role of radioactive iodine in patients with DTC is complex and unfortunately hindered by a significant amount of low-quality evidence. The advent of risk stratification has allowed identification of low-risk groups with little to gain from adjuvant therapy and high-risk groups who gain the most. Radioactive iodine should only be given to low to intermediate risk patients who have a significant risk of recurrence based on clinico-pathological prognostic factors and/or post-operative abnormal ultrasound or elevated thyroid globulin. We also know that delayed ablation beyond 6 months in appropriately selected patients does not appear to influence long-term outcome. For radioiodine remnant ablation, there is no difference with respect to short-term ablation success and long-term recurrence-free survival based on preparation with low versus high activity and thyroid hormone withdrawal versus recombinant TSH. And finally, radioactive iodine treatment following reoperation for locoregional neck disease does not appear to improve structural recurrence-free survival. For distant metastases, however, RAI appears to be more effective for younger patients with well-differentiated small radioactive iodine metastasis, particularly in the lung. So happy to take some questions.
Thanks, Dr. Ash. It was a brilliant talk. We have a couple of questions right now. The first one is from Dr. Devendra Chokar. He wants to know, when there is no uptake on a diagnostic scan, do you advocate empiric high-dose scan?
So essentially, well, it depends on the clinical situation. So if we're talking about a diagnostic scan after surgery as part of post-operative disease status, we would have to factor in the thyroid globulin neck ultrasound, patient factors, clinico-pathological factors, and then decide whether or not to give a therapy dose, because there are many instances where the diagnostic scan can be negative, but the post-treatment scan can indicate where disease is. So it depends on multiple factors, but if we're talking about the situation where we have a rising TG with negative structural imaging and maybe even negative diagnostic iodine whole body scan, again, therapy could be offered, particularly with a TG that's above 10 and rising, because we could potentially localize disease in up to 50% of patients on post-therapy scanning. Just keep in mind, though, that the reason why it's not routinely advocated is because of no proven benefit in terms of survival.
Okay, thank you. The next question is by Dr. Joshna. Is there a role of radioiodine therapy in recurrent thyroid bed disease?
Yeah, so thyroid bed disease in its own right, probably not. I mean, with any locoregional recurrence, if there's something that's surgical amenable, that would be the preference. And again, it depends on what size. I mean, we've got thresholds on neck ultrasound with central neck disease, with short axis, etc. I mean, it depends on the rate of doubling time of tissue on neck ultrasound measurements, thyroglobulin, etc. So again, it's not a routine thing that we would do, but it's, you know, if surgery is not amenable and we're concerned about increasing volume of thyroid bed tissue, that could certainly be considered. Or alternatively, if there's concerns regarding the aerodigestive tract, external beam radiotherapy.
Okay, thank you. The next question is by Dr. Ankit. He wants to know what are the indications for delayed ablation?
Yeah, so if you have someone with low to intermediate risk and your initial post-operative disease staging indicates that the person probably doesn't need radioiodine ablation or adjuvant therapy, but as you're tracking that person through and find increasing thyroglobulin or development of neck disease with nodes, then you can certainly offer delayed ablation. And certainly for low to intermediate risk, I mean, there's a couple of papers out that indicate that whether you ablate in the first 6 months or second 6 months, it doesn't seem to have an impact on long-term outcome. I think from Korea, they looked at an intermediate to high risk group and found that ideally the cutoff, rather than being 6 months, should probably be close to 3 months. That it does seem to matter in that slightly higher risk cohort about trying to get some therapy in within the first 3 months versus the second 3 months.
Okay, thank you, Dr. Ash. I think we're done with the questions.
Great.
I think we'll move on to the next topic then.
I'll just
The
stop
next
sharing.
topic is a carryover from last Sunday. Just hold on. Which is on micropapillary thyroid carcinoma versus papillary thyroid microcarcinoma, which will be given by Professor Michael Elliott, who is a highly trained ENT and head and neck surgeon with expertise in thyroid and parathyroid disease management. Over to the Professor Michael.
Thanks so much. I'll just share my screen. I just need to. Okay. Oh, hang on a sec. Okay. All right. Well, thanks very much for the organising committee for giving me the opportunity to give a talk. So the topic that I was allocated was papillary thyroid microcarcinoma, which is an interesting topic because this is the one situation which tends to, in my experience, take longer for the patient's consultation, because as soon as you start mentioning cancer and active surveillance in the same setting, they start to get a bit worried. So we're going to go through some of the background and then just some of the features about management and also about active surveillance. So this is just some Australian incidental data, which is very similar to what the worldwide data shows, that the number of cases of thyroid cancer is exponentially increasing. The death rate, however, is very low. 97% of people are still alive at 5 years after diagnosis. So the definition of a papillary thyroid microcarcinoma is a lesion that is less than or equal to 10 millimeters in size. There's controversy in the literature regarding the optimal management of these tumours because the vast majority of them are considered indolent. However, there are a subset of patients who present with extensive disease both in the regional neck and also with rarely but a distant metastatic disease. So if we break it down into incidental and non-incidental, so incidental papillary thyroid microcarcinoma is a focus of PTMC that is found in patients who are undergoing surgery for benign conditions such as Graves' disease or multinodular goiter, with a reported incidence of around somewhere between 15 to 20%. But it depends on how thoroughly the pathologist slices the thyroid specimen. And it's largely thought to be of very little clinical significance. We published our data a few years ago now, when we looked at our management of incidental and non-incidental papillary thyroid microcarcinomas, and in our cohort, none of the patients who had incidentally discovered papillary thyroid microcarcinoma occurred. So therefore, in our institution, the way we generally manage this is to reassure the patient. However, follow-up is necessary in patients who have had hemithyroidectomies in the setting of nodules on the contralateral lobe. But generally, the vast majority of people can be discharged after total thyroidectomy and incidental discovered papillary thyroid microcarcinoma. So if we look at non-incidental papillary thyroid microcarcinoma, we need to divide it into indolent and potentially aggressive disease. So it's also been described in the literature as low risk or high risk. So patients who have non-incidental papillary thyroid microcarcinoma are those subset of patients that have been diagnosed preoperatively, so Bethesda 6, or have suspicious features on their ultrasound, and or have a preoperative FNA Bethesda 3 to 5. We all know that there's an increased detection of these tumours because there's common usage with ultrasound, CT scan, MRI scans, and PET CT scanning. And we really need to distinguish those patients who have got an indolent disease and those patients who have got potentially aggressive disease. And these are the patients who will present with bulky central or lateral neck disease and can present with distant metastatic disease. So this is one of my patients from a few years ago, but a 58-year-old male who presents with an 8-week history of a right-sided neck mass. The ultrasound demonstrated a 3.3 centimetre level 4 swelling with 3 other smaller adjacent cystic lymph nodes. High resolution ultrasound of the thyroid did not demonstrate a primary lesion. An FNA of the lateral neck cystic mass demonstrated scanty epithelial cells, but the TG level was 193,000. Patient went on to have a total thyroidectomy, central and lateral neck dissection, and the pathologist, after multiple serial slicing of the thyroid, eventually found a 0.5 millimeter papillary thyroid microcarcinoma in the right lobe with evidence of extensive lymphovascular invasion. And this patient had 16 out of 63 lymph nodes were positive for metastatic PTC. So this is clearly not a patient who has got indolent low-risk disease. The management guidelines have changed. In 2009, the ATA guidelines essentially advocated for a lobectomy for low-risk unifocal intrathyroidal papillary thyroid carcinomas in the absence of other risk factors. And if we move forward to the next guidelines in 2015, the terminology is now changing. So we're now seeing, if surgery is chosen, patients with small tumours without extrathyroidal extension can be treated with lobectomy unless there's other clear indications to remove the contralateral lobe. So we've gone from an emphasis of surgery to one of, if surgery is performed, active surveillance, and that's what contemporary management is all about. Prophylactic neck dissections for papillary thyroid microcarcinoma have largely been abandoned, even though we all know that if you do a prophylactic neck dissection, it's very common you'll find little microdeposits of papillary thyroid carcinoma. So let's take the scenario that you're going to do an operation. So what information do you need before you decide on the extent of surgery? So you've got to take into consideration patient factors such as their age, their occupation, particularly if they're a professional voice user. You want to know about any family history of thyroid cancer, previous neck irradiation, and you also want to know about the patient's concerns regarding cancer or potential cancer in certain situations. With disease factors that need to be taken into consideration, high resolution ultrasound of the thyroid with assessment of the central and lateral cervical lymph nodes to look for potential regional nodal disease. You need to know if that thyroid tumor has got evidence of extrathyroidal extension or if there's any obvious cervical lymph node metastatic disease. And if you're contemplating doing a lobectomy alone, you want to know, are there any other nodules in the contralateral lobe? Because there's up to a 50% chance of multifocal disease with about a 50% chance of that disease being in either lobes of the thyroid. With respect to surgery, the literature largely supports the disease-based approach. So with a patient who has a solitary cancer with no other nodules, a lobectomy is considered entirely appropriate. In the setting of a solitary cancer, but with nodules in the contralateral lobe, if there's no suspicious nodules in the contralateral lobe, then I think lobectomy is worthwhile discussing with the patient, particularly considering we now have TIRADS classification that gives an assessment as to the suspiciousness of the nodules, or given the fact that there is a high incidence of multifocality, total thyroidectomy can also be done. If there are suspicious nodules in the contralateral lobe, then I would advocate, and the literature advocates, a total thyroidectomy. With respect to neck dissection, if there are no suspicious lymph nodes, either in the preoperative radiological investigations or an intraoperative assessment, then generally no prophylactic neck dissection is advocated. If there are suspicious or confirmed lymph nodes, either with your preoperative fine aspiration or on your preoperative radiology or intraoperative assessment, then a neck dissection is indicated with removal of the involved compartments. So in the central neck, that's level 6, and in the lateral neck, a level 2 to 4, or extended into level 5A. With contemporary management of papillary thyroid microcarcinoma, the Japanese have been pioneering active surveillance. First report in Thyroid of 2003, 70% of tumours in the observation group did not increase in size, or in fact decreased in size. There was a 10% subset of patients in which the tumour did enlarge by 10 millimetres, and only 1% or 1.2% of patients developed lateral neck disease. In the same group, in their follow-up paper in World Journal of Surgery in 2010, reporting 340 patients undergoing active surveillance, a growth rate of greater than 3 millimetres was seen in 6.4% at 5 years and 15.9% at 10 years, with a development of nodal disease of 1.4% at 5 years and 3.4% at 10 years. However, approximately a third of the patients in the observation group eventually underwent surgery for a variety of reasons, such as not willing to continue to participate in active surveillance programs. The Memorial Sloan Kettering Cancer Center and the Kuma Hospital in Japan developed a clinical framework to enable clinicians to consider the factors that are important for considering active surveillance. And those important factors involve the tumor and the neck ultrasound characteristics, patient characteristics, and the medical team characteristics. So with the tumor and the neck ultrasound, you want to know about the size of the primary tumor. You need to know about its location within the thyroid gland. Patient characteristics that are important include age, other medical comorbidities, and the patient's willingness to accept observation. The medical team characteristics involve factors such as availability and experience of a multidisciplinary team. The patients were then allocated into ideal, appropriate, and non-appropriate candidates. So if we look just at the tumor factor component, an ideal candidate for active surveillance would be a patient who had a solitary thyroid nodule with well-defined margins, surrounded by at least 2 millimeters of normal thyroid tissue, without any evidence of extrathyroidal extension, and with no clinical, regional, or metastatic disease. Active surveillance is still considered appropriate in a patient who has multifocal papillary thyroid microcarcinoma, a subcapsular location, but not adjacent to the recurrent laryngeal nerve and not associated with evidence of extrathyroidal extension, with ill-defined margins, background ultrasound findings that may make it difficult for follow-up, such as thyroiditis, and FDG avid papillary microcarcinomas may still be appropriate for active surveillance. However, patients are not considered appropriate for active surveillance if they have evidence of aggressive cytology on their FNA, if the tumor is located adjacent to the recurrent laryngeal nerve, if there's evidence of extrathyroidal extension, clinical evidence of invasion of the recurrent laryngeal or trachea, which is rare, if there's any evidence of regional nodal disease or metastatic disease, or if there's a documented increase in size of greater than 3 millimeters in the tumor, then that patient is not considered appropriate for active surveillance anymore. So in summary, papillary thyroid microcarcinoma, commonly found cancer in the setting of surgery for benign thyroid conditions, largely completely and utterly indolent, and patient can be reassured and discharged. With non-incidental papillary thyroid microcarcinoma, you need to define those patients into low risk and high risk. Base your decision making on whether you go into an active surveillance program based on the factors discussed. And if you're going to do surgery, consider lobectomy or total thyroidectomy and neck dissection only for identifiable structural disease and only involving those compartments in which the disease is present. Okay, thank you for that. I'll take any questions.
Thank you, Professor Adit. We have a couple of questions here. One is from Dr. Mayuri. She wants to know, in a case of micropapillary thyroid carcinoma with involvement of lateral compartment nodal disease with contralateral subcentimetric compartment disease versus just give me a minute. Okay. Can I go again?
Sure.
In a case of micropapillary disease where there is a bulky lateral compartment nodal disease, however, the contralateral has subcentimetric disease, which is between low to moderate suspicion and ultrasound. So in such a clinical scenario, what would you recommend? Would you, she wants to know whether you would get an FNAC versus frozen, or would you do a prophylactic neck dissection on the contralateral side?
Okay, I mean, so I think like with high resolution ultrasound, you can get a very confident idea about whether lymph nodes are involved with metastatic disease. I think I would advocate against doing a prophylactic contralateral neck dissection. I think you need to have FNA documented evidence of disease in that neck before you go into it. And I think that with the high resolution ultrasound these days, you can be fairly confident that if that node looks like a normal lymph node, even if it is a slightly bulky, greater than 1 centimeter, then I would advocate leaving it alone. But certainly FNA confirmation, TG assay before considering operating the contralateral neck.
Okay, thank you. There's another question by Dr. Mohan. How do you manage incidentally detected PET-avid subcentimetric thyroid nodules?
Yeah, so this is increasingly common because of PET-CT being used for cancer management. So it basically, I mean, the risk of cancer in a PET-avid nodule is about 30%. That patient would go down the same investigation strategy, so high resolution ultrasound and FNA biopsy of the nodule. And certainly I would advocate surgery only in the setting of indeterminate Bethesda 3 to 6 and abnormal ultrasound findings. Certainly, I would not advocate surgery purely based on the fact that they may have a PET-avid nodule. It needs further investigation with an ultrasound and FNA.
Okay, thank you, Professor. I think we're done with questions with regard to micropapillary carcinoma. Is Dr. Ash here? Hello.
I'm still here, yes.
Yeah, I'm sorry we missed out 2 questions which came in late for radioiodine ablation. Can we go ahead with them if you're okay?
Yeah, that's fine.
Okay, one of them is what is the time gap between 2 radioiodine ablation treatments?
So if follow-up treatment's required, generally they say 12 months, but if required, you can give a second dose after 6 months. The main concern is in relation to bone marrow, but bone marrow recovery, we typically see over that 12 to 18 months, but if required, particularly if you've got RAI avid metastasis, and in particular, I guess, lung metastasis, where there's evidence of, response after initial treatment, then you can give it as often as 6 monthly.
Okay, and one more question, which is again from Mayuri ma'am. She wants to know what is your preferred management strategy for subcentimetric nodal disease versus subcentimetric thyroid disease? Whether surveillance versus radioiodine therapy.
Oh yeah, she did message me privately and I did say surveillance.
Okay, yeah, thank you. I think we're done with the questions now. We can move on to the next topic. Is Professor Robinson here? Hello.
I think he had some problem logging in.
Okay.
So we'll just wait. We'll go ahead with the next talk and then come back when he is able to join in.
Okay, fine. So the next topic will be moving on to management guidelines in medullary thyroid carcinoma, which will be given by Dr. Hubert Lau, who has special expertise in microvascular head and neck reconstruction and management of facial nerve disorders. He is also in charge of the largest clinical pathological head and neck database in the Southern Hemisphere. I think Dr. Hubert is one of the brilliant minds I've ever met in head and neck, and I was privileged to work with him for a couple of projects. It's great to have you here, Dr. Hubert.
Well, thank you very much for the introduction, Trudy.
Yeah.
I'd like to thank the organizer for inviting me to do this talk. Now, can I share my screen? Can you see my screen, Trudy?
Yeah, we can.
Yep. Okay. So the topic I was given is to give a summary of medullary thyroid cancer. And I've noticed that Bruce Robinson is going to be in the panel. So Bruce actually is a co-author in that ATA 2015. So it'd be good to have him on the panel for some of the questions. So I'm just going to move on. The way I sort of basically revamp the guideline into a few sections, and that would probably be a little bit more a surgically relevant talk. So I want to talk a little bit about medullary thyroid cancer and a little bit on the RET mutation and the risk category, because that had changed between the 2009 and 2015 guideline. And for us, most of this tumor will present as a thyroid nodule. And how do we work this patient out? And occasionally we'll be sent patient with a known history of RET mutation, and how do we manage this group of patient? And lastly, after we've done surgery on this group of patient, what do we need to do? And one thing to note that the management of medullary thyroid cancer, just like any other cancer, has to be multidisciplinary. So just a little bit about the medullary thyroid cancer. It's the third sort of more common thyroid cancer. So it's about 3 to 5%. It is a neuroendocrine sort of tumor, so it's very different to a differentiated thyroid cancer. And it's come from the parafollicular C cell, which is located in the upper 1/3, lower 2/3. So if you find C cell outside those areas, they are abnormal. And when you treat this sort of tumor, we know that about 75 to 80% are sporadic. Sporadic means that it's a somatic mutation, and about 20 to 25% are familial. So they're germline mutation. These are inheritable, whereas the somatic are not inheritable. And the mutations are slightly different. In the sporadic group, they are more sort of that tyrosine kinase family type of mutation, whereas in the germline group, they are mainly the RET mutation, which is located in chromosome number 10. And that will lead to some sort of the MEN syndrome, which we're all sort of familiar with. So looking at these two groups, most of the time, if you look at the sporadic group, they tend to present a little bit later in the 40 to 60 age group, whereas the one with the MEN syndrome, because of the ability to detect the RET mutation, they tend to be a lot younger. Now, all the familial type generally have multifocal disease, whereas the sporadic type only about 1/3 will have multifocal disease. And almost all the familial type have got C cell hyperplasia. So you find C cell outside that traditional location. They're all throughout the thyroid gland. So one of the questions that we normally ask the registrar is, how bad is medullary thyroid cancer? And we generally get a response like, this is a very bad cancer. So about 10 years ago, when I was in the North Shore group, working in North Shore group, we look at the series of about 94 patients with the medullary thyroid cancer. The medullary thyroid cancers are slightly slower growing disease, and they have actually pretty reasonably good prognosis. So in this cohort, we have 94 patients, and their 5-year overall survival is 87%, and their 10 years overall survival is 75%. Now, in the first glance, you'll notice that we split them into the sporadic group, which is that dotted yellow line, and then the blue and the hereditary group, which is the blue line. The other way around. So the first glance, what you'll notice is that the hereditary group, the familial group, seems to have done a lot better. But if you look at look at the group of patients, what you notice is that a lot of the sporadic group, they should present later with a higher calcitonin level. They got higher size disease, lots more lymphovascular disease, and lots more nodal metastasis. So when we do the multivariable analysis, that actually is not a determining factor for survival. What is more interesting is that if you look at this table in the bottom, there's a misprint here. This is meant to be 93%. If you look at this, so if it is an index case of the familial group, they tend to present almost similar to that sporadic group, where they tend to have a much bigger disease, much more lymphovascular involvement, and much more sort of lymphatic involvement. However, if you have the strain familial, so family that got diagnosed with a RET mutation, and then you strain the family, you tend to be able to pick up the smaller type of disease, and therefore they actually do a lot better from the survival and outcome point of view. So treat them early, screen them early. Now, this is a slide that I borrowed from UpToDate. I know it's not ATA guideline, but I thought it will give us a bit of idea about what this familial group is like. So this is RET tyrosine kinase. It's and it's basically a transmembrane receptor. And then in this disease, you know that they can exist as an MEN2A, MEN2B of familial FMTC group. Most of the mutation in these are in exon 10 and 11, and then they're responsible for about 90% of the MEN mutation. And then there is also the intracellular component mutation, which is in exon 16, and that's responsible about 5% of all the mutation. So just a little bit, one slide on that the familial type. Nowadays, when we manage the familial type, we do need to know what codon mutation they have, because the codon mutation determine the risk for their medullary thyroid cancer and how we need to manage them. So largely the ATA guideline divided to MEN2A and MEN2B. But a lot of text and a lot of particles still have this FMTC. In the ATA group, they put the FMTC under the MEN2A. But I find that having the FMTC group is actually a little bit clearer to look at what they are. So in the FMTC group, it's just purely a familial inheritable medullary thyroid cancer group with really no other endocrinopathy. Whereas if you have the MEN2A, they have the risk of the pheochromocytoma and also parathyroid disease. The MEN2B do have a lot of other nerve-related problems. Now, this is where the nomenclature changed a little bit. In the risk category, in ATA 2009, this is called the high risk, this is called the higher risk, and the last one is called the highest risk. In the ATA 2015, they dropped that. So they called it the moderate risk group, the high risk group, and the highest risk group. And the reason for that is that you treat each of these groups slightly differently, and we're going to go into that a little bit. So that sort of gives you a bit of outline about what the medullary thyroid cancer and the risk category. What we commonly see as surgeon and also as endocrinologists is patients that presented with thyroid nodule, and there's a suspicion that this could be medullary thyroid cancer. So this is a flow chart from the ATA. I find it hard to follow, so I changed it to this flow chart. So what you can see is that a lot of times we are referred with a patient with a nodule, and the FNA is suggested of medullary thyroid cancer. One thing to note is that the accuracy of FNA to diagnose medullary thyroid cancer is not that good. And the ATA do advocate that if there's any suspicion of that or some sort of abnormality in that FNA, you ask for a calcitonin washout. I'm going to use the CTN as a short form for calcitonin. That is a terminology that's used in the ATA guideline. And consider using immunohistochemistry on the spin cell to determine the type of cytology. Once you confirm, or once you sort of reasonably suspicious of the medullary thyroid cancer, you do need to do a few other things. So a good thyroid ultrasound to look at the thyroid and neck ultrasound, central neck and lateral neck. We need to also do a serum calcitonin and CA level, and all patients need to be referred for a rare germline mutation. Now, if they are germline mutation negative and they've got very, very little, very low level of calcitonin, then they are subjected for surgical treatment. So this is total thyroidectomy with some form of neck dissection, which we're going to discuss a bit later. Now, if they are RAT positive, if they are RAT positive, then we do need to investigate for parathyroid disease and pheochromocytoma. And the recommendation is to check for the PDH and calcium level, triple phase CT for the liver, and also CT, chest, abdomen, pelvic. They do not recommend a PET CT or Doppler PET scan. Now, in either way of the sort of mutation analysis, if your calcitonin level is more than 500, it is very suggestive of a regional or systemic disease. So you do need to look for your systemic disease. And one of the things is that the ATA use picogram per mil. In Australia, our nomenclature here is nanogram per liter, but the numbers still apply the same. So when you convert them, I think we need to be very careful when, depending on which country you are and what your lab spit out, what sort of numbers, and do your conversion appropriately. So just a little bit on that sort of a little bit more on medullary thyroid cancer. So even if you suspect that this is a sporadic type medullary thyroid cancer, you should subject them for germline mutation because in the studies, about 7% of what looks like clinically a sporadic type mutation do have a germline mutation. And we mentioned before that the ATA put the FMTC under MEN2A. So they actually classify the MEN2A into 4 groups. One is the classical MEN2A, which also has a risk for pheochromocytoma or parathyroid disease. There is the MEN2A with cutaneous disease, MEN2A with Hirschsprung disease, and generally this group, you'll pick them up early stage as a baby because of the Hirschsprung and constipation. And there's a majority of these patients FMTC. The MEN2B group is a very small group of the germline mutation. They generally present with more aggressive medullary thyroid cancer in the earlier stage of the child and also with nodal metastasis. So when I was preparing this talk, there are a few things just away from the ATA guideline to look at, is there any other reason in Australia that we have, is this RAT mutation funded, and what are the indications for us to send for a RAT mutation? So in Australia, and when I look at the worldwide literature, the guideline pretty much the same. Anyone with a diagnosed medullary thyroid cancer are funded to have a RAT mutation. Anyone with a family history of RAT mutation should also funded for a RAT mutation analysis. Patient with a MEN suspicion or MEN2A, and which means the family history with one of the other features of MEN2A, they are funded for that. Patient MEN2B also funded for this RAT mutation, and patient with paraganglioma or pheochromocytoma or the cutaneous disease of amyloidosis, they're also funded for that. Now, the yield for them are variable depending on the indication. So if you have medullary thyroid cancer, we know that 75% are sporadic. So the yield for familial is between about 25 to 30%. If you have a family members with that, then because it's autosomal dominant, it's between 25 to 50% yield. If you have the clinical suspicion, then the yield is very, very strong compared to just pheochromocytoma or paraganglioma. Now, how do we determine the extent of disease? One thing to know is that medullary thyroid cancer has a propensity for nodal involvement. So in most patients, in most series, about 50% of the patient has got nodal disease. Now, this nodal disease is not determined by the size of the primary tumor. The more node you have in the central neck, the more node you will have in the lateral and contralateral neck. And what is more important is that the calcitonin level does give you some indication of your risk for nodal disease. So if you have a very, very low level of calcitonin, that is really the risk of the nodal disease is very small. Between 2 and 200 is the risk to the ipsilateral central neck and ipsilateral lateral neck. If you had it more than 200, then you have to consider the contralateral neck disease, and more than 500 mediastinal lymph node and distal disease. So calcitonin level is important in making in this surgical decision making. Calcitonin is also elevated in a younger patient and also in other disease such as autoimmune thyroiditis and renal failure. And to differentiate that, you can use a calcium stimulation or pentogastric stimulation, and most of these patients do not have a positive response, whereas the one that's due to medullary thyroid cancer has a positive response. CEA will give you an indication of the burden of disease, but it's really hard to use a cutoff to guide you with the surgical management, because a lot of other disease do result in the elevated CEA. But it's something that you will measure because it gives you a risk, an indication of what's the risk of burden of disease, either in the regional sense or in the distant sense. So the ATA recommendation on number 24 to 26, it says that if you got the medullary thyroid cancer and on a good ultrasound, there is no disease and you have a non-detectable calcitonin, the recommendation is a total thyroidectomy and central neck dissection. Now, if you have a medullary thyroid cancer and on an ultrasound, you do not see any structural disease, but you do see an elevated calcitonin, and the elevation is under 200, then you think about a total thyroidectomy central and ipsilateral neck. If your calcitonin level is more than 200 but less than 500, you will consider a total thyroidectomy and central as well as bilateral lateral neck dissection. So the decision for the extent of disease is both structural, so imaging, and also biochemical, driven by calcitonin. Now, no talk would be complete with AJ without talking about the AJCC staging. The issue with this AJCC staging is that it's just a borrowed staging from the differentiated thyroid cancer, and it's really not as relevant to medullary thyroid cancer. There is no mention of calcitonin level. They still have this N2A, N2B disease, which is lateral, whereas the ATA recommended using the calcitonin as well as number nodal disease to actually risk stratify your patient. So it's just a mention, but I don't think many people will use this. So we talk about now patient with thyroid nodule and the management MTC. What about those patients that present to you with a RET mutation? So this is most of them. The ATA divided into children and adult. Now the language has also changed between 2009 and 2015 guideline. So remember, we had this risk stratification to highest, high, and moderate. So the first one is actually the highest, so MEN2B. So if there's a family history of MEN2B, the recommendation is to offer the child a total thyroidectomy within the first year of life. And the management of the parathyroid will be depending on the surgeon's confidence, and then a routine screen thereafter. Now, if you have the high risk group or MEN2A, the recommendation is the total thyroidectomy before the age of 5. Now, if you have the moderate risk group, the old guideline will say total thyroidectomy before the age of 10. Now, the new guideline has changed. Essentially, they're recommending that we'll measure this calcitonin. If the calcitonin is normal, you do not have to offer this child a total thyroidectomy, but you continue to surveillance this group of patients. So that is the language that changed. And then the recommendation for the total thyroidectomy, if you look at the history of it, is to look at every single mutation and look at the first documented transformation for medullary thyroid cancer in this particular mutation, and also look at the nodal disease. So they basically pick the year before the first documented risk of medullary thyroid cancer. Now, if you look at the adult, so if the case is a screen adult, so they got someone with mutation, and they screen the family, notice that they also carry the red mutation. In the past, you offered total thyroidectomy, but this is now changed as well. So we basically screen them with the calcitonin. If the calcitonin is normal, you actually continue to monitor this the thyroid with ultrasound and ongoing calcitonin. So that is for that group. Now, what about the management of the parathyroid gland? So if you're going to offer someone with total thyroidectomy, what do you do with the parathyroid gland? Now, in the group with the codon mutation 609, 601, 18, 220, and 30, they are the group that has got a higher risk of concurrent parathyroid disease. They also note that they're usually not a very high level parathyroid disease. So the ATA do make a statement, not a strong recommendation, but a statement to say that if you were to do that, consider transplanting the parathyroid gland during the surgery into the brachioradialis, so that you don't render this patient hypoparathyroidism. Yet if they form problem with the hypoparathyroidism, it's not a difficult disease to go back. Now, I just want to draw the attention to another technique that I'm not saying that this is more surgical group, which is a spare technique, which is a technique that can be applied for a renal hyperparathyroidism. So instead of leaving your parathyroid within the thyroid bed, you translocate that into the strap muscle. So this is the strap muscles. Essentially, you translocate it with a vesicular pedicle into the midline strap muscle. So if this patient subsequently develop a hyperparathyroidism, the exploration for the hyperparathyroidism is not going to risk your recurrent ligation nerve. It's something to think about. I certainly don't have experience in this group of patients, but I've done it for a renal hyperparathyroidism. So the last section we're going to cover is what happened after we offer this patient a surgery. So the ATA has got some recommendation for external beam radiotherapy. These are offered for patients with high risk or local recurrence. So they have either microscopic or macroscopic residual medullary thyroid cancer, cancer with extrathyroidal extension, or very extensive nodal metastasis, or on the palliative side, there's a risk for airway obstruction. Now, after the total thyroidectomy, the recommendation is that they follow this group of patients with regular ultrasound, thyroid function 10, calcitonin level, and also CEA. Your first calcitonin check is at 3 months, and thereafter 6 months, and then 12 months. So if it is non-detectable, 6 months, and then yearly thereafter, non-stop for the rest of the patient's life. If it is less than 150, now the risk of metastatic disease is going to be very low here. So essentially, what the recommendation is that we basically surveillance the neck region. So they're mainly a regional disease. So you surveillance them, and you look and also treat for a local or recurrent disease. Now, if the calcitonin level is more than 150, then you do need to look for a distant metastasis. And so the investigation will include a neck ultrasound, a chest ectopelvic CT, a triple phase CT of the liver, and they also suggested a bone scintigraphy or MRI of the exoskeleton to look for distant disease. So just to complete the other recommendation, which I just saw that Bruce Robinson had joined, so he's probably in a better position to talk to you about this. in recommendation 53, they basically recommend that systemic disease shouldn't be administered to the patient who, even though they got elevated calcitonin, but you do not have a documented structural disease, you don't offer that. Or if the W time is very, very low, you can continue to monitor this group of patients, only offer them if they're symptomatic. And then if patient has got a persistent elevated calcitonin after total thyroidectomy plus minus neck dissection, and you can't find a structural disease, you should actually evaluate the liver with laparoscopically or open with a biopsy to exclude an occult metastasis disease. The option of systemic disease traditionally is chemotherapy, but the response rate is poor. But lately, there's a lot of trial on TKI, and the two that they sort of discuss in ATA is venetoclax and cabozantinib. But if you look at a lot of the review paper, there's a lot more at the market, and in terms of some of the review paper, did the TKI become now the first line, and then all the other TKI are second line now. So that would conclude my sort of summary on the ATA guideline. And thank you very much for the invitation.
Thank you, Dr. Hubert. A couple of questions here for you. Dr. Mayuri wants to know what are the indications for adjuvant radiotherapy in medullary thyroid carcinoma?
Look, the role of adjuvant radiotherapy is really not as well defined for risk reduction. It's not like oral cancer where there's actually a defined role into that. So if you've got a high risk of recurrent disease, then you offer them. You obviously will discuss that in a multidisciplinary clinic, and the pros and cons of the radiotherapy will be discussed with the patient.
Okay.
Can I just add, Hubert?
Hi, Bruce. How are you?
Well, how are you? I mean,
very good. I'm very humble to have to give this talk, given that you're the author of the ATA guideline.
So I just make a point about radiotherapy. I think it has a fairly limited role in this disease. The problem with irradiating the neck is that it really makes it, as you would know, very difficult to do subsequent surgery. And I often think that it's better for patients to have repeated operations on their neck than it is to have radiotherapy, which is associated with quite a lot of morbidity, with I think very little evidence of any gain. There's really not much in the literature to support it. And I think, well, we're actually just working on the ATA guidelines now, and I think you might find that that guideline from 2015 will change, Hubert.
Thank you.
Thank you. The next question is, in a recurrent locoregional medullary thyroid carcinoma, would you decide on a morbid surgery versus radiation therapy?
I think Bruce has covered that. If the medullary thyroid cancer as it stands at the moment is probably a surgical disease. Now there's a role of TKI that sort of might change that decision making a little bit, and that decision will have to make depending on your access to that. But it's largely a surgical disease. If you think that you are able to offer a patient a surgery that they can remove the disease without too much morbidity, that would probably the way to go.
I absolutely agree.
Okay, thank you. There's another question by Talker, sir. Is there any indication for hemithyroidectomy in medullary thyroid carcinoma?
Probably not. I think that unless there is a lot better adjuvant treatment for this disease, you probably want to offer them a total thyroidectomy rather than hemithyroidectomy. You don't have backup for that.
Okay. And then I'm probably combining two questions here. In India, there is, we do not often have mutation information, and most of them cannot afford that kind of studies here. So in this scenario, what is the role and how do we recommend prophylactic? Where does prophylactic thyroidectomy in these cases stand? And how do we manage parathyroid glands during surgery for MTC when there is no information on mutations?
That'll be hard. Almost like going back to the dark ages. So the BRAF mutation is not available in Australia until 1993. Before that, if you look at that group of patients, so Bruce, I did present the work I did when I was in North Shore on that 94 patient of MTC. So before that, a lot of the patient were diagnosed based on clinical suspicion, and we grouped them as hereditary because there's a good patient, there's good history to suggest that they are hereditary. Bruce, you then subsequently went back and offered a lot of these patients a RAP mutation analysis, and we were able to then get a bit of sense of where these mutations are. I don't know if I know how to advise if you do not have a codon mutation on how to offer prophylactic surgery, because your risk is so variable. But I would monitor your calcitonin and CEA very closely. Bruce, do you have an opinion on that?
Yeah, look, I suppose I do an ultrasound as well, Hubert, but bearing in mind, of course, you're going to find a lot of completely incidental nodules when you do that. So measurement of calcitonin and a neck ultrasound, I think, would be the two things that I would do if I didn't have RET analysis. And the other thing, of course, you can do is a pentagastrin stimulation test. You still can get pentagastrin, I'm told. We haven't used it for years, actually, but I am told you can get it from ICI, actually, in the UK. But it's not a very pleasant test. If you've ever done them, it's not a very pleasant test to do.
Keep in mind that a lot of the prophylactic thyroid surgery are for very young kids. So it's going to be very hard to have all this repeated investigation for this group of patients. But nevertheless, if you do not have a mutation analysis, I think you'll kind of have to bound to do that.
And the other point to make too is that the patients with MEN2B are usually phenotypically very obvious. And so if you couldn't do codon 918 analysis, then frankly, you wouldn't worry too much about it, because if you had an MEN2B phenotype in a child, you would just proceed to do that prophylactic thyroidectomy in the first 12 months.
Okay.
In fact, I've seen families in Vietnam where exactly that has been done. They haven't had RET analysis available, but on the basis of a phenotype, they've done a prophylactic thyroidectomy.
Okay, thank you. The next question is by Dr. Chalker again. He wants to know what is the indication of using TKIs in MTCs. Do you do it at the detection of metastatic disease, or do you wait for progression?
Bruce, this might be a question for you.
That's the next talk.
Okay. Yeah. Okay. I think that will be all. I think we'll move on to the next topic. The next topic is, just 1 minute. The next topic is by Professor Bruce Robinson, whose next topic is on targeted therapy and potential for TSH receptor targeted therapy in thyroid cancers. He is an endocrinologist who has special focus research on cancer genetics. And he is also a clinical lead of cancer genetics at various hospitals, and has been instrumental in forming international consortium of families to study medullary thyroid carcinoma. Over to you, Professor Robinson. Do I still share your PPT, your presentation?
Yeah, if you can share the slides, please, that would be great.
Is this seen?
Not yet.
Okay, just 1 minute.
Terrific. Okay, so thank you very much for the opportunity to speak with you this afternoon and hopefully help you understand some of the advances in thyroid cancer management. Just by way of disclosures, I have worked as a consultant for both ASI and Loxo, which has now been purchased and incorporated into Eli Lilly. So next slide, please. Next one. All right, so what I wanted to do in the talk today is just outline the survival data on in patients who have advanced thyroid cancer and the role of radioactive iodine, talk to you a little bit about some of the multi-tyrosine kinase inhibitors, and then more specifically, one of the new RET tyrosine kinase inhibitors, and then finish up on with discussion of some of the additional genetic targets that we now look to look after our patients, and I'll finally spend a couple of minutes just on currently active clinical trials. Next slide, please. So this slide really shows you that survival in patients with advanced differentiated thyroid cancer is not very good. If patients are radioactive iodine responsive, then the 10-year survival is 92%. But if they become refractory to radioactive iodine, and that occurs in about a third of patients, the 10-year survival drops to only 10%. And so this is a group of patients that we're beginning to recognize are potentially able to be saved or have their lives extended with tyrosine kinase inhibitor therapy. Next slide. So the first thing that we have to be clear about here is radioactive iodine refractory disease. And it is also very clear that there is no benefit from giving additional radioactive iodine to patients who have radioactive iodine refractory disease. There was one study from Italy back in the 1980s to suggest that there was potentially a very small benefit from adding a final dose of radioactive iodine, but by and large, giving extra iodine to people who don't take it up is not going to achieve anything. So the ATA has then defined this group of people as a group of people who don't concentrate radioactive iodine, as a group of people whose tumor tissue loses the ability to concentrate radioactive iodine, having previously done that. And in fact, we see in some patients now almost two clones of cells developing. So some of their tumor metastatic deposits do concentrate radioactive iodine and others do not. And that's the third group. And then the final radioactive iodine refractory group are people whose metastatic disease progresses despite the fact it still concentrates some radioactive iodine. All of those groups are now called radioactive iodine refractory. Next slide, please. So the advent of tyrosine kinase inhibitor therapy was very important because it's changed the landscape. And the number of these are listed on this slide here, these different drugs, lenvatinib, sorafenib, cabozantinib, and vandetanib. These are all drugs which can inhibit multiple kinases. They have anti-angiogenic effects. They act at the VEGF receptor, at the FGF receptor, and also at the RET receptor. And in doing so, they inhibit the second messenger pathways that are shown on this slide, either the RAS-RAF-MEK-ERK pathway or RAS signaling through PI3 kinase to mTOR. So both of these pathways can be inhibited to varying extents by this group of drugs. And this accounts for the fact that they are variably effective in different patients, depending upon the level of expression of each of these particular receptor subtypes. Next slide. So the first really important study of a tyrosine kinase inhibitor in patients with radioactive iodine refractory thyroid cancer was the SELECT study that was led by Martin Schlumberger and published in the New England Journal back in 2015. Now, because the trials of these drugs, in this case lenvatinib versus placebo, involve a crossover study design, so what that means is that after patients have been in the study for 3 months, it's possible to decide whether you think they're still progressing, and if they are still progressing and it appears that they're receiving placebo treatment, then they're able to be crossed over to active drug. Now, that type of study design means that progression-free survival is really all that can be accurately measured. You can't measure overall survival. Now, in this first study of lenvatinib versus placebo, you can see that the progression-free survival in the placebo treated group was only 3.6 months, and the progression-free survival in the lenvatinib treated group was 18.3 months, with an overall response ratio of 65%. So this was a really big step forward. There had been a study previously of sorafenib, which for time's sake I've deleted from this talk. It showed a progression-free survival of 11 months versus an equivalent of about 3 months. So this study of lenvatinib was really the first to demonstrate significant progression-free survival. Next slide. And when we've looked subsequently, and this was published 3 years later in endocrine-related cancer, that progression-free survival difference in the treated group versus placebo group persisted. Next slide. The other thing to note here is that in people who respond to this drug, lenvatinib, prolonged duration of response is seen, and that's shown here in the bottom part of this slide. These people have been shown to have progression-free survival for up to 33 months. And in fact, even since then, we've had patients who've been on this drug for 5 years. I describe this to patients as the drug is a bit like a handbrake on their tumor. So it doesn't make it go away, but it is able to really halt or slow down its rate of progression quite dramatically. Next slide. Now, both of these trials, the SELECT trial with lenvatinib and the DECISION trial with sorafenib, used patients or enrolled patients who were required to have RECIST positive and progressive disease. Now, this is RECIST is a type of staging system that is known to oncologists, but not so much known to endocrinologists or endocrine surgeons. And so the patients to have RECIST progressive disease have to have demonstrated a more than 20% increase in the size of their lesions. Tumor doubling time was not required to get into these studies, but it does help, as Hubert has said before, help with providing you with useful prognostic information. So the big question here, and it was asked in the questions to Hubert, was when do you start these patients? It is really difficult to know. Do you wait, as we did in the trials, until they've got really quite significant progressive disease? Or as we're now beginning to ask ourselves, should we be beginning these drugs earlier rather than later, when the patients have obviously lost condition and are not as well? Next slide. Now, one of the reasons this is an important question is that the side effect profile of these drugs is not trivial. In fact, it's very significant. Many patients, nearly half of all patients in the study, develop hypertension, diarrhea, fatigue, weight loss, nausea, stomatitis, and a condition shown on this slide, the hand-foot syndrome, are all well recognized. The hand-foot syndrome refers to blisters which can occur on the soles of the feet and the palms of the hand, and which can be quite painful, so much so that it's easy to see if a patient is on a high dose of this as they walk into your office, because they are often limping on the way into your office. So we've learned now how to manage some of these side effects. Next slide. And I'll show you that shortly. But just before I do, one of the things that we also now recognize is that these drugs, like lenvatinib, still work quite well in old patients. Initially, it was suggested that old patients don't do well with these drugs, but as the data on this slide shows, when we divide the patients into over 65 and under 65, the over 65-year-old people still have a very good response rate. And so don't deny your patients who are older access to this drug. Next slide. And this is shown here, that the overall survival now as we've been able to look at as this drug has been in longer use, is actually better, ironically, for the patients who are over 65 than it is for the patients who are under 65. Next slide. So just an example here that helps to try to bring home to you who should get these drugs. Well, this first case is a 79-year-old man who has progressive metastatic radioactive iodine refractory disease. Back in June 2015, he had a moderately elevated thyroglobulin level of 115. He'd been under active surveillance since 2010. Next slide. Now in January 2017, you can see that his thyroglobulin has started to increase quite dramatically, and he's now developed shoulder pain. And if you show the next slide, or the next panel, you can see now that on a FDG PET scan, he now has diffuse bony metastases. He's got a metastasis in his right scapula, which was irradiated. He's then subsequently gone on to have radiotherapy to his left chest wall and also to his right femur. So it's pretty obvious that this man needs systemic treatment as well as that radiotherapy. He needs something systemically to try to tackle this radioactive iodine refractory disease. Next slide. So he needs systemic treatment yesterday. So in answer to the tricky question, who to treat and when, we know that lenvatinib now is approved in countries like Australia, the US and Europe for patients with progressive radioactive iodine refractory differentiated thyroid cancer. And we also know that you should not withhold it from patients who've got symptomatic disease, bulky disease, and probably also in the absence of resist measurable disease, people who've got pleural involvement or bony metastases, they may also benefit from treatment with this drug. That's not to say, though, that focal approaches such as surgery, radiation, radiofrequency ablation, and cryoablation also have a very, very important role and should be thought of, I think, even before you start thinking about treatment with a tyrosine kinase inhibitor. Lenvatinib, however, does have activity in bony lesions. This is contrary to what the ATA guidelines state, and this is another one of the guidelines. This is why it's important to regard these as living documents, which state that bony metastases are often poorly responsive to kinase inhibitor therapy. We now know that that is not true. So use this drug carefully in patients with radioactive iodine refractory disease in their bones. Next slide. The other thing that we know in patients who are treated with lenvatinib, and this was work that we published from the SELECT study, was that the change in tumour size over time continues for many, many months. So even though the dramatic fall in tumour size or decrease in tumour size occurs very early on in disease treatment, it can persist for, in this case, out to 88 weeks, people getting small monthly reductions on average in the size of their tumour. Next slide. So the optimal side effect management is important, though, in managing these patients so that you can balance their benefit in terms of tumour control and the quality of life that they're experiencing. Next slide. So one of the things that we've learned about in managing people with these drugs is that adverse events are frequently able to be managed by giving the patients dose holds, that is drug holidays, giving them 4 or 5 days off drug, or by reducing the dose. And in fact, in the SELECT study, dose holds occurred in 82% of patients and dose reductions in 68%. And we know that you can actually withhold drug for possibly a month before there is any compromising effect on progression-free survival in these patients. Next slide. The half-life of lenvatinib is only 28 hours, so it only takes 3 or 4 days and you're able to get it out of their system and then reintroduce it at a lower dose. So hypertension was the most common treatment emergent adverse event. It was quite common and ironically, the development of hypertension was associated with an overall survival benefit. And we think that that's because these patients who develop hypertension are slow metabolizers of lenvatinib. They therefore have high levels. They're prone to get side effects because of those high levels, but because they've got high levels, they also get particularly good control of their tumor. So I tell patients, if they develop hypertension, don't panic, don't worry. This is actually a good thing. Next slide. And the management of the hypertension is fairly straightforward. We either use ACE inhibitors, angiotensin receptor antagonists, or calcium channel blockers. They all work very well in this group of patients. Next slide. This is the palmar-plantar erythrodysesthesia syndrome. You can see the blisters on the toes of this person and also on the hands and the fingers. And again, that's able to be managed by people having appropriate footwear, gel foam inserts, wearing running shoes, and also by using exfoliating foot ointments that contain salicylic acid and urea. These are often very helpful in helping to manage these conditions. Lenvatinib is also a photosensitizer, so it's very important to make sure that people wear long sleeves, sunblock, and that they wear a hat to try to minimize their this particular side effect. Next slide. So the next group of patients I want to talk about are patients who have now had some specific gene mutation detection. Now, in India, I suspect you are able to get BRAF mutation status assessed immunohistochemically in many centers, even if you can't get gene testing done. And so on the basis of BRAF testing now, we decide if a patient is radioactive iodine refractory to give them a combination of either dabrafenib alone or dabrafenib and trametinib. And we do that on the basis of this work that was published by Manisha Shah from Ohio State University in collaboration with colleagues at Mass General, MD Anderson, and those other universities listed there. The next slide shows the waterfall plot. In the right-hand panel here, this is patients treated either in blue with dabrafenib alone or in red with dabrafenib and trametinib, showing quite significant reduction in tumor size if patients have the V600E BRAF mutation, which was present in 94% of the 53 patients in this particular study. So this is now becoming a routine part of the histology of patients who had thyroid cancer at our hospital. We do this at the time of diagnosis to help us decide whether we need to be on the lookout if these people are radioactive iodine refractory. We need to be on the lookout to give them access to these drugs. Next slide. There's also some evidence that dabrafenib and trametinib in patients who have BRAF mutant anaplastic thyroid carcinoma may also, there's not a large number of people in this study, but these people may also show some responses. And you can see here the individual patient responses in the waterfall plot shown on the left. Only one of the patients in that study had progressive disease. All of them had some response to a degree. This often very much depends on the histology of the anaplastic thyroid carcinoma, since we recognize now that these anaplastic thyroid carcinomas generally arise from a pre-existing either papillary or follicular carcinoma, and often the massive tumor will be seen to respond because it might be 80% follicular cancer or Hürthle cell cancer and only 20% anaplastic. And that may be the reason why some of these patients respond to this drug combination, which is generally fairly well tolerated. Next slide. Now, the holy grail in this area now is to try to find therapy which is much more targeted. Because of the role of RET in a number of different sorts of thyroid cancer, not only medullary thyroid carcinoma, which Hubert has just been talking about, where we know that mutations in the RET proto-oncogene can cause constitutive activation of the receptor, as is shown in the middle two panels there, the example being the codon 634 cysteine to arginine mutation, again causing ligand-independent dimerization and activation, or the intracellular, more aggressive codon 918 mutation that's characteristic of people with MEN2B. Again, ligand-independent activation and dimerization can occur in those patients as well. In the final panel there, you can see that we recognize now that RET is involved in a number of fusions with chromosomes in other parts of the genome besides chromosome 10, and that these are particularly common in patients with papillary thyroid carcinoma and very common in patients who've had radiation-associated papillary thyroid carcinoma, particularly around the Chernobyl nuclear reactor accident. And I suspect we will see these types of RET rearrangements also around the Fukushima nuclear reactor accident in Japan. So if RET is involved now, obviously it would be good if we had drugs which are very targeted towards the RET proto-oncogene itself and didn't have off-target activity on other tyrosine kinases, which cause many of the side effects that we are so recognized now to be so frequent in patients who are treated with lenvatinib or sorafenib or any of the other drugs such as pazopanib, matetinib, sunitinib, etc., that was shown on one of those slides of Hubert's. Next slide. So the new focus is on targeting the RET gene particularly, and the first of the drugs, and I won't cover both of these in the interest of time, but the first of these to be identified was LOXO-292. And this drug is very specific for the RET tyrosine kinase, and so is very active in patients with medullary thyroid carcinoma who have RET gene mutations, but can also be used in patients with lung cancer and papillary thyroid cancer who have RET gene rearrangements. And so this drug has been a tremendous boost to us, particularly in looking after patients with medullary thyroid cancer. Next slide. This work was published, actually it was presented here in October at the ATA in 2018, and it was actually just published in the New England Journal with Laurie Wirth as the first author in June this year, if you want to look it up. So the next slide shows, next slide please, shows the waterfall plot here of the patients with RET mutant medullary thyroid carcinoma in the left-hand part of this waterfall plot. And in the right-hand part, the patients with RET fusion positive thyroid cancer. These are papillary thyroid cancers. And again, you can see that either the RET fusion positive PTCs and the MTCs had quite dramatic reductions in tumor response. So the best response was seen in a patient with medullary thyroid carcinoma and another with papillary thyroid carcinoma who had tumor responses of nearly 80% reduction in the size of their tumors. So, and the other thing about this drug is that it's able to cross the blood-brain barrier. So we've even seen intracranial responses in patients with cerebral metastases. And this is something that's not seen in the patients treated with lenvatinib. Next slide. The final group of mutations that I want to talk to you about are the N-track fusions. Again, if you have access to it, understanding these fusions is important because although they're rare in thyroid cancer, if they are present, then patients are able to be treated with a drug called larotrectinib. The TRAC receptors are shown here. They have a role in normal people in nerve regulation, helping us appreciate pain and temperature, and also movement and proprioception. So TRAC is a receptor which is like RET, which is important in normal people, but when it becomes broken and then fuses with another gene in papillary thyroid carcinoma, it can be carcinogenic. Next slide. And this shows you in a basket trial, that's a trial where a lot of different patients with different tumor types are included, and the thyroid patients are the ones in very light green here. they're asterisked, these patients have had responses to larotrectinib, and this is a drug that we do offer patients if we can find that they do have one of these particular types of fusion. Next slide. So if I can conclude, the majority of patients with advanced thyroid cancer, that is either advanced differentiated thyroid cancer, medullary thyroid cancer, or anaplastic thyroid cancer, can be found to harbour actionable mutations. The proof of principle studies are consistently positive for patients with BRAF mutant, NTRK fusions, or RET altered disease. And I think it is time for us to now think about establishing a new paradigm for genotype-phenotype treatment approaches. So don't wait till the patients develop widespread metastatic disease, genotype them, and then try and correlate that genotype with phenotype at the time of diagnosis, and then to try to match up in an individual patient when the best time is to actually start these drugs. As I've indicated to you, the drugs have side effects which are not trivial, and it is important that we don't lose sight of the fact that we are treating patients. We're not treating numbers like calcitonin or thyroglobulin levels. We're treating patients, and ideally, as we become more comfortable treating these patients, we'll find new ways of using these drugs as well. And one of those ways, which I don't have a slide on, which we are just in the process of writing up, is to use a drug such as lenvatinib as neoadjuvant therapy. So pre-surgical therapy to try to partly shrink an anaplastic thyroid carcinoma to turn it from being surgically unresectable to being surgically resectable. Often it takes only 4 to 6 weeks of a treatment with a drug like lenvatinib to enable that to happen. And we've had some quite good success here in Sydney and working with colleagues in Boston in using that drug in this way, and hope to be able to get that into the literature shortly. So the final slide is just my final slide, saying it's time for me to stop, and I'd be happy to take questions. Thank you for listening, and I hope you're all doing well in Bangalore.
Thank you, Professor Robinson. It was an excellent talk. It covered almost all the gray areas in targeted therapy for us. And we have a couple of questions here. I guess we don't have any. Thank you, Professor Robinson. We don't have any questions. I think you covered almost everything for us. Can we move on to the next topic then?
Thank you.
Thank you. The next topic is by Professor Michael Elliott on management of anaplastic thyroid carcinoma. Welcome back.
Thank you. Okay, all right. So thanks again for inviting me to give a talk. So I'm going to provide a summary on anaplastic thyroid cancer. In fact, it's going to cover some of the stuff that Bruce has just mentioned, which is emerging changes in the way that anaplastic thyroid cancer is being managed. So this is generally a miserable disease. It's fortunately very rare, though. It only accounts for 2% of thyroid cancers. It's one of the most aggressive cancers that is known, and it's characterized by rapidly progressive disease. Most patients, in fact, will present with advanced disease that is often inoperable due to invasion in adjacent structures in the neck. 50% will have evidence of metastatic disease at the time of their presentation. Median survival is very poor at only 5 months, and a 1-year survival of about 20%. And hopefully with emerging therapies, these numbers can be improved upon. As Bruce said, it's often seen in association with well-differentiated thyroid cancers and thought to be a de-differentiation process of papillary, particularly the TEL variant, or with follicular conventional or Hürthle cell variant. The staging for anaplastic thyroid carcinoma, they're all stage 4, and it's divided into stage 4A, B, and C. It's important because management decisions are based on this. But stage 4A is T1 to 3A with no gross extrathyroidal extension and no regional metastatic disease or distant metastatic disease, whereas stage 4B can have any T stage, but with the presence of regional disease, but no distant metastatic disease. And stage 4C is characterized by the presence of distant metastatic disease. So clinically, these patients will often present with a rapidly progressing thyroid and or neck mass. They can commonly have voice change due to recurrent laryngeal nerve involvement. Due to the rapid progressing mass, they can present with dysphagia, airway obstruction, and shortness of breath. The examination is focused on local regional assessment. Fiber optic nose endoscopy for vocal cord assessment is standard. The investigations for anaplastic thyroid, high resolution ultrasound of the neck and assessing the lateral neck for evidence of regional metastatic disease. CT scan is routinely performed with intravenous contrast, looking for local extent and invasion into adjacent structures. MRI scan can then be used for better soft tissue detail for defining the extent of involvement of adjacent structures such as the trachea, the esophagus, involvement of major vessels in the area such as the internal jugular vein and the carotid artery, invasion posteriorly into the paraspinal muscles. These patients will routinely have PET CT scanning, looking for evidence of distant metastatic disease. And this is a standard CT scan of a patient who presents with anaplastic thyroid with a very large, impressive mass. With pathology, FNA can be difficult because these patients will often present with a wide variety in their morphology. So typically core biopsy or open biopsy may be required to actually get diagnostic material for proper assessment. And as mentioned, they often have a mixed appearance in their morphology. The most common morphology described is a biphasic spindle and giant cell tumor with the presence of bizarre malignant giant cells, spindle, squamoid cells. There's numerous mitotic figures and atypical mitoses, and extensive necrosis is also classically present, and that can make diagnosis difficult if biopsy of necrotic areas is undertaken. Confirmation of the pathology is aided with immunohistochemistry with pancytokeratin, high molecular weight keratins, TTF1, PAX8, P53 immunohistochemistry staining. And they're important because these tumours being poorly differentiated can look like other types of tumours. So the immunohistochemistry can be important for defining whether this is actually anaplastic thyroid or maybe some other form of metastatic disease or even a high-grade lymphoma. Molecular testing, these tumours characteristically have got mutations in TP53, beta-carotene, BRAF, RAS, PIK3CA, PTEN, and RET PTC3. Interestingly, RET PTC1 and PAX8 PPRA gamma is not classically seen in anaplastic thyroid cancer. There's reported rates of BRAF mutation in 25 to 45% of cases of anaplastic thyroid cancer, and that's important because there are immunotherapy BRAF inhibitors that are now being described for use with anaplastic thyroid cancer. And as Bruce said, these tumours are often dedifferentiated, and interestingly, if you have a high component of a well-differentiated thyroid cancer, you often do better if there's a high component of well-differentiated thyroid cancer compared to the anaplastic component. So if we break down the forms of treatment, surgery, radiotherapy, chemotherapy, and immunotherapy, so we'll discuss surgery first. Complete surgical resection is the most important factor in outcome for these patients, with the aim of achieving local regional control. The difficulty is that there's high rates of presentation of involvement of adjacent structures such as the trachea, esophageal, carotid artery, and that makes surgery extensive and determination of resectability sometimes difficult. These patients will need to be discussed in an MDT setting. You need the input of your surgical colleagues, endocrinologists, radiation therapists to work out a treatment plan for each patient that is likely to help. Resectability needs to be balanced against the experience, judgment, and technical experience of the surgeon. with a focus on the expected morbidity and risk, as these tumours are locally very aggressive. So that depends on the local regional extent of the cancer, whether the patient has got distant metastatic disease. You need to assess for this patient what is going to be the expected and accepted morbidity with undertaking surgery. Surgery should be undertaken with the aim of hopefully achieving an R0 or an R1 resection. As part of the assessment, the patient may require laryngoscopy, bronchoscopy, and esophagoscopy, looking for gross involvement of these structures. As Bruce mentioned, and I'll talk a little bit more, neoadjuvant radiotherapy and chemotherapy has been used with the aim of reducing the tumour size and help aid with resectability. And the best results overall are seen with multi-modality treatment, with surgery, with neoadjuvant or adjuvant radiotherapy, plus or minus chemotherapy. So looking at stage 4A and stage 4B resectable tumours, the initial therapy is surgery with adjuvant radiotherapy and or chemotherapy, and then the patient's response. If they have no evidence of disease, typically they will be observed. Unfortunately, these patients will often present with recurrent or distant metastatic disease. So local recurrence depends, the management depends on what form of treatment they've had. So often they've already had radiotherapy, so that's not an option. Limited people can be offered surgery, and often these patients will go into some sort of palliative or clinical trial with chemotherapy, immunotherapy, or palliative medical therapy, depending on the extent of the disease. With systemic disease, your options are limited, and often these patients will go into some sort of palliative treatment or clinical trial with immunotherapy, chemotherapy as other options. Looking at stage 4 unresectable disease, the difference in this treatment paradigm is we're seeing the emergence of neoadjuvant treatment. So looking at preoperative radiotherapy, chemotherapy, immunotherapy with the aim of reducing tumour size to enable the tumour to be resectable with outcomes similar to the previous slide, so I won't go through them again. But no evidence of disease, local recurrence, and systemic disease with similar treatment options available depending on how the patient presents. With the extent of surgery, essentially patients will have a total thyroidectomy with a central neck dissection. With respect to a lateral neck dissection, so lateral neck dissection is performed for structurally identifiable disease on your preoperative imaging, or may be required as part of an extended procedure if there's invasion into local structures. Generally, the literature does not support a total laryngectomy because of its morbidity and also the high likelihood of residual disease. A very small subset of patients will actually present with an incidental microdeposit of anaplastic thyroid cancer. The extent of the surgery is governed primarily based on the non-anaplastic thyroid component of the tumour. So the patient may in fact have a lobectomy or may have a total thyroidectomy, but that's really based on the non-anaplastic thyroid cancer. And there's lack of evidence for adjuvant treatment in this setting. So radiotherapy can be given in the neoadjuvant or in the adjuvant setting, or can also be given for palliative non-resectable disease. It's often given in combination with chemotherapy. The literature has demonstrated that patients need at least 60 gray of radiotherapy. Doses less than this are associated with poorer response. Usually the radiotherapy is given as soon as the patient has sufficiently recovered from surgery, usually within 2 to 3 weeks. And there's conflicting data on the survival benefit of different radiotherapy regimes, such as hyperfractionation versus standard fractionation. Just looking at one paper published in Head and Neck in this year, looking at adjuvant external beam radiotherapy for surgically resected non-metastatic anaplastic thyroid cancer in a large number of patients, 496 patients, of which 375 underwent adjuvant external beam radiotherapy, and 188 patients also received concurrent chemotherapy. External beam radiotherapy was associated with longer overall survival on both univariate and multivariate analysis, with better results associated with concurrent chemotherapy, with longer overall survival on univariate and multivariate analysis, demonstrating the indication and importance of this treatment. Moving on to chemotherapy and immunotherapy. So chemotherapy, the classes of chemotherapy drugs that have typically been used include the taxanes such as paclitaxel and docetaxel, carboplatin, doxorubicin and cisplatin. They're often given in combination with radiotherapy as previously described. Newer immunotherapy treatment regimes are now available. The immunotherapy agents are often given in combination with different mechanisms of action to improve their overall therapeutic efficacy. There's different classes that have been described, and Bruce presented data on these. There's multi-kinase inhibitors, sorafenib, lenvatinib, etc. There's BRAF inhibitors such as dabrafenib, MEK inhibitors, trametinib, and PD-1 inhibitors such as pembrolizumab, and the list goes on and on. So this is an article that was published in Thyroid in 2019. It basically demonstrated in a small cohort of patients of only 6, the benefit in BRAF mutated anaplastic thyroid carcinoma of giving neoadjuvant dabrafenib and trametinib. 3 patients also received pembrolizumab. In this cohort of patients that were initially surgically unresectable, complete surgical resection was achieved in all patients. There was encouraging overall survival at 6 months of 100% and 1 year of 83%. Local regional control was established at 100% with 2 patients who died of distant metastatic disease. So this is encouraging data using immunotherapy regimes to improve the outcomes of patients with this miserable disease. So what is the future? So there's reported literature on using aurora kinase inhibitors. There's literature reporting the use of nanoparticles, gene therapy using oncolytic viruses. And we may in fact move to a model of personalized care. So these patients may actually be started with standard chemoradiotherapy. The tumor may be cultured with various immunotherapy agents to investigate sensitivities, and then patients may be then administered immunotherapeutic agents based on the results and sensitivities of these cultures. So this is potentially where we're moving towards very personalized care in these patients with anaplastic thyroid cancer. And that was the end of my talk. Thank you very much.
Thank you, Professor Michael Elliott. It was an excellent talk on such a fatal disease. We have a couple of questions here. One of the question is by Dr. Mayuri, who wants to know the sequence of imaging and management when you find papillary thyroid carcinoma with areas of anaplastic disease who has undergone R1 resection.
R1? So you've got evidence of microscopic disease.
Yes.
Yeah, so it means that these patients need to be first of all presented in an MDT setting. So assuming that this patient has had surgery for papillary thyroid cancer with incidental anaplastic thyroid cancer, they need to be imaged again to have a look for evidence of local regional disease. These patients are R1 resection. So I guess that need to be discussed with probably needing to have, if there's no identifiable structural disease remaining, that at least need to be discussed with the plan for radiation therapy plus or minus chemotherapy.
Okay, thank you. The next question is by Dr. Anand, who wants to know, should we consider upfront surgery when resection involves major upper aerodigestive resection, or would you consider neoadjuvant therapy in the form of radiation or chemotherapy, followed by reassessment for resection?
Yeah, challenging. Look, I mean, the reality is that the surgery has to be weighed up against the expected morbidity associated with the the procedure. For very extensive disease with borderline resectability, I think probably the best thing to do is to consider that patient for neoadjuvant treatment to shrink the tumor down and hopefully get the tumor to a resectable stage that is likely to present with a less morbid option for the patient. I think in that situation, that's what I'd be advocating.
Okay, and the next one is a clinical scenario. In a case with papillary thyroid carcinoma with areas of anaplastic areas, would you, for imaging, would you consider radioiodine or PET-CT?
The natural behavior of anaplastic thyroid cancer is that it's not radioactive iodine avid. So, I mean, as opposed to papillary, which radioactive iodine scans is routinely used, in this sort of patient, the disease outcome is going to be determined by the anaplastic thyroid cancer, depending, I guess, on the volume of anaplastic versus papillary thyroid cancer. So in this sort of setting, I would be doing a PET-CT scan in this patient. I mean, they may still be considered, it depends on what sort of proportion of anaplastic to papillary, but they may still be considered for I131 therapy for the papillary components, in which case they'll have a whole body scan anyway. But for staging investigations, I'd be looking at a PET-CT scan first.
Okay, thank you. I think we're done with question, Professor Elliott. Can we move on to the next session then?
Thanks so much for your time.
Yeah. The next topic is a surgical video on a revision of central compartment neck dissection by Professor Carsten Palme, who is Director of Head and Neck Surgery at Chris O'Brien Lifehouse and Clinical Associate Professor in Surgery at Sydney Medical School. Sorry.
Thank you very much. Can you hear me and see my slides?
Yeah, we can hear you well.
Well, that's great. Look, I really want to congratulate Akshay again and Dr. Rao for just a wonderful educational event, and really want to thank all the previous speakers, particularly my colleagues from Australia, for really giving up generously giving up their time and sharing their vast experience. They were excellent talks. My talk is really far more practical, and we're going to really slow down a little bit here. And I've been asked to just talk about revision central neck dissection and really share my approach to this problem. When we look at treatment failure for papillary thyroid carcinoma, we've got to understand a number of definitions. We've got to understand, are we dealing with biochemical recurrence or actual structural recurrence that is evident either clinically or on radiology? We need to understand, are we dealing with persistent disease, that is disease that has been present really the entire time and there's been no period of no evidence of any disease? Or are we dealing with recurrent disease, meaning that there was no evidence of any disease from the original treatment, and now people have turned up with papillary thyroid carcinoma? And when you look at the literature, and certainly Mazzafieri told us in the early 90s, that the recurrence rates are actually quite high. That can be up to 30% in a number of series. And interestingly, most of these recurrences are actually persistent disease rather than true recurrence. And when we look at locoregional recurrence, that varies between about 5 to 10%. And we've seen this slide last Sunday. This is the risk profile for developing structural disease recurrence, and we really can see that tumors with BRAF mutations, increased number of lymph nodes, vascular invasions, their recurrence rates really escalates, and really at the top you've got gross extrathyroidal extension, vascular invasion. Can we mute people, please? Or
no, Professor, they want you to put your PPT on slideshow so that we can visualize it on full screen.
Sorry?
We want you to put your presentation on slideshow so that we can watch it on full screen.
Carsten, you shared the wrong screen.
What am I sharing?
You need to share your presentation. I think you shared just the PowerPoint slides.
Right. Can you see this now?
Yeah, this is good. Thank you.
Can you now see my presentation?
Yeah, this is good.
All right. I'm not sure why that happened. So you have not seen any of my previous slides?
We saw a small picture of it. We didn't see it full screen.
Okay, right. I'm not quite sure what's going on here.
It's
Oh,
fine.
hang on.
That's good, Carsten. It's working now.
So when we have patients with recurrent thyroid cancer, the approach is everything. We need to take a history, and it's very important to understand what was the reason and the extent of the original surgery. It's important to get the operative notes and the pathology. And importantly, we need to understand what's the state of the parathyroids and the recurrent laryngeal nerve. And this really leads on to the examination, where we need to have a good look at the scar, we need to have a understanding of the voice, and clearly perform nasodoscopy. In terms of investigations, it's the parathyroid hormone and the calcium levels that are important, and particularly vitamin D. And a lot of people are vitamin D deficient and therefore require, potential calcium supplementation, including vitamin D. Clearly, thyroglobulin, and in the case of medullary cancer, calcitonin is important. And really, the best way to map the recurrence is with imaging. And when we look at, I'm not sure why this is not going ahead. Sorry, guys, I'm really having a problem here. Sorry. And it's very important to look at the imaging, and really the workhorse is the ultrasound, which is going to help us also potentially facilitate the needle biopsy to histologically verify the recurrence. And you can see an ultrasound. This is the trachea here, and the common carotid artery here on the left-hand side, and this is the actual recurrence, which is really elegantly seen here on the CT scan. And really the workhorse for central neck disease is really the CT scan. And if you're really worried about invasion of upper air digestive tract structures, it's probably important to perform an MRI scan. When we have disease within the central compartment, there are a number of options. One, we can potentially observe or intervene. And really the reason for pursuing intervention really depends on the likelihood of disease progression and the impact that has on the outcome. And importantly, what is the likelihood of it involving critical upper air digestive tract structures, neurovascular morbidity, particularly with respect to the recurrent laryngeal nerve, and in terms of outcome. And we do know that central recurrence generally portends a worse outcome, because what we really want to avoid is the situation here where you've actually got tracheal invasion, which will require tracheal resection. So really, generally, large central node compartments greater than 1 centimeter, those nodes that are showing a growth per year, are really pointing us towards a surgical solution. The options are multiple. I think if we have biochemical disease, the options are quite a little bit more easy. You can either observe or give radioactive iodine. But if there is structural disease within the central compartment, well, generally in experienced hands and high volume centers, surgery is really favored as the initial approach. And as we say, everything depends on patient factors, tumor factors, what was the previous treatment like, the philosophy of the institution, and the individual surgeon's experience. And really, we need to create a risk-benefit and which always has to be met in favor of the patient. So when you're looking at approaching the surgery, you really do need experience and be a high volume surgeon. You know, we need to have a number of things such as loops and lighting. I think it is absolutely vital to have a trained assistant. And I think nerve monitoring, although not so much standard of care, but really, certainly in my hands, has become a standard whenever I perform thyroid surgery. I think you should definitely have the imaging available in the operating theatre. And where there is a concern about invasion of the upper airway, it's always very important to perform bronchoscopy to have a look internally and look for neovascularization and possible evidence of invasion. And you really need to practice a meticulous technique with a systematic approach in order to get a good outcome. And there is nothing like knowing your boundaries and the anatomy of the central compartment. And as you can see here, there's a lot of very important real estate within that area. And the boundary of the central compartment really extends from the hyoid superiorly to the innominate artery, because I think we should include the superior mediastinum within the central compartment, and from one carotid to the next. When you're approaching this surgery, the incisions that I favor is generally reopening the old incision, which you generally need to sometimes perform a little bit wider in order to really get down low and get down high. And if you need to also perform lateral neck dissection, this can be easily extended laterally and then move superiorly behind the sternocleidomastoid muscle, which is actually a very good incision for accessing all the levels of the neck and highly cosmetic. When you're approaching the central compartment, you really need to approach it in a systematic way. And really, the first thing that I look for once we've opened the neck is to look at the cricoid superiorly, define the midline with the trachea as far inferiorly into the mediastinum as possible. And I often at that particular point like to also see the innominate artery straight away to identify the inferior limit of my dissection. Then we need to, often the sternothyroid muscle has been preserved. So the plane between the sternohyoid and sternothyroid is often unaffected and easily explored. And I like to just extend it right lateral to the carotid sheath, as you can see here, and start identifying the vagus nerve early, because this is going to be a very important structure for checking the neural integrity of the vagus and recurrent laryngeal nerve during the dissection. I think it is very important then to define the lateral boundaries of the carotid of the central neck, and generally that is trying to find the carotid arteries on either side. Inferiorly here on the right hand side, you can see the innominate artery and the common carotid on the right, and on the left hand side you can see the common carotid on the left and the brachiocephalic trunk. So this pretty well outlines your area of dissection when performing this surgery. And you really don't want to delve into the contents of the central neck until you have defined those boundaries clearly. The contents of the central neck, and here I've shown this on the right-hand side, are clearly the recurrent laryngeal nerve, the parathyroid glands, the inferior thyroid artery. There are a number of lymphatics, fat, and clearly diseased lymph nodes. We must not forget the thymus deep down in the superior mediastinum, and understand that the deep limit of our dissection is going to be the esophagus and the prevertebral fascia. So how do we approach the recurrent laryngeal nerve? Maisie Shindo wrote an excellent paper in 2005 and really showed that the relationship of the nerve to the tracheoesophageal groove really depends on whether you're dealing with the left side or the right side, and what the distance is between the cricoid cartilage superiorly and the sternal notch inferiorly. And really, in summary, the nerve is going to be very much parallel and closer to the tracheoesophageal groove on the left-hand side. And the nerve is going to make a far more lateral approach on the right-hand side. And in those short necks that are less than 5 centimeters between cricoid and superior sternal notch, those nerves are going to make far more obtuse angles and come in from a lot more lateral and from a lot deeper. So that's very important. But that said, when you're dealing with revision surgery, those nerves unfortunately can be anywhere. So when you're tackling the right-hand side, the safe margin is always going to be the innominate artery, because you know that the recurrent laryngeal nerve, which you can see here, runs deep to it. And that's the same thing on the left-hand side, where you've got the common carotid, the brachycephalic trunk, and you can see here the recurrent laryngeal nerve going deep to these structures. So when you're starting to look for that nerve, and here you can see a resected specimen of the right central neck, it's always important to start low. And it's because it's safe, because you've got the innominate as a good marker. And also, this is going to be one of the less surgically violated areas, and it's much easier to find the nerve in this area here. When present, you can look for the inferior thyroid artery, and as you're tracing it medially, you will come across the nerve. But also the parathyroid glands, which you might see superiorly or inferiorly, are going to give you a guide to the possible location of that nerve. But that said, with the advent of the nerve monitor, if you turn the nerve monitor to 2 milliamps, you can actually map out the potential area where that nerve is with applying the probe to this area here, and it can really lead you to the nerve very quickly. And this is such a case. And here you can hear the nerve being stimulated, and then with very focused dissection, you can identify the nerve very quickly. One of the really important things is to understand that lymph nodes in the compartment are equally found either anterior ventral or posterior dorsal to the recurrent laryngeal nerve. So when you're clearing lymph node tissue in that area, you really have to clear all the tissue around. And that often means taking the tissue off anteriorly first and then swinging the tissue inferiorly underneath, and must in order to make sure that you get all the disease out. And this was a paper written by Clayman in 2015, who reported on a very large number of revision surgeries. The second important structures really are the parathyroid glands. And again, you really need to know the normal position and relations of this gland. And you can see here a picture on the bottom left, which is actually during a parathyroidectomy and thyroidectomy. You can see here the parathyroid adenoma, but importantly, you can see the recurrent laryngeal nerve here, and you can see that the superior gland is in a posterior or dorsal position, and the inferior gland is in an anterior or ventral position when you're using the nerve in a coronal plane. And that's really the classic position. It's really important that you know what the color is of the nerve, and you can see here a left central neck revision surgery, and you can see here the superior gland demonstrated clearly with the different color to the little surrounding fat. The other really important thing is to see the interaction of the parathyroid within the tissue. And again, in revision surgery, this might not hold perfectly because of the scar tissue, but we talk about the gliding sign, and you can see here the parathyroid gland just lying underneath the fascia, and you can see what happens when we actually stimulate it, and you can see the parathyroid is gliding nicely within that pocket, and that's going to give you a big clue of where that gland is. Once you've dissected out the tissue, however, and this really holds most commonly for the inferior gland, is that we sometimes have to tease out a parathyroid gland from the resected specimen. And you can see here, this is the gland that we removed. Ensure that you check it with frozen section and then re-implant the parathyroid within either the sternocleidomastoid muscle or other muscles available. One thing we must not forget is that lymphatic tissue can actually ride quite high into the neck and even become involved and at risk during a thyroid surgery. And here again, you can see a left central neck that's been re-resected. You've got the common carotid artery here, and here you can see the lymphatics coming in behind the carotid sheath. And again, on the video, an important test for the lymphatics is actually to disconnect the patient from the ventilator and press on the abdomen, and you can see the gland expand as you do that. And that sign was described by Soneia, who's a very well-known thyroid surgeon in Brazil. And you can see here how the lymphatics, every time I press, really expand as the lymphatic tissue kind of refluxes back out. So you've got to take really good care looking for those glands, because you can be surprised and get a Chi leak. When you do a central neck, generally we do not enter the lateral neck, but one area where disease is often missed is within the carotid triangle. And the carotid triangle is an area, and you can see it here on the diagram, lined by the longest colli muscle, the scalenus anterior. You've got the subclavian artery going through it. The carotid artery and carotid sheath lies anterior, and the vertebral artery goes through it. And this is often an area where disease can be missed. And it is an area, when you're doing a central neck, that one can explore very easily and just make sure you don't miss any other lateral disease. So really, once you've done your surgery, you really should have a very clean central compartment. You can see it here on the right. You've got the carotid artery, you've got the prevertebral fascia with the nerve going across, and you've got the carotid artery. You can see it here on the left-hand side with the trachea here, the carotid artery lateral, the nerve coming, no, actually the nerve is actually coming up here in the tracheoesophageal groove with the superior parathyroid and right into the superior mediastinum. Here you can see the innominate. Here's the brachycephalic trunk and the common carotid artery on the left, and level 7 has been thoroughly cleaned. What's the outcome? Well, we know this procedure can be performed safely. The hyperparathyroid rates, as shown by Clayman, and the recurrent laryngeal nerve palsy rates are very low and very acceptable. And disease-specific survival is clearly excellent, and you get very good local control. But one must recognize that the aim of getting a negative thyroid bed ultrasound and an undetectable thyroglobulin is really only achieved between about 20 to 70% at best in the best series. And Clayman's success rate was 66%. So there are going to be a number of people who are going to have measurable thyroglobulin, but continue to have excellent disease-specific outcomes. And we must not forget that thyroid cancer actually has a significant financial burden on patients, to the point that it is now the second most common cause of medical bankruptcy in the US. So we really need to balance the risks of what we do with the excellent outcomes that are generally achieved with parathyroid carcinoma. We do know that 10 to 30% recur. Biochemical disease does very well. Structural disease in appropriate hands can also have good outcomes. And distant disease generally has, let me just go back. And structure and distant disease clearly has the poorest outcome. but the best results of revision central neck dissection only achieves at best 70% thyroid globulin negative. So whenever we're treating these patients, we need to consider risk factors. It's got to be a team approach by experts. We've got to balance the risk versus the benefits and treat these patients in tertiary and high volume centers. Because importantly, we do not want to unnecessarily hurt these patients. Thank you very much.
Thank you, Professor Carsten, for such an excellent presentation. We don't have any questions as yet. Akshay?
Perfect.
Yeah, it was a great talk, and there were some beautiful pictures. So it reminds me of working with Carsten with this beautiful dissection and this technique. So I've learned a lot from him. Thank you, Carsten, for the wonderful discussion on the revision central compartment dissection.
Pleasure, pleasure. And thank you to everybody who's been so patient, as I think we've overrun significantly. So thank you very much for everyone's attention.
Thanks, everyone. We would like to invite Dr. Mayuri, who is a senior head and neck consultant at Aster Kochi, for any comments and conclusion remarks.
I thank the organizers for this opportunity. I actually want to just congratulate the HCG academic team, Dr. Vishal Rao, Akshay, their teams for such a wonderful program. And I don't just mean today's program. The entire series has been very educational for me. I've learned a lot. All the speakers have been fantastic, excellent academic content, high level of academic content. I'm learning. I look forward to the next program as well. And thank you for indulging all my questions to all the speakers and the organizers. I appreciate it. Thank you.
Thank you, Mayuri ma'am. It was really encouraging for us with a lot of questions and interactions. Thank you, Samskruti, for beautifully moderating this session. Special thanks to Professor Palm and his colleagues from Sydney, Dr. Ash Gargia, Professor Elliott, Professor Robinson, Professor Hubert Lowe, and our own Professor Chowkar. So it has been a great learning for us. The information shared by you is going to be very, very valuable for all the head and neck surgeons across the globe. And it is going to be a learning repository on thyroid for us. Special thanks to Carsten for really initiating this and working with us to make this possible. Thank you, Carsten. Looking forward for future meetings going forward. We all there is a slight change in the program schedule because of the time this thing. So we have 2 talks in the afternoon by Kapre sir and Vishal sir, followed by 3 surgical video demonstration. Thank you all the participants, and thank you again all the faculties for taking time out on this Sunday and making this a wonderful event. Looking forward to see you at 4 o'clock in the evening. Until then, bye. It's bye from us.
Thank you.
Thanks. Bye.
Bye.
Thank you.
You used Windows before.
Remember, whatever name you call it, it's a tiger. And whenever you plan to enter into this surgery, remember it's entering into tiger's country. What makes it retrosternal? There are certain guidelines. How much of this thyroid is behind or in the superior mediastinum? How much is it into the neck? And depending on how much percentile composition of this tumor lies in the superior mediastinum, people have given these various gradations. Now, why these gradations? And why should you know about it? The simple reason is that the blood supply will be coming from the neck regardless of where the tumor lies, depending upon the anatomical landmark where it is, and secondly, the histopathological nature of the tumor. So this is very important to know that how much is it in the neck and how much is it into the chest. Why does the thyroid migrate? Another thing we should remember is because of the adjoining structures. because of the deglutition force, respiratory dynamics, negative intrathoracic pressure, and the landmarks or the facial planes which guide them. So this will tell us how this goiter is going to go into the chest and which direction it is going to move in. And that gives us some idea. Now, for example, let's say an isolated mediastinal goiter. Now, this may not necessarily be an aberrant goiter, but this may be just a Stachy's remnant, which is from the lower pole of the thyroid, and it just migrates down into, because it is not really absolutely in continuity with the thyroid, but they can just pull themselves down. And what sounds like an aberrant thyroid is actually a Stachy's remnant which has migrated down. Now, why this knowledge is sort of important for us to plan our surgical approach is because if this be the case, then just isolatedly attacking the thyroid won't solve the problem. One. Secondly, if it is not truly aberrant, that means no connection with the thyroid, the blood supply will be different. And if it is the Stachy's remnant which is being pulled down, the blood supply will be definitely different. So this is how the knowledge of the pathogenesis or the genesis of the retrosternal goiter going to help us to decide what kind of an approach are we going to take. The other thing is how much is truly which of the things going to operate. Because if you go regardless, about 80%, 85% plus of the time, you will come scot-free, because this is probably a neck or a cervical goiter or a cervical thyroid, which are just dipped into the mediastinum. And for this, a simple knowledge is helpful, that most of the CT scans which will be reporting that part of the goiter is substernal or superior mediastinal is because of the position in which the CT scans are taken. But truly, if you look at the posterior mediastinal goiters, which are the more difficult proposition of the lot, are fortunately not very common. And the isolated or truly mediastinal are even less common. There are multiple classifications are given. Now, what does the classification do to us? It allows us to decide and communicate amongst ourselves and our colleagues. What is it we are talking? Is it a simple cat, or is it a tiger, or is it somewhere halfway a leopard? So this is how we decide, by having some kind of a classification. And the first one is clinical. The second one is anatomical. Now, anatomical means in which anatomical plane the goiter is moving. Is it moving into the visceral plane? That means it is between the trachea and the esophagus, and it is in the posterior mediastinum, or it is moving into the vascular plane, which is between the arch of aorta or the common carotids on both sides, and not likely to progress beyond the arch of the aorta, a little better proposition. Or it is altogether a de novo or an aberrant or truly detached Stachy's remnant which has gone into the mediastinum. This definitely helps. But I will draw your attention to the more practical classification which is going to help us into these matters. Where would the RLN be? Which would be the position of the brachiocephalic vein? What is the blood supply likely to be of this goiter, and what relation will it have with the trachea and esophagus in terms of compressive symptoms, which will be helpful to us in management of the anesthetic techniques and the post-operative care. And of course, all this put together will help us to decide what approach or what rationale we have in deciding how am I going to approach or remove this retrosternal goiter. The most practical classification that I could dig out for you is from Professor Greg Randall's book, and which is not only practical, but is actually guiding you into what kind of a surgical approach would you take for a given retrosternal goiter. The one type A or type 1 is a straightforward, which is in the older book called as the vascular part of the vascular type, where it lies between the great vessels, and the trachea will lie sort of behind or in between the two lobes of the retrosternal goiter. This will definitely deliver itself in almost practically all the cases cervically, and therefore no indication to do a kind of a thoracotomy or a sternal split of different kinds, which I will elucidate later. whereas the type 2 are the posterior mediastinal, and therefore they lie posterior to the vessels and they lie in the visceral compartment. That means their relationship with the recurrent laryngeal nerve will change. The recurrent laryngeal will not lie behind the goiter, but will lie actually anterior to or ventral or superficial to the goiter. And that naturally will guide me into deciding what kind of an approach am I going to take and what kind of a surgical steps will I take in getting at this retrosternal goiter. Again, it matters whether it is ipsilateral or whether it's a bilateral, or is it one-sided is a multinodular goiter but not retrosternal, but the opposite side is going retrosternal. All this knowledge comes handy to us in deciding, and I will elucidate the surgical steps that you should take in dealing with these different kinds of goiter when it comes to removing them. The isolated mediastinal goiter, which is type 3, is a different kettle of fish altogether, and what you require here is a certain thoracotomy or a sternal split, depending upon where exactly the goiter is lying. But before we move in, let's go with the standard approach. What would decide you to take your surgical approach will be age, sex, duration, and of course, the most importantly here is difficulty breathing and deglutition, because these probably will tell us two things. A patient having difficulty in breathing in supine position would probably indicate that this goiter is anterior or ventral to the trachea, and therefore it's compressing the trachea when the patient lies down by its weight. Whereas those patients who will have a very obvious difficulty in deglutition would probably be indicating to me that this is probably a visceral or a posterior esophageal extension, and therefore my antennas will be up and I will be looking at the visceral or the type 2 retrosternal goiter. Change in voice, is all thyroid surgeons know, is an absolute paramount importance in knowing whether the recurrent nerve is involved. Two reasons: either pure pressure, which is unlikely because it's a very robust nerve and it does stand a fair amount of traction, or elongation, which happens over a period of time. But the palsy would usually indicate not just the pressure or elongation because of a benign disease, but because of a malignant disease, which is going to cause infiltration into the nerve and therefore a palsy. The simplest of morning puffiness of face. Now we all know from our MBBS days or undergraduate days, as we call them, is the puffiness of face is query renal, query kidney. But to us as thyroid surgeon, a morning puffiness of face would probably indicate that overnight, when the patient lies supine, there is some superior vena cava obstruction syndrome, not a full-blown one, but a milder version, and therefore the patient tends to get puffiness on the face, which gradually disappears as the day progresses. In clinical examination, I can't stress more about the importance of the Pemberton sign, examination with hyperextended neck, and above all, the telelaryngoscopy to see whether the vocal cords are mobile. It's not just the vocal cords, but the other information which I'm going to share with my anesthetist on this telelaryngoscopic examination is the pressure or the edema effect that it may cause upon the vocal cord or the larynx, and pre-warn my anesthetist. We'll talk about intubation and anesthesia a little later, but at the clinical point of time, it is enough to know that a skewed larynx or a larynx which is not in the middle, edematous, and the piriform fossa are showing fullness would indicate to me that maybe this is going to be a little bit of fun while intubating or looking at them post-operatively. Assessment of the retrosternal goiter. We know all the modalities at our disposal. I'll just quickly run through one by one, which is their sort of a rational position in management of surgical approach. Let's talk about ultrasonography. Now, people would say, limited approach, there's a big sternum there, everything is in the mediastinum, what are you going to do? But many times when you have a tumor which is partly in the neck and partly in the chest, like the one you see on the right-hand side, this might be a good case to do a fine needle aspiration cytology from a suspicious area, which will know us in advance that yes, this is probably a papillary or some kind of a well-differentiated carcinoma, although all clinical parameters are towards benign. And how would that warn me? Be that a papillary, I should be prepared to handle lot of nodes in the superior mediastinum as I'm planning my surgical approach. So ultrasound is not just to be thrown out of the window, but has got its application, particularly in aiding my fine needle cytology in a doubtful case. CT contrast is absolutely a gold standard. You can't run away from it. And the axial plane will not only give me a standard information as to benign versus malignant or differentiate them from other mediastinal masses or presence of lymphadenopathy, it most importantly will tell me about the relationship with the trachea, the esophagus, and the vessels. And in particular, the compression on the trachea or maybe softening of the tracheal cartilages or even indentation of trachea either unilateral or bilateral. In malignant cases, it might actually also tell me that the trachea is physically invaded into and pre-warn me into management of the trachea either at the time of surgery or post-operatively. What is the value of MRI? We all know that MRI is incremental in this, is ability to display the anatomy in coronal plane, because the coronal planes are not available on a CT scanner. CT scan will do by its jigglery or the computerization to give you coronal planes, but the true coronal planes will be available to us only on the MRI. More importantly, early detection of esophageal wall or the tracheal wall will be picked up on the MRI. Although it is expensive, although it takes a longer period of time and the patient feels claustrophobic, particularly if they have got an orthopnic state, it will definitely tell us far more information for its incremental value. Poor definition of malignant versus benign, we all know that, but then there are other methods of knowing that differentiation, which we want to know beforehand by way of CT scan, but it is definitely of important value. Now, this is a very standard picture I would like to share with you. Look, as big it looks, it is still completely within the arch and the two common carotid artery. So this is something everybody would love to do, because you know that the recurrent laryngeal nerves are way out of harm's way. They are lying posterior to the main mass, and a careful dissection will almost guarantee their safety throughout the surgery. Not only that, because it is dragging in blood supply from above down, and there are fat planes there, which will indicate to me that this is benign and also unlikely to draw its blood supply from the superior mediastinum and not make my surgical approach little messy. This is the one which I showed you a while ago, a lady which we have not seen so long ago in our clinic, and had misfortune of sort of handling her, because this is not that you would like to do every day, but there she go, and you got this tumor which is going all around the viscera and going between the trachea onto the esophagus and making your life that much more difficult to handle. The age and the characteristic clinically of the tumor is no doubt to indicate what kind of pathology we are landing up with. But importantly, the imaging will tell you these three pictures. I borrowed this from Ricardo Simo's presentation from the surgical management of interthoracic goiter, and I immensely like the idea that there are oval, tubular, and iceberg. Now, this is very, very important and very, very rational deciding thing, that if you got oval kind of tumor, you can be almost sitting pretty the night before and have a good night's sleep and not lose your bit of a sleep because of the next day case, because you're almost assured of an easy delivery. Same is about the tubular, but sometimes the tubular one are flimsily connected at the lower pole, but that doesn't really still make you worry too much. The third category are the iceberg type of retrosternal goiters, where what you see in the neck, and I'll show you a clinical picture of that towards the end, are the real ones which will make you lose your sleep, because what you see is just the tip of the iceberg, and most of the meat is right in the mediastinum. Now, when do I and why do I operate the retrosternal goiter? And there we really begin into the meat of my talk, which is the surgery. Now, People would say, oh, why operate, wait, if it is seen to be progressing? What are you going to wait for? Your predicament, what is there today, is going to get worse day by day. Surgery offers the best chance for a dysfunctional larynx in case one of these nodules are hyperfunctioning. Also, the obstructive symptoms of aerodigestive tract are best handled as early as possible rather than late. When you suspect histopathology, your best bet is before it starts showing, going out of the capsule and into the mediastinal structure and start drawing its blood from that area, which will make your life that much worse as you move along. By and large, this is what Greg Randolph's recommendation is. And I'm not so lucky to get 5 centimeter retrosternals. They're far bigger than this when they land up with me. But what he is recommending, and I quite sort of good guidelines to follow, is anything which is bigger than 5 centimeter is must or should be removed surgically at the earliest possible opportunity for these obvious reasons. If the tumor is either compressing aerodigestive tract, there is no real sort of wonder that you need to go in, or same is the case with superior vena cava. Now, this is another slide I borrowed from the same presentation of Ricard Simo, and this gives you a good guidelines in the beginning, because you see in the beginning when you are finding your ways about in the superior mediastinal masses of goiter, it is important to know how do you counsel your patient and how do you counsel yourself, that to know which is a genuinely a diverse country and which can be a little pussycat. Now, anything which is going below the arch of aorta is a highest risk. Any recurrent goiter you may ask to operate upon again amounts to a highest risk. Any multiple mediastinal, multiple mediastinal nodes in case of papillary carcinoma makes it definitely a big job. Pleural or aerodigestive tract involvement, obvious that they are very high risk. Relatively, they are low risk. They are into the retroclavicular extension. So in between are the moderate risk ones, or the tubular, which I mentioned to you, are the oval and the tubular ones. Now, why do I need to know this? I need to know this and get myself accustomed with this kind of a practical classification of risk, is because this is where I'm going to address this tumor, not only within my own mind, but with my patient, with my colleagues, and be prepared for post-operative eventualities. Most importantly, before I start sharpening my knife, I have to really go in for assessment of airway, either clinically or by imaging or by endoscopies. But most importantly, not because my wife is an anesthetist, I may have an angry woman in the kitchen when I go home if I don't tell her about all the airway assessment that I've done, is because no matter who she is, she must know what she is landing into. So always share all your information that you have gathered on the anatomical or the compartment involvement of the retrosternal goiter with your anesthetist. When do I call? If I'm not accustomed to operate in the thorax, when do I call my thoracic colleague? Or if you're competent enough to operate in the thorax yourself, when do I get my thoracic tray out? Now, there are 3 approaches which are well known: transcervical, mini thoracotomy, or manubriotomy, or upper third thoracotomy, or a sternotomy, or a full-blown, full-stage transsternal approach. But most importantly, deciding, and let's see what the experts have to say. And I'll share with you, and I would like to drive your attention to certain facts. Now, let us see what the first colleagues of ours from Poland have said in the year 2008. And he says, 8 out of 27, the location was in the posterior mediastinum, and he required a thoracotomy. This is what we have been talking all the time. He also mentioned that one of the reasons why he had to have a thoracotomy was an aberrant thoracic goiter, obviously because it carried aberrant blood supply. Now, the other gentleman from Turkey in 2004, same deep enlarged gland in the posterior mediastinum, can't be repeatedly enough, where it caused Dell's adhesion or attachments with the visceral organs, which is trachea and the esophagus. Now, as we move on in year 2010 and 9, from Italy and USA, you will find a similar kind of a picture, that most of the people are suspecting vascular invasion, that is the innominate vein, or a primary goiter where it is independently draining its blood supply from the mediastinum, which you cannot handle transcervically. Now, Cohen in 2009 also shares his experience that 1 in 5, which is 20%, will be below the arch of aorta, in which case you cannot reach them. The arch will come in your way. You need to have a direct approach below the arch, and that's the only way possible is by splitting the sternum. And therefore, these are the kind of indications so far. And one more paper, one more set of papers we'll review will be from China and from Taiwan. There is no way that you can compete with the statistics coming across from there. But still, the giant traditional goiter, the only reason why they were attacking them by a thoracic approach was malignancy. And the Taiwan paper says that the reason why they were approaching large posterior mediastinal tumor because of the uncontrolled hemorrhage that they will encounter with the tumors. And they also indicate that there would be a RLN paralysis at the beginning of the surgery, indicating or necessitating a thoracic approach. But my friend and a good friend from England has slightly rationalized and made the life a little easier. And thanks to Professor Neil Tolley, that he has come up with another classification. I think this is the classification we need to know from the approach point of view, is the anatomical location, which is almost similar to Greg Randolph's, but slightly different, because he is now retracting back into telling us that 1, 2, and 3, the 3 will require definitely a full sternotomy. Type 2, which is up to the aortic arch and the pericardium, will require at least manubriotomy or a mini thoracotomy or a mini sternotomy. And about T4, which is between the arch of aorta, this will only be delivered happily transcervically or through the neck. I think this is probably the most working classification that you would probably have, not retrospectively, but I would say prospectively. And what was his analysis? He said that this is again Professor Neil Tolley's work, and he says that he only had to have about 71.9% cervical, but look at the full sternotomy. He only required 5% or 5.4, which is almost 6, and only in 3.6 he required a very formal thoracotomy. And if you go into details of those papers or those cases, you will find that the reason why he required those was that the tumor was behind the arch of aorta and therefore not amenable transcervically. Now, indications for sternotomy, by and large, we have summed up so far, is malignance, transverse diameter. This is an important factor. If the transverse diameter of the tumor is greater than the thoracic inlet, it is unlikely that you will deliver it from the neck. Type 2, we have already seen SV syndrome and region surgery. Surgical techniques, I'll share with you that the facial planes and dividing the fascia from top to bottom and releasing the strap muscles and part of the sternal head of the sternocleidomastoid will improve your access into the mediastinum. How do you manage RLN? Very important. The RLN is diagnosed as soon as possible in this particular surgery. That means you will find it at its entry into the larynx, or you'll go what is technically described as medial to lateral approach. Very easy into type 1, not so easy in type 2. My own ideas or my own suggestions for finding out RLN in type 2 is finding out its insertion, but dividing all the apopole, dividing the isthmus and reflecting it all the way down, and take a double approach that you are finding it the nerve from medially as you are medial to its insertion and also from laterally at its insertion. And you know from here onwards the nerve is going to be ventral or superficial and your plane of dissection lies behind the nerve. So this is very important. Sometimes I tend to divide the isthmus right in the beginning because that makes my thyroid a little bit more mobile. It may be worth an idea into this tumor, particularly if they are multinodular, is to address and approach the opposite side, which is easier of the two, And as they call it with the famous quotation, put your money in the bank. So you put your one superior parathyroid and one recurrent laryngeal nerve in the safe deposit vault, and then come into the tiger's country and start dealing with the opposite multinodular goiter. What are the special maneuvers? Nothing really special, but remember the great William Halsted observation upon the surgery of the great Robert Cocker and Bill Roth. The thing he said, the meticulous hemostasis. Cannot be stressed more that this is one particular thyroid surgery where we will not like the blood flowing about here and there and make the field as dry as possible at all possible times. RL identification and following it in the mediastinum is of crucial importance, and I described to you already my own recommendation how to find it. The cephalic identification of RLN is absolute mandatory in type 2 retrosternal goiters. Now, finger dissection, everybody talks about finger dissection. Now, let me share with you about finger dissection. Finger dissection does not create facial planes. The finger dissection is not meant to create planes, because as general surgical training, we all know when the plane don't exist, push your fingers and create your planes. No way. This is not the place to create the planes with your finger, but explore and take advantage of the traction that creates the plane. So your one hand keeps on gently pulling, and I sometimes get the head down or make the patient a little taller than me and then look underneath. So my one finger or set of fingers are pushing the tumor backwards, whereas I'm creating a plane which already has been created, and just insinuate my finger with the great vessels on the other side of my finger. So my finger is palpating in a way, a vessel on the dorsal aspect of my finger, and my ventral aspect of my finger is actually palpating the tumor. But remember, I'm not creating a plane. I'm not dissecting. I'm just exploring or exploiting, maybe the right word to use, the existing plane. And this will safeguard my innominate and the subclavian. Now, complications 1, 2, 3, 4, 5, 6, everybody knows that. But let's see how to prevent them. In retrosternal goiter, the type 1 is the one likely to get many complications, and type 2 is the one with the maximum complication. Now, intraoperative nerve monitoring for recurrent nerve palsy. You can't have a better person on this than Greg Randolph talking, and I'm quoting him and his paper and his work on to you, is that, however, there is no significant retrosternal goiter in terms of palsy, but the use is obvious that the functionality of nerve that will be stretched on a long course will be known to us and forewarns us about the status of the nerve. It is a very useful adjuvant tool at our disposal in the last decade. Now, parathyroids in retrosternal. This is something which is a hobby horse for me. I draw your attention to this particular picture of vascular loop, where the superior parathyroids, particularly on the contralateral side, are my safe or my lifeboats, and they must be saved at all costs, because I will not be so certain about how my inferior parathyroid, the inferior set of parathyroids are going to be, where they're going to be, and if and when I'm going to be able to save them. Unlikely I can save them, practically speaking, because I will be taking control of the inferior thyroid artery, which in turn is the main supplier of the inferior set of parathyroids, and I'm obviously going to cause the damage. Should I be so lucky to find them out after the specimen is delivered, it is imperative that I re-implant them. In conclusion, as I close my talk, the transverse diameter will guide me. If it is greater than the outlet, obviously I need to do some sort of a sternotomy. De novo or the retrosternal type 3 will require some kind of a retrosternal approach. Malignant disease, absolutely must. Malignant disease with the sternal involvement, you will need to take the sternum out anyway, so that's no big argument. The nodal involvement, if there are lots of mediastinal nodes and they're likely to be bilateral, it probably helps me to have a sternal split, and all type 2 will require at some point of time a retrosternal approach. Revision surgery, there is no denying that it is a retrosternal goiter. And I told you about some clinical pictures that you should be very wary about. Is this particular gentleman, this is tip of the iceberg, very superficial like small looking goiter, but believe me, most of it is in the mediastinum. Now, this lady, you will say a piece of cake, doesn't look big, but this is not a piece of cake. This is absolutely a Christmas pudding, because this is what the lady who had this tumor. Now, if I have interested you enough in retrosternal goiter, you're all very welcome to our Thyroid Gurukul. Hopefully, we will not miss in the year 2021. The corona and all the viral pandemics should probably quieten down by then, and we will be able to host it as usual. Thank you all very much for your patient hearing, and thank you, SCG, one more time.
Thank you very much, sir. Sir, we have a few questions. So first question is by Dr. Mayuri. Is there any way to predict which goiters will become retrosternal on long-term follow-up?
Yes, very good question, because we are nowadays trying to follow up lots of our goiter and not operate on every single goiter that we see. Those who are mostly at the lower pole, and where you find like a distant lobulation on the lower pole of the thyroid, these are likely to be the Stachy's remnant goiters, and they are likely to be pushed down over a period of time. And if you find that they are getting isolated from the main bulk of the thyroid, then maybe these are the ones we should not wait too long to operate upon and get in there soon enough so that they don't become a big nuisance in the years to come. I will not wait upon this kind of a situation. A repeated ultrasound or CT scan showing that they are getting detached or they are getting little distant from the main thyroid gland.
Okay, thank you, sir. So we have another question. How to manage patients of retrosternal goiter having severe dyspnea? How to do tracheostomy?
Good question and a very practical one. First answer, if your imaging shows that there is a compression on the trachea, but not actual tracheal invasion, mark my words, if it is showing compression but not invasion, then these are very easy patients to intubate. They are not as difficult as they look, because as the tube will go in, it will stent or push the goiter out, and that will give you a reasonably nice, you use the armored tubes or the flexometallic tubes, and you can almost get through. And if you do an indirect laryngoscopy or a telelaryngoscopy or a flexible bronchoscopy, we will tell you, yes, I have a reasonable airway to get in there and get in there with my scope. Now, more difficult ones are not the benign ones, but the more difficult ones are the malignant ones. And here you are caught between the deep and the devil, deep blue sea and the devil. Now, here again, I will insist that see if you can ventilate them a little bit and get any sort of a tube, if you can, into awake intubation with a flexible bronchoscope. That's your best bet. But should you not be so lucky to have these kind of experts with you, the best bet to do is here is to count your stars, pray your prayers little bit louder than usual, and maybe little not less longer than usual, because you need to speed up and divide the isthmus. Many times, as soon as you divide the isthmus, the compression effect on the trachea disappears and the stridor immensely improve. And if you are lucky, you might be able to do this bit of the surgical procedure under local anesthetic. But they are difficult, easy said than done. I will not be in that. I will not like to be in that position. And fortunately, one doesn't get into that position that often.
Okay, thank you. So are there any minimally invasive approaches recommended for clearing the thoracic portion of the goiter?
Of course there are. And of course there are people who are doing all kinds of thoracoscopic procedures onto the mediastinal masses and tumors. I will be very honest. I have, why would I say minimal? I will say I have no experience of that surgery. But yes, there are people who are doing this. There are experts who are doing this. Only word of caution to the juniors, because at my age, I'm not going to learn doing the thoracoscopic approaches and the mediastinal robotic surgeries, because maybe my fingers and my eyes are not that coordinated at this age or not dexterous enough. But certainly if younger people want to get into there and get into this kind of surgery, that's the future. And they are very welcome to develop the technique for the betterment of our services and the surgical result. Only piece of advice is that unless you are well versed with the open techniques and unless you know the anatomy like back of your hand, please do not venture as a new tool that you got. Otherwise, you'll be George Washington hacking away at all the trees.
Okay. So we have another question. I think it's already answered. The question says, how will you manage a case of retrosternal goiter or a case of huge MNG presenting with stridor?
Yeah. The thing which I didn't mention in that part of the answer was you must be absolutely certain that this goiter is not as a result of recurrent nerve palsies and this is purely a compressive symptom. Because if that goiter was because of the recurrent laryngeal nerve palsies, you had to be prepared in a very different way, because those bilateral recurrent palsies in a large multinodular goiter are indicative of something different in terms of pathology. So my answer is valid in the earlier part for benign and normal vocal cords.
Yes. Sir, how do you manage these patients in the post-operative period? Would you get them extubated immediately or would you wait? Or what are the intraoperative aspects you look into for post-operative extubation?
Yes, very good question. Very good question. Is that from you, Bhushan?
Yes, sir.
Yes, that's very practical and a very true question. There are 2 or 3 things I look at when I'm extubating this patient. Number one, what is the functionality of my both recurrent laryngeal nerves? And that's where the intraoperative nerve monitoring comes very handy. And if they are both functioning well, that is one. Number 2, I also look at the trachea. Now, tracheomalacia as a cause of postoperative stridor is a bit of myth. Very rarely will you have a trachea which is malatic or weak or palsied, which will be sort of reason for stridor. And the third thing I look at is what are the other comorbid conditions that we may have. Now, other comorbid conditions like a pulmonary poor reserve, old people, and in those situations where my anesthetist is not too happy, I will probably extubating them the next day. But in all other cases, if all these parameters are good, I'm happy to extubate them on the day 1.
Okay.
As a finish, not day 1, at the end of the surgery.
Okay, sir. We have a comment by Dr. Kudosh Ahmad who says, in large goiters, awake intubation may be tried when someone just gives a gentle upward traction to the thyroid gland to relieve the compression.
Absolutely correct. And I have indebted Kudush for this particular piece of advice which I have received from him, and I have passed this on to my wife, who's an anesthetist, is to do a lateral intubation. Now, this is a trick I learned in Guwahati with Kudush, that if you make the patient lie on the opposite side so that the traction is pulling the trachea toward by gravity medially, so that slightly makes the life easy for the anesthetist. Excellent point, Kudush.
Yes, yes. So I think we are done with the questions, sir. I think we cannot think of any other person who would have made such a complicated topic sound so simple and with lot of practical inputs, sir. Thank you very much, sir.
Thank you all very much.
Thank you. Thank you for joining, sir. So we'll move on to our next speaker, Dr. Vishal Rao. Dr. Vishal Rao is a regional director in head and neck surgical oncology and robotic surgery and associate dean for academic research at HCG Cancer Center, Bangalore. He's also been conferred honorary FRCS by Royal College of Surgeons, Glasgow, and American College of Surgeons, recognizing his contributions. He's also a recipient of Judy Wilkenfield Award for Global Excellence in Tobacco Control. So Dr. Vishal Rao will be speaking about sodium iodine importer and its implication in management of tennis syndrome, which is a nightmare for any thyroid surgeon. Dr. Vishal Rao, over to you.
Thank you, Bhushan. I'll just start sharing my screen. There we are. So I was asked by Akshay to speak on this topic. I will be in the next few minutes covering and giving the necessary emphasis on sodium iodine importer gene expressions. I'm representing HCG here. We are a chain of cancer centers. We are at about 26 now across the globe, and recently entered into Africa and Vietnam. And in head and neck specific, we run an affiliated course with the Royal College of Surgeons, which is a joint fellowship given by the Department of Head and Neck and the Royal College of Surgeons. We run our own courses with Nature on scientific research and publication, and we also have our own journal which we have recently started with Walter Kluwer's of the Journal of Precision Oncology. Now, coming to this topic, I'm just going to introduce this topic with an interesting case that I came across of this 26-year-old lady who was a papillary cancer diagnosed in September 2016 from Eastern India, underwent a surgery there of total thyroidectomy, central compartment neck dissection, and a left lateral neck dissection at a trained regular center that practices oncology. After this, in September, the histopathology read as papillary CA, multifocal, focal angioinvasion, and extracapsular extension was present. Lymph nodes were positive, and extranodal extension was present. These were the features given to on this patient. Now, following this, the patient underwent an ablation again the next month. Thyroglobulin at that time was 18 nanograms, and she received 100 micrograms of ablation. She was on a follow-up. Next year, when the iodine scan was done, the diagnostic scan was negative. There was no tracer uptake, but the thyroglobulin seemed to be rising, 78 nanograms now. And so the nuclear team put this as a tennis syndrome and advised a PET-CT scan. PET-CT scan interestingly showed a lot of uptakes at the thyroid level. They showed that there was some soft tissue nodules in the thyroid bed and the TO group. There were multiple nodes on the right side and some suprasternal regions suggestive of metastasis. There was no other distant metastasis. So the comments from the nuclear medicine team was that in view of this raised thyroglobulin and the metabolically active disease, this was suggestive of both a local and a regional recurrence. This is 1 year later for your kind information. So an ultrasound was also done, which reconfirmed that yes, there is a local recurrence and a regional recurrence. And this patient after that underwent MRND, central compartment neck dissection, and the final report again came positive. Now, there were some key messages that I want to give at the end of this. Another case study, 41-year-old lady with a swelling of 1 month history, 2016, underwent total thyroidectomy, central compartment neck dissection in Bangalore, January. The reports were capsular invasion, lymphovascular emboli, extrathyroidal extension, lymph nodes positive, and after that iodine scan 150 millicurie given, tracer uptake, thyroglobulin 330. Now, okay, so sorry. So with this report, here in this case, the lateral compartment neck dissection was not done. Now, the PET scan that we did showed multiple thyroid, multiple bilateral lymph nodes in this area and nodules in the thyroid bed. Again, a local and regional recurrence suspected, but in this case, it was also bilateral lung nodules. Now, again, a similar case. So they suggested that in view of this, there is local, regional, and metastatic disease. Ultrasound done, confirmed the same, and we went ahead, did a completion thyroidectomy, bilateral selective neck dissections in this particular patient. Histopathology revealed multiple nodes positive. Thyroglobulin after that was at 46. Now, in view of the persistent recurrent disease, he was also in addition to the radioiodine therapy given that was given at 300 millicurie, is also given external beam RT to the local region as a personal choice discussed on the tumor board. Now, I brought these two discussions into this particular presentation primarily to highlight a couple of points. Now, in this case, if you see today, the global incidence of thyroid cancers is rising. And this paper, which was published in 2006, is a very interesting paper, a thought-provoking paper on the span of practice changes over 3 decades. And they showed that over 3 decades, there was almost a 2.5-fold increase in the number of thyroid cancers, majority of them papillary. And in that group, if you see, majority of them were less than 2 centimeters. Now, why this is crucial is when half of them were less than 1 centimeter, more than 90% of them were less than 2 centimeters, which means there was a sudden rise in the number of small thyroid cancers which were being picked up early. And this particular paper gave a very strong note that this particular rise in thyroid cancers is not because of a true rise in cancer, but it is because of an increased diagnostic scrutiny that has led to an increased pickup. But at the same time, during this particular period, and this has been something that has been strongly argued about, that these small thyroid cancers are actually laboratory cancers. You know, Dr. Ashok Shah has been a great proponent of it. Judah Folkman, who's considered the father of angiogenesis, is another gentleman who has constantly proposed about these laboratory cancers, and very well elaborated in the Harrison's Book of Medicine, a chapter that was removed later in the 13th edition. Now, it is interesting to note that they argued that not all of these people require an aggressive treatment, and these are cancers that person will live and die with this. Now, if you look at around the same time, a very interesting paper came out from Mazaferi, where he showed that the 5-year relative survival rate in thyroids. Now, I know that we don't measure 5 years in thyroids, but there was a small relevance here was this paper showed that over 3 decades, the survival of these particular patients had improved. That means the 5-year relative survival in thyroid cancer patients was improved from 92 to 97%. Whereas in the same period, the rate of distant metastasis at the time of diagnosis had increased by almost 2-fold in men and in women, which is 9 and 4%. And the change in the thyroid cancer mortality was increasing by 2.4%, one of the largest increase that any cancer had seen. I am again emphasizing on this because there are 2 important aspects to this discussion of what I'm telling. What do we infer out of this? That there is a survival that has improved, but a mortality that has worsened. How do you decipher and make a message out of this? And this is where it is very important to understand that there is a difference between mortality and survival. While mortality defines the number of people who die at a certain cause in a year divided by the total number of people, the survival rate calculates the number of people with a disease who are still alive at a certain point of time after diagnosis. So you see thyroid cancer patients live very long. And most interestingly, what I want to talk about is, and these are the patients wherein you see something called as time bias in statistics, which means the cancer started at the age of 55 and the patient developed symptoms like a goiter at 67. Now the patient died at 70 years of age. So the 5-year survival here is going to be considered as 0%. Whereas in the same patient, wherein we screen the patient, the cancer started at 55, and because of ultrasound, you picked up this patient at 60 rather than at 67. The 5-year survival will be represented as 100%. Now, this is what you call as a dilution effect that happens when you start picking up cancers, and that is largely been the philosophical difference between the US kind of capitalistic medicine versus the British socialistic medicine, which leads to these dilution effects. Now, if you see the range of cancers that happen, you have the papillary, the follicular, the poorly differentiated, the anaplastic, what they often say is the good, bad, ugly cancers. Now, you know, there are so many staging systems. Till date, there are 17 staging systems in thyroid, and the 3 best practice yet are not able to effectively predict the course of this disease. And this is the biggest lacking, and I'm going to re-emphasize this to say, today we know that not all of these thyroid cancers are innocent. Some of them can behave aggressive. Some of them can lead to increased mortality, decreased survival, and not all of these are innocent. And there is no strong way today to predict which of these are really aggressive and which of them require very close follow-up, because on an average
Hello. Hello, sir.
Surface of biochemical to a very, very basic extent and very few genetically. And that is why most of our staging systems, even if you look at the most popular staging systems that have been advocated, the 17 of them, are not practiced in more than 95% of the clinical scenarios. So it is very important in this scenario, what is it that we could do? And that is when I come into this topic of sodium iodine symporter gene expressions. Sodium iodine symporter gene is a very, very important glycoprotein that actually controls, it has got an extracellular and an intercellular domain that controls the entry of iodine. And remember that the thyroid gland today exists because of this particular single gene. If this gene were not to be present, the thyroid gland wouldn't exist. And it is so important because the sodium iodine symporter gene is an active secondary transporter mechanism that uses sodium potassium ATPase and exchanges one iodine for 2 sodium. If you see this diagram over here, it is at the basolateral membrane that it exchanges for 2 sodium, it exchanges 1 iodine and allows the iodine to enter into the follicle cells. Now at this juncture, once the iodine enters into the follicle cells, it is then taken up by the peroxidase enzyme to undergo oxidation, and that is when T3, T4 are formed. So it is very, very important for us to understand that if not for the sodium iodine symporter gene, the thyroid gland would be a dysfunctional organ. And this particular sodium iodine symporter gene is singly controlled by one hormone, which is the thyroid stimulating hormone, the TSH. So this forms the basis of my discussion today, that the sodium iodine symporter gene is the most important denominator for the thyroid gland. And another important aspect of this is that the sodium iodine symporter gene does not differentiate between normal iodine, which we take in our salt, versus a radioactive iodine. Now, if you look at the pathophysiology, active radioactive iodine, when you give it, is trapped intercellularly and goes through a particular process of organification, which is what I told you about. And the decrease in this iodine concentrating ability of the residual disease is quite often seen through a particular pattern of a phenomenon called the stunning effect. But defective tumor cells couldn't hold radioactive iodine intracellularly, and the iodine influx can occur. Now, this happens because of a defective sodium iodine symporter gene expression. Like I told earlier, if there was no sodium iodine symporter gene, the iodine trapping mechanism will be completely abnormal. Another very important thing which I elaborated earlier was that TSH can control the entire mechanism of sodium iodine symporter gene expressions, looking at its proliferations and increasing it up to 27-fold in terms of both quantity and quality and sensitivity. Now, this sodium iodine symporter gene glycoprotein was discovered not very far away. It was discovered just about 2 decades back in 1996, and thereafter there has been a lot of human and mouse sequences that have developed. Now, what's most interestingly to be known about this thing is it lies on chromosome 19, and there are a lot of clinical implications which have been today being worked upon. Most important in the area of other glands such as salivary glands, mammary glands, where in addition to the breast and other things, in thyroid also they are used for diagnosis and therapeutic targets. The other is in the area of looking at sodium iodine symporter as an autoantigen for the pathogenesis of autoimmune diseases. Sodium iodine symporter genes based gene therapies to actually look at reactivating a defunct or a functionally defective gene, looking at it in terms of therapeutic targeting through a tagging mechanism in scintigraphies, or looking at their mutations for congenital hypothyroidisms. Now, but what remains unanswered and very interesting is that in many of them, although the sodium iodine mechanism or the glycoprotein is not functional, the mRNA and the proteins were seen, but they were not functioning. So there were many, many aspects to be understood of how the extracellular, how the intracellular membranes function, how do they coordinate with each other, what actually controls the regulation of this particular protein, and its functionality is still to be uncovered completely. Now, if, like I told earlier, mammary glands express this, salivary glands express it, stomach expresses, and it is not, however, in the thyroid, its expression is very, very high compared to salivary glands, mammary glands, and stomach. Another very important thing pertaining to thyroid is that sodium iodine expressions are generally not seen in normal lymph nodes. Normal lymph nodes do not express them. It is somehow found that in certain metastatic lymph nodes, it may express. However, even if they were expressed, their functionality were defective. So this generally gives you the impression and understanding that sodium iodine importer genes are not functional or expressed in lymph nodes, and hence iodine trapping cannot be used and radioactive cannot be used to treat lymph nodes. So it's the wrong notion that if I say that I will do a total thyroidectomy, but I won't treat the lymph nodes and the iodine will take care of the lymph nodes. It is a wrong notion because sodium iodine importer gene expressions are not functional or are not expressed at all. The other very important thing to understand is the very, very close connection between the sodium iodine importer and the GLUT receptors. Now, this is again something very, very relevant for you to understand, that when generally, you know, if you look at all cancers look at the glycolytic pathways. And we've recently written a paper on this called Electron Acceptors in Carcinogenesis, where we actually talk about the glycolytic pathway. It was accepted about a month back. I would urge of you all to just Google it up on electron acceptance and cancer. That actually talks about the molecular electron chain mechanisms in this. Now, with this, the one exclusion that the thyroid gland has is no cancer cell uses fat for its metabolism except for the thyroid. All cancer cells use glucose, but the thyroid gland is a very unique gland that uses fat for its metabolism. And it is interesting that when the sodium iodine importer gene expression changes, that is when you see a simultaneous improvement in the, or an increase in the GLUT receptor expressions, which means there is a crosstalk between sodium iodine versus the GLUT. And as the sodium iodine importer dependence reduces, the GLUT dependence increases, showing that it is becoming biologically more aggressive and something that is correlated very well with its biological nature. And this has been proved time and again through various studies from the South Korean group, another Italian group, who have proved that a gradual decrease in thyroglobulin, TSH receptors, thyroid peroxidase, pendrin, which is a very important protein that once the iodine enters into the follicle, the pendrin actually integrates the thyroglobulin with the iodine. So pendrin plays a very important role here. All of these go together, they go on decreasing while the de-differentiation and GLUT expression increases. So there must be a very deep crosstalk between sodium iodine and GLUT, that as the sodium iodine dependence decreases, the GLUT dependence increases. And that's why in lymph nodes, you see that the GLUT mechanism functions a lot and the sodium iodine functions less. Now that brings us to the importance of clinical application in sodium iodine importer gene. So as I told earlier, a very simple way to understand is that as the differentiation reduces, as the thyroid cancers become more aggressive, like poorly differentiated or anaplastic, the expression of sodium iodine importer gene is lost. The expression of GLUT increases, the tumor becomes more aggressive, and thus PET scan starts to pick up and iodine scans don't pick up. It's a very simple way. And this is what we call the flip-flop phenomenon. Now, this is very, very relevant because PET scans actually function on the GLUT receptors. Now, this can have very, very important decision-making points on adjuvant therapy, on whether to use iodine or whether to use external beam radiotherapy, because if GLUT is overexpressing, external beam radiotherapies can be more effective. And like I told earlier, planning gene therapies is very, very important and relevant. And lastly, looking at potential targets such as vitamin A, lithium, and others that somewhere are known to indirectly influence the sodium iodine importer gene functioning. Now, how it is what we don't know, but we know it further helps in the functionality of the sodium iodine importer gene by improving organification. In which particular area it does it is something that is actively still an open question for studies. So we did a study. We went and embarked on a very interesting study at HCG, where we wanted to study this in a much deeper point. And towards this, what we did was, this study was funded by the HCG intramural funds itself. And we wanted to look at what happens to the expression of it. Again, I'm not going to go into too much of these specific details, but what we wanted to know was, we wanted to compare thyroid cancers which were not tennis syndromes versus thyroid cancers which had become tennis syndromes in the long run, and compare the two and find out, was it possible that at the time of thyroidectomy, completing after that, when you get the histopathology report, what if I can tell with my help of my pathologist that this patient is likely to become a tennis syndrome in the future? Now imagine this, I know it's a very small percentage of 5%, but we know today, like from my beginning of the slides, that mortality is increasing. A sudden rise is being seen in sodium iodine in tennis syndromes. So it's important that if we can predict, rather than following him up for 10 years, keeping on calling him for annual iodine therapy, and then one fine day understanding through thyroglobulin elevated and negative iodine scan to say that this is tennis, which is more of a reactive approach, could we look at potentially developing a proactive approach wherein we can predict pre-op, immediate post-op, that this potential candidate could be a candidate for a PET scans, could be a candidate for adjuvant therapies like radiotherapy, could be counseled better on more closer follow-up, which could be every 6 monthly possibly. And this patients being on a more tight monitoring on thyroglobulins, thus picking up the tennis syndromes much earlier rather than looking at it, which could have a very strong bearing on outcomes, is our hypothesis. So based on this entire thing, we embarked on a study where we looked at these expression profiles, and we used both fresh samples and FFPE. We used RNA isolation kits. We used the Tachman fiber probes for NIS, which we were using. And based on this, we actually did the entire study with PCRs and found a very interesting plot. And this is a very interesting plot that would be worthwhile for you all to understand. Today, I'm sure with the corona PCR testing, everyone has got a training on PCR. So when you look at this amplification plot, you should understand that this is based on cyclical thresholds. Now, if you see this here, this is the baseline, which we have drawn, the blue line. And we've put the baseline as 0, and all those expressions that were studied, we found that expressions from 10 onwards up to 25, we found had very high expressions, which means they were very high expressions of sodium iodine symporter. And those ones with about 25 to 35 were on complete, were on no expression. So there was two differences that we found here. There was a group of tumors who had very high expressions, and there were a group of tumors that had no expressions. Cyclical thresholds 15 to 25 and cyclical thresholds from 30 to above 40. And in between were moderate expressions. Now, based on this particular thing, we compared it with the tissue types. Now, this was patient 1 who was a patient of tennis syndrome. And we compared that with expressions in normal thyroid gland, which had very high expression of sodium iodine symporter. When we compared that with some fresh thyroid tissue, that is fresh, the thyroid tissue that was normal, but which was derived from FFP, frozen tissues, we found the expression of sodium iodine symporter genes was less. This showing that when you take FFP and analyze it, you will not get the most optimal result because of the quality in which FFP is preserved, because of DNA and other decay that happens because of poor preservation. At the same time, we saw very high expressions in salivary glands, and negative controls were equal. So this was a very good standard for us on quality checks that we did. And after that, we studied these patients, close to about 20 odd patients of tennis, and compared them with that of regular patients. Now, we definitely found that there was a very, very strong correlation that at the time of the immediate post-operative period, we can possibly predict tennis syndromes effectively in these patients. So I would like to end with a few thoughts. So what we have currently done is we are developing the first Indian probe for developing the sodium iodine symporter gene test at HCG, which hopefully in the next 1 month we will be able to release. And we will have an indigenous one, which is India developed sodium iodine symporter gene test. The second, We've also developed quantitative assessment. So like I showed in this particular figure, we've looked at cyclic threshold to understand which expressions are high and which expressions are low, and to correlate that with dysfunctions. We are looking at, based on that, hopefully in the future, we are going to have more targeted redifferentiation therapies that can actually make a difference. And finally, the moonshot being that sodium iodine syn-importer gene expressions through mRNAs can be picked up in FNAC also. Now, this is something that has been tried earlier of looking at FNACs using mRNAs to predict sodium iodine expressions for diagnostic purposes. But we want to go a step beyond that to understand and see if we can do it for prognostication. So I'll kind of stop at this point, and if there's any questions, I'll be happy to answer them. Thank you.
Thank you, sir. So we have a question by Dr. Rakesh. Can we assume that sodium iodine syn-importer is a tumor suppressor gene?
Yeah, I think that would be wrong, because what we don't know today clearly is that sodium iodine syn-importer gene is not related to tumor progression or regression. So it's neither an oncogene or a tumor suppressor gene. What its functionality is what we really don't know. But I think what Rakesh has brought about is a very relevant discussion. There is work needed to understand what its role is, because in all the thyroid normal glands, sodium iodine syn-importer gene is expressed. Its mutations are not seen in thyroid glands, in thyroid cancers. Its mutation is not seen. But I mean, this may be worth a research by genomic studies to take up and see, are we seeing specific loop domain related mutations that in sodium iodine syn-importer could be posing its role as a suppressor or as an oncogene? I think that's a worthwhile study. Well, I mean, absolutely relevant, but we cannot assume at this point. I think Rakesh himself should take up some study like this, but I think it's worthwhile. And I'll be happy to work with Rakesh further to take this and maybe dig deeper into this, but absolutely relevant.
So I think the sodium iodine syn-importer and TSH receptor expression is a lot of epigenetics which play a role in terms of histone modification in this gene expression.
Absolutely. Absolutely. And epigenetics in this is very, very, very relevant. And that is why the factors in epigenetics that have been I would say attributed to are numerous. And that is why we've not been able to clinch on what are those epigenetic factors that are actually contributing to the changes here.
Okay. I think that's because the investigation was initially for global expression. It was not specific for one particular gene.
Could be.
Experimentation.
Could be. True.
So we have another question by Dr. Kudosh. Do some of the PET-CT positive respond to radioactive iodine in Tennis syndrome? If so, how?
I think sir's question again is a very relevant one. We have found that many of the patients who are PET positive are also RAI positive. That means they are positive. And the only explanations that we have found till date, even in our own personal experiences in these studies, was when we studied them both at microscopic as well as at genetic level, they had expressions of GLUT and they had expressions of sodium iodine syn-importer together. But what we have known from our own studies and biological significance is that it is the GLUT ones that are going to trouble you and not the RIA ones, which is why today the literature is coming out say that in such kind of settings, when you know that there can be radioiodine avid tumors as well as there can be PET avid tumors, it is important to give priority and understand and target the PET positive ones first, because they are the ones that are going to trouble you. So at HCG, what we have been practicing for a few of these select cases is, when we know that there is a coexisting experience, that means there is mild uptake, thyroglobulin is high and PET is positive, we tell the patient to take recombinant TSH so that within the span of the discharge of the patient, the iodine therapy is done. And then within 4 to 6 weeks, the external beam radiotherapy can be planned. So that way you get a combination of targeting sodium iodine syn-importer as well as GLUT together.
Okay. So we have a question from Dr. Prathamesh Pai. If you find sodium iodine importer gene is altered, how would we proceed?
I think we have to ask Guru only. How do you so I think, Prathamesh sir, our findings in this particular case was we did not actually go into the qualitative assessment of the gene, but it would be worthwhile actually looking at what happens if the NIS gene is altered. I think the current focus that has been tried is if the sodium iodine importer gene, for example, we know is reduced. If the sodium iodine importer gene expression is reduced, could we look at agents such as lithium, vitamin, and others to improve the expression of sodium iodine importer gene expressions in this setting? Is all what we know limited way. I think that is all that we know today. I don't know if sir has got some other inputs to add on this, but I think most of the studies have stopped short of this discussion here.
Yes. So we have another question.
I don't know if sir has got some other suggestions on this.
Yeah, maybe I think we'll have to wait for his reply. I think he might comment on
Sure.
that. I'll let you know. So we'll proceed with the next question. Is the NIS affected earlier or later in the course of disease? Does initial radioactive iodine therapy affect or cause NIS mutation?
So what we studied in this limited set of patients, we found was in these patients at the beginning. So which means I went and did thyroidectomy in 2016. 2020, the patient came with tennis. In 2016 itself, the NIS expressions were completely altered, clearly showing that these patients, the NIS was already affected. So that brings us to the point which I think Rakesh brought about and Prathamesh sir later, that these patients, the NIS is already affected. We are coming to know of it much later. In the initial phases, when you're giving radioiodine, which we give as a blanket therapy for all of them, it's like a general blanket thumb rule. In those cases, we are not differentiating and we don't know the information of NIS. So in our limited study that we have done, we have clearly shown that it is NIS that is already affected in the very early phase. We are only coming to know of it later on because that is when we are starting to dig on this.
Yes. Yeah. So, are there any role of NIS in anaplastic thyroid cancer?
As of now, no, absolutely no, because anaplastic is completely blood dependent. Completely blood dependent. It has zero NIS roles in it.
Yeah. So we have another question by Dr. Siddharth Shah. How to explain when thyroglobulin is serially getting higher, but we don't get any disease on PET or radioactive iodine ablation post radioiodine therapy?
I don't know. I think Siddharth is. This is a very, very small subset of patients that you may see that thyroglobulin is high, but generally it will not be alarmingly high because if thyroglobulin is high, it clearly shows that the NIS part is working well. And generally glut is less expressed. So it is more likely that in these subset of patients, you are going to do. The most common reason why we can explain this in this is the therapy scan. So you give the possible reasons could be stunning effect. The possible reasons in this could be low dose of iodine therapy that is given instead of 100, if you would have given 250. And if you would have done a post-therapy scan, you would see the disease being shown up. And this is what is shown in about 10 to 20% of the patients, that when you do a post-therapy scan in these patients, they are picked up the disease. So I think it is this particular category that he is alluding to, which is thyroglobulin high and where you pick up the disease in the post-therapy scan. It's the post-therapy scan that is important in this group.
Yes. So we have another question. Most cases of tennis are initially iodine avid. Which tumor or patient factors can predict future tennis?
So again, coming to this point which Mayuri has asked, the most cases of tennis are initially iodine avid. So again, re-emphasizing the fact that if you see most of their diseases, when you see initially in the phase, the iodine, they are iodine avid, and the iodine avid part, the sodium iodine dependent part is targeted by iodine and destroyed. Towards the end, what only remains the glut dependent part, and that is why it expresses later. So iodine and the glut would be to looking at the glut versus NIS, I would say a combination of both of them, because even in these studies that we did, we only looked at NIS, but we didn't look at glut. It would be worthwhile in the future to look at both of them and look at differential expression of both of them and look at possible ratios between the two to see how does this ratio map. So if you have a very high expression of cyclical threshold for NIS and low for glut, then you know that these are the kind of ratios that we have to quantitatively build as a scoring system to say what should be the customized therapy for them.
Yes. Okay. Yeah, we are done with the questions. Thank you very much, sir, for your enlightening talk.
Thank you very much.
So we'll move on to our next presentation. So next presentation is by Dr. Akshay. It's a surgical video demonstration on thyroidectomy. So Dr. Akshay is a head and neck surgical oncologist in HCG Cancer Center, Bangalore. His special interest is minimally invasive surgery of head and neck, transoral microsurgery and robotic surgery, and reconstructive surgeries of head and neck. So Dr. Akshay, over to you.
Thanks, Bhushan. So I'll just share my screen. So as a part of the organizing team, I took the liberty to talk on a relatively simple topic, that is total thyroidectomy, but it's one of the important topics for a young head and neck surgeon. This lady is a patient who was a 33-year-old lady who presented with a right side thyroid nodule. On ultrasound, the nodule measured about 3.4 centimeters, and the sonologist reported that there was a suspicious central compartment node. So in these situations, all thyroids, we plan a transverse cervical neck crease incision, and in situations we have to do a lateral neck dissection as well. Then we extend the skin incision a bit longer. It's advisable to mark the incision preoperatively in the waiting area. Look for a good skin crease, and in the female, it is always better to place incision slightly higher, about 2 to 3 finger breadth above the suprasternal notch, because there might be chance that the people with a large breast can pull the scar line downwards, and there is a risk of scar formation. We usually infiltrate with a lignocaine with adrenaline before about 5 to 10 minutes before we start the procedure. So once we do that, we start the skin incision with a surgical knife, and then we move on to a coagulation mode cautery, and then raise the skin flap in a superiorly up to the hyoid. And in situations when we have to do a lateral neck dissection, we expose the digastric on both sides, and inferiorly we go up to the suprasternal notch, exposing the medial edge of the sternocleidomastoid. So the most important part in the thyroidectomy begins with identification of the midline, which can be identified by looking at the 2 anterior jugular veins. In situations where the midline identification becomes difficult, especially when there is a large nodule, it is always better to go to the lower side where there is a splaying of the strap muscles. So getting into the right plane is very important to get an avascular plane, and an assistant countertraction plays a very important role to get an avascular plane. And you should you should take care not to hit the anterior jugular vein on the top or in the below where they join each other. So it's always good at this point to palpate the suprasternal area in situations where you have an aberrant, highly placed subclavian artery before running your cautery. So next step is to use a Babcock, and then with the help of the retractor, elevate the sternothyroid muscle right from inferior to superior, so as to get exposure of the lateral edge of the strap muscles. So this exposure is very important. And then in situation, especially when you're doing a revision thyroid, or you are anticipating a patient with a vocal cord palsy, it's a good idea to identify the ansa cervicalis with the blunt dissection and preserve it if at all possible. You can to help in laryngeal reinnervation if at all you need to sacrifice a nerve, especially in a patient with a preoperative vocal cord palsy. So next, what I do is once I free the lateral edge of the sternothyroid muscle. So the next step, what I do is I free the medial edge of the sternothyroid muscle. In all the thyroidectomy cases, I make it a practice to resect the strap both at the superior and the inferior edge. And my resection, I tend to cut this strap muscle as high as possible. The reason for my rationale for this technique, this step is one is to help in better exposure of the superior pedicle, as well as if there is any small chance of a minimal extra thyroidal extension that is dealt with this technique. And cutting of the inner layer of strap doesn't significantly affect the speech or swallowing in a patients. So as a routine, irrespective of the size of the nodule, my practice is to cut the inner layer of the strap along with the thyroid specimen. And when you cut it, I go as high as possible, and that way I get a better exposure to the superior pedicle. So once I get the superior pedicle, I apply a Babcock, get a traction, and go lower and cut the lower end of the strap. Once the superior and the inferior end of the inner layer of the strap is cut, I go to the lateral edge to expose the paracarotid gutter just at the superficial fascia level. I look for the middle thyroid vein in this during this dissection. If at all I encounter a middle thyroid vein, I clip it or suture ligate it. So by sticking to the right planes, you will have an avascular plane. So the next step, once I release the superior strap muscle and then go to the lateral edge, then I enter into the avascular reeve space. There might be tiny blood vessels which needs to bipolarize, and then go into the pedicle. I usually don't look at the superior laryngeal nerve, but I tend to be very close to the pedicle and really skeletonize the superior thyroid vessels. And then with simple blunt dissection, I skeletonize these vessels, cut open the fascia if at all there are any bands which are there adjoining the pedicle, and then either clip it or ligate it. If you have harmonic instruments such as a harmonic or a ligature in your center, you could use that as well. So I usually place 2 clips on the patient side and 1 clip onto the specimen side. So the identification of this reeve space is very critical, for which when you have to do the opposite side, you need to dissect the pyramidal lobe up downwards and then get into the reeve space when you're doing it into the opposite side. So once the superior pedicle dissection is done, then I go to the tracheoesophageal groove looking for the nerve. Initial part of my surgery, I do it standing opposite side to the side where I have to dissect the nerve. So I make just 1 pocket and tend to dissect in that pocket rather than making multiple pockets and creating bleeding. So once I dissect on that pocket, I palpate the trachea, I palpate the carotid artery, and then I identify so that's the carotid. And in this situation, there was a paratracheal node there, and more so in situations when there are paratracheal node, when you have a bulky paratracheal node, this carotid dissection helps us in identifying the nerve lower down and then following it forward. So whenever there is a paratracheal node, this technique I learned it from Vishal sir when I was doing a case in HCG, that dissecting over the carotid and identifying the nerve lower down helps in great way in identifying the nerve easily. Next step would be to identify the inferior thyroid artery and the parathyroid, and just deep to that, majority, about 50% of the times, deep to that, you will find the recurrent laryngeal nerve. So you can see the parathyroid here. And once I identify the nerve, I use a nerve stimulator and confirm the position of the nerve. And then I dissect it slightly lower down to anatomically confirm it again. And once I do that, I dissect the tissues on top of the plane of the carotid and the tissues which are there superficial to the nerve, especially when you have to do a central compartment neck dissection. So this is a very important technique. So you have a bulky lymph nodes in the central compartment. It is better to skeletonize the carotid and try to identify the nerve lower down in the neck. So now once I identify the nerve, I come to the opposite, the side where the nerve has to be dissected or the side where the thyroidectomy has to be done. And then with the assistant helping me with the retraction with the gauze piece and retracting the thyroid, I drop the parathyroid by doing a subcapsular dissection and clipping the vessel which are there, clipping or bipolarizing the vessels which are there medial to the parathyroid. And then using combination of blunt dissection, bipolar forceps, and scissors, I dissect the tissue on top of the recurrent laryngeal nerve and free the thyroid tissue to expose the berry ligament. When you're dissecting in this area very close to the nerve, it is a good practice to use certain the saline sprinkles to prevent any cautery damage. And once you cauterize this area, especially at the level of the berries ligament, you use the surgical knife. And once you are well away from the nerve, you can use a cutting mode cautery and reflect the thyroid from the trachea and free the superior edge of the thyroid near the berries ligament. Then you go down to do your paratracheal dissection, and the paratracheal dissection, you need to skeletonize the cricoid right up to the subclavian artery and remove all the lymph node in this area. It is always better to keep the nodes which are attached to the thyroid. That way it helps in counter traction. And in the midline, you might encounter the thymus, and you don't have to really remove the whole of the thymus. Only the node and an adjoining part of the thymus can be removed with the bipolar forceps. And if at all any vessels are encountered in this region, it is better to doubly clip it or ligate it, because there might be risk of the nerve dropping, the vein dropping down and causing difficult hemorrhage to manage. So that's the the central compartment dissection being done, and you can see this little venous branch which is coming from the main vein in the chest, and that has to be clipped. And once the nerve is fully dissected, all the tissues adjoining to that are safely bipolarized, clipped, and separated, and that completes the ipsilateral hemithyroidectomy. And at this point, so I just want to emphasize this point of reflecting the pyramidal lobe. So once you separate the thyroid from the trachea, and this part of the pyramidal lobe has to be dissected off to get into the reeve space appropriately. So that's the central compartment nodes being dissected. Once the ipsilateral neck dissection, ipsilateral thyroidectomy and the central compartment neck dissection is done, you go to the opposite side and do the same procedure like what we did in the right side, on the left side, to get into the tracheoesophageal groove. So again, I do the same step, identify the trachea, identify the carotid artery, and look for the nerve. So anatomically, the nerve in the left side is going to be straighter and more deeper in the tracheoesophageal groove, unlike the right side, which comes at an angle, obtuse angle in the tracheoesophageal groove. So once you dissect in the tracheoesophageal groove, you can use, if you have a facility of a nerve monitor, you can use a nerve monitor to confirm the presence of the nerve, and then you do a subcapsular dissection, staying above the plane of the plane of the recurrent laryngeal nerve and dropping the parathyroids, superior parathyroids down. So you need to be very, very gentle and careful at this region. Certain times the nerve will be very, very close to the attachment of the thyroid, and you need to use gentle dissection with a fine tip mosquito forceps, bipolar with the saline irrigation, so that there is no collateral spread of the thermal currents and damage to the nerve. Once the nerve is fully skeletonized, you do a blunt dissection, separate the tissues adjacent to the nerve, close to the thyroid, make multiple small pockets, avoiding the tiny vessels, use bipolar forceps, and then use a combination of bipolar forceps and sharp scissor dissection to reach the area of the Berry's ligament. Then, as we did in the opposite side, use a bipolar forceps. If you have a help of a nerve monitor, just doubly make sure that you are well away from the nerve, especially the anterior branch, which is very important for the vocal cord mobility. And once that is done, use a sharp dissection followed by using the monopolar cautery to complete the dissection. So in this situation, there was a large node which was sitting very, very deep right in the junction between the carotid artery as well as the axillary artery, which needed to be dissected out. So this we noticed after we removed the central compartment node. On palpation, we noticed that. At the end of the procedure, we re-stimulate the recurrent laryngeal nerve, and we compare the potential of the nerve monitor in terms of the latency, the amplitude to the first detected readings of the nerve monitor to see if there is any neuropraxia of the nerve or not. So all of these are documented and attached to the discharge summary of our patients. So you can see the right recurrent laryngeal nerve comes with an angle, and there are multiple tiny branches, and you can see the parathyroids which are sitting there. And on stimulation of the recurrent laryngeal nerve, you can notice the twitching of the cricothyroid muscle. So you can see that we have done a total thyroidectomy and dissection of the central compartment right from the hyoid to the subclavian artery, carotids on both sides. And in this situation, we did a bilateral selective neck dissection as well. So we do a Valsalva, confirm see that the hemostasis is maintained, and we place 2 small Surgicels in the thyroid bed, place 2 drains, make sure that the drains are not sitting on the tracheovascular groove, and then we do a layered closure of the outer strap muscle, and then layered closure of the subcutaneous platysma and the skin. Thank you.
Thank you, Dr. Akshay, for a beautiful demonstration. So we have a question from Dr. Mayuri, who asks, what are your tips for dealing with dilated veins in Berry's ligament area, especially in goiters?
Right. So for dealing with the dilated veins, so what I tend to do is what I explained. I use like a Debicki non-to-Debicki forceps for handling on the nerve, and the movements are very gentle, and use a sharp-tipped artery forceps to stay in a plane in a facial plane below the vein, and then I tend to use a clips rather than tying in those situations. So my technique doesn't, irrespective of the type of vessels, the technique is same: gentle handling of the vessel, getting into the right planes, be as gentle as possible, and use of clips if available. And a combination of bipolar as well as sharp dissection whenever required.
Okay. So we have a comment by Dr. Shivkumar who tells incision in sitting position in women.
Incision in sitting position or marking in sitting position?
Marking, yeah. Incision marking.
Yeah. So That is very important, Shashi. That's a very important point, that whenever we mark the incision, thyroidectomy incision, we need to mark the patient before we make them lie down in a sitting position, look for a skin crease, and in the female especially place the incision slightly higher as possible.
Yeah. So we have another question by Dr. Kudush. Any way of knowing if there could be a type 2B external branch superior branching in the upper pole?
Anyway, I mean, anatomical, it's an anatomical thing. So you need to dissect in that area, look for it. I don't know of any landmark or any, I'm sorry, I don't know about anything like that.
Okay. So again, Dr. Shashi asks, is it always necessary to cut the strap muscles even in benign disease?
So this is the practice. I mean, this is not always necessary, but this is the practice which I have been following, and it makes surgery easy for me. And for me, any surgery, I need to do the same surgery, same technique, and again to do it right. And that way my fellows or our trainees can learn it better by repeating the same step again and again. So that is my practice of doing it, but it is not really necessary to cut the strap always.
Correct. So how far would you actually delineate recurrent laryngeal nerve when your plan is just total thyroidectomy without any central compartment neck dissection?
Correct. That's a very important point. So you need not really dissect the nerve in the whole course, because when you dissect the nerve unnecessarily, especially you don't have to do a central compartment, there is a risk of neuropraxia, which is as high as about 15 to 30%. So in this situation, you don't really have to skeletonize the nerve completely. You can just identify the inferior thyroid artery, and based in relation to that, you can find out the nerve. Or you can come from the superior pole, identify the parathyroid, and look for the nerve at the entry point. And at these situations, if you have a nerve monitor, it really comes handy for doing this type of a dissection, where you have to do a minimal dissection of the nerve.
Yes. Okay. So I think a few of them are asking you to elaborate on landmarks for identifying RLN.
Right. So if you look at the RLN identification, there are two or three approaches. So one is the superior approach. The superior approach, the landmark you use it once you ligate the superior pedicle, then you identify the superior parathyroid, and the recurrent laryngeal nerve is going to be deep to the medial edge of the superior parathyroid, and identification of the cricothyroid muscle, and that way you can look for the recurrent laryngeal nerve at the entry point. So at the middle of the course of the recurrent laryngeal nerve, you can identify it by looking for the inferior thyroid artery. So, and in relation to the inferior thyroid artery, 50% of the time it is going to be inferior to the inferior thyroid artery, and about 30% is going to be superior to the inferior thyroid artery. In situations where you have a bulky disease in the paratracheal region, it is a good idea to dissect the carotid artery right up to the subclavian and try to identify the recurrent laryngeal nerve lower down in the neck. And this is also useful when you're doing a recurrent case. So you can identify the recurrent laryngeal nerve in a virgin area, which usually doesn't get dissected in a routine thyroidectomy and a central compartment neck dissection.
Yes. So,
and the trachea and carotid is a good landmark. The Siemens triangle is a good landmark to start the dissection to identify the recurrent laryngeal nerve.
Correct. Absolutely. So there's another question who's asking, do you check calcium level before total thyroidectomy?
Yeah, I think this was a question which was asked in the morning to Chaukar sir. Okay. So in our institute, as a practice, we check serum calcium in all patients as a protocol.
Okay. And do you give calcium supplementation routinely?
Post-operative.
Post-operative.
Yeah. Again, this was discussed in the morning, and our institution protocol is that if the serum calcium is less than 7, or if the patient is symptomatic, that is the situations where we would start on prophylactic calcium supplements. And we look at the trend of the calcium as well. So we look at the trend of the calcium in serial done every day.
Okay. Do you check
if there is a positive upward trend? We are comfortable and we would discharge this patient, but we would still put them on oral supplements.
Do you check PTH hormone levels post-operatively?
So we don't. We do check PTH hormones, but the frequency is just we do a 1 PTH reading an immediate post-op day. But we do PTH as everyone does when you do a parathyroid surgery.
Okay. So
not more so in a thyroid surgery, not as a routine in thyroid surgery.
In thyroid surgery. Okay. So there's a comment by Dr. Mayuri. In asymmetrical goiters with midline shift, it is better to use medial border of SCM or EJV on either side, depending on the side of the mark, as a landmark to mark the incision to avoid incision to migrate more on one side.
Yeah. So when you have a bulky goiter, that is like a goiter which has kind of done what do you call that, expander, tissue expander kind of a situation. You have excess of skin. These are the situations you may have to revise the skin significantly. So there will be because the slow growing swelling, the skin would have expanded significantly. And again, the incision plan will be as high as possible. But we need, in the end of the surgery, before closure, we may have to excise a significant amount of excessive skin.
Yes. So there's a question on, please tell about retrograde approach.
Retrograde approach, meaning superior approach, is it? Retrograde.
Probably, I think it means identifying RLN in the carotid.
Yeah, so you can either identify the recurrent lesion on the top or in the lower down in the neck, or in relation to the inferior thyroid artery.
Yes.
Does it answer?
Yes. Hello.
Yeah.
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 Okay. Yeah. So thank you very much, Dr. Akshay. It was a wonderful presentation and discussion.
Right. Thank you. Thanks, Bhushan.
Okay. So we'll move on to our next presentation by Dr. Shiv Kumar on again a surgical video demonstration on how I do it, tracheal resection. So Dr. Shiv Kumar is an associate professor in the Department of Head and Neck Surgical Oncology in Tata Memorial Hospital, Mumbai. And Dr. Shiv Kumar, over to you.
Yeah, thank you, Bhushan. I'd like to first thank HCG for inviting me to present this video, especially Akshay for having me here today. Is it visible on your screens? Bhushan?
Yes, visible. Please go ahead.
Yeah, thanks. So this video is about tracheal resection for differentiated thyroid cancer. So this is a 48-year-old lady who presented to us with a tracheostomy already done from outside, where she presented with stridor. She had no other comorbidities. On examination, she had the right vocal cord fixed already when she presented to us. And a core biopsy from the nodule gave us a diagnosis of a papillary CA thyroid. A CT scan was done. This is the virtual bronchoscopy that was done from the CT done at our institute, which showed a tumor right at the well below the subglottis, at least 2 centimeters below the subglottis, and the CT scan showing gross extrathyroidal extension involving the key groove, the party wall, and various other structures in and around it. So we did a total thyroidectomy, a tracheal resection, and a right central compartment clearance and a left central compartment sampling, along with a right neck dissection covering levels 2 to 5. So we had Dr. Devendra Chokka, who had presented the morning's lecture, along with Dr. George, who's a thoracic surgeon. For tracheal resections, we usually involve thoracic surgeons along with during the procedure, and this was the surgery done. Now I just would skip all the flaps were raised, and you can see that the skin was incised. The skin of the tracheostomy that was done was incised with the specimen, and the rest of the skin incision was a horizontal skin incision, and the flaps were raised up to the hyoid superiorly and the, as already described by Akshay, and inferiorly till the notch. And we opened the strap muscle area, and we saw that the gross extrathyroidal extension, as already seen in the scans. And here intraoperatively, we saw that the strap muscles, both the sternohyoid and the sternothyroid was infiltrated, and we could say part of the sternohyoid muscle, but most of the sternothyroid we had to remove. So they were sacrificed, and there was a lot of inflammation in the adjoining area to close to the carotid sheath. So we had to first remove the strap muscles that were infiltrated, and then dissect and go into the paracarotid and into the carotid gutter, so to say. So that's the strap muscles that are being cut. And subsequently, you would see that we would be going into the, dissecting lateral to the internal jugular vein. We can also see the ansa cervicalis going into the strap muscles, which was sacrificed. We couldn't preserve much because it was going to the diseased involved strap muscles. And we are slowly opening the carotid gutter. There you can see that, and we are going inferiorly now and dissecting all the tissue. There was a lot of central compartment nodes there, so we slowly cleared all the soft tissue over the internal carotid artery. And this is the side of the side where the vocal cord was already fixed pre-operatively. So we just wanted to see as to go ahead, see, confirm operability, and just see what is the extent of surgery, because she was already tracheostomized and it was a low tracheostomy. We all actually went in with a consent for a total laryngectomy as well in this patient, but we wanted to try hard to do only a tracheal resection. But just in case, if there was an eventuality where we had to convert it into total laryngectomy, we had taken that consent prior. You don't have to do it in all cases, but in this cases we had to do that. In this case we had to do that. Now we're dissecting at the superior pole, and we try to always see the external branch of superior laryngeal nerve. We could see that. You will see it better once the upper pole is ligated. There you see that. Once the upper pole is ligated, you'll see the external branch of superior laryngeal nerve. And individual ligation, as already mentioned by Akshay, and that's the external branch of superior laryngeal nerve there. And the paracarotid gutter dissected. Once that is done, we confirmed that it is operable, and then we moved on to the opposite side. We wanted to save all the important structures, the opposite recurrent laryngeal nerve. Remember, this is tracheal resection that we are planning to do, and we wanted to save the parathyroids, the recurrent laryngeal nerve on the opposite side. So once we confirmed operability, we knew that structures other than the recurrent laryngeal nerve could be preserved. We just went ahead. So mobilizing the straps, the sternothyroid was preserved here. We just raised the sternothyroid. We went now going to the superior pole area, trying to identify the same structures. This is the, before going into the ligating the superior pole, the practice is always to identify the inferior parathyroids. As you can see here, the inferior parathyroids here, and our practice is to apply a clip adjoining the inferior parathyroids, which helps us identify the inferior parathyroids as we do the central compartment clearance. You see the parathyroid and the gliding sign, the so-called gliding sign or the rowing sign. And we, and that's dropped down. Usually the inferior parathyroid is found, in the perimeter of 1 centimeter around the lower pole of the thyroid gland. This is the upper pole. On the other side, you see the external branch of the superior laryngeal nerve here as well. It always goes from medial to lateral, and you have to individually ligate and then individually identify the vessels and ligate. You can see the nerve in its entirety, the external branch of superior laryngeal nerve. Once that is done, you identify the superior parathyroids. We identified the superior parathyroid there, and now we are trying to dissect the thyroid of the tracheoesophageal groove, preserving the recurrent laryngeal nerve. You can see the recurrent laryngeal nerve there as it enters the larynx there. So a gentle dissection, as already mentioned, and then sharp dissection as well to get it off the trachea, the Berry's ligament area especially. So then we dissected in and around and centering onto the area of the tracheostomy there. See all the soft, the tissue removed in and around. That's the pyramidal lobe with the Delphian node, prelaryngeal node removed and taken down. Now, once that is done, we come back to the disease side again. That's the inferior thyroid artery. In this side, we had to ligate the inferior thyroid artery lower down than usual because of the amount of disease that we had. And this is the superior parathyroid on the opposite side. That is the disease side. So that was preserved, identified and preserved. Now the inferior parathyroid could not be identified. And this is the recurrent laryngeal nerve. You can see there's a lot of nodes that are there, studded with nodes. And we're just trying to dissect it off. And we just, before sacrificing the recurrent laryngeal nerve, we just wanted to see if at all there was a possibility of saving the nerve. Because there are chances that if you could anatomically preserve the nerve, it could resume, recover, the functions could recover subsequently. With that hope, we just saw before sacrificing if that is a possibility, but it didn't look like it could be saved, because you can see the nerve is already thickened. Preoperatively, the nerve was not functioning, and as we were trying to dissect it off, it was just thinning away into the disease, and we really couldn't save the nerve, a meaningful nerve. And maybe it didn't contribute to the clearance as well. So we decided to sacrifice the nerve. Subsequently, we would be sacrificing it, though it is seen intact right now. So there was infiltration into the esophagus. So with sharp dissection, we were removing the disease off the esophagus. You can see the disease was infiltrating into the esophagus. It's being dissected off using the knife. And at one point, you'll see the mucosa being exposed there, but not entering the esophagus. There you see that's the esophageal mucosa there. And it's very important to be careful here, because if you puncture the esophagus with a tracheal resection, esophageal puncture could be a double whammy. It could be troublesome in the post-op. Now, the tracheostomy was well below the area of the disease. So we went at the site of the tracheostomy area and opened it. And we confirmed that this area was not diseased with the frozen control. And the inferior limit of our resection was at this level itself after frozen control. And then once we divided the inferior area, then it was again infiltrating the party wall. We had to do a sharp dissection here. And this was in direct vision of the, after having the recurrent laryngeal nerve under your direct vision, the opposite one, because it's very, very crucial to save this recurrent laryngeal nerve. Otherwise, it would be a disaster for this tracheal resection. So slowly you just dissect it and drop the nerve down. And then we had to do a sharp dissection and get the disease off the party wall. We could just save the mucosa. And so for all these reasons, we had taken the consent for a total laryngectomy upfront, but we could get away without a total laryngectomy. And we could just do a sharp dissection. As we just kept dissecting it, we could see there was more and more disease. So we went deeper and deeper, and we ended up, and there was a time when only the mucosa could be saved and the sliver of muzzle. So it was not R2 resection. We could shave off the disease totally from the esophagus. That's the disease being shaved off totally from the esophagus, slowly and slowly. Now, once that was done, we entered the trachea superiorly, trying to see where the disease is. It's always better to have a guarded approach here to maybe get, you should definitely have a margin, but you can always revise a margin even if you're closer, so that you should be able to have adequate, tracheal rings for closure, which is not under tension. So it has to be oncologically sound, as well as, you should not be removing too many tracheal rings as well, which will put the anastomotic area at more tension. So it has to be guarded. It has to be a balanced approach, so to say. And with a margin on the posterior wall, we could take it off. It was a proliferative kind of a disease which was jetting out, but the mucosal margins was clear all around, which was confirmed on frozen section before attempting the anastomosis at the end of it, once the disease was removed. So for the interest of time, we didn't show the specimen picture, but it was confirmed with frozen that the margins of the upper and the lower tracheal rings were free of disease, and that's when we proceeded with the anastomosis. And now the pretracheal plane is being released, and usually the finger dissection and clearing all the soft tissue, that's the thymus being retracted. And good amount of tracheal release will happen with this, at least 1.5 to 2 centimeters, with a flexion of 15 to 35 degrees you can have up to 2.5 to 4 more than 4 centimeters of at least 2.5 to 3 centimeters of the laryngeal release as well. Now, it's important to understand the blood supply of the trachea, because as you dissect the posterior part of the trachea, you should need to understand that the blood supply comes from laterally. So you should not dissect on the lateral aspect, because that will devascularize the trachea and it could pose trouble. So keeping that in mind, you see the dissection is done in the posterior wall and the lateral soft tissue is kept intact, because that's where the blood supply for the trachea comes in. So it's very important to retain the, not dissect the lateral aspect. And as I already said, with a 15 to 35 degree, neck flexion, you'll get up to 4.5 centimeter of length of trachea. And it also depends on the individual body habitus and range of neck motion, depending on the age or any spondylitis and things like that, So you have to keep that in mind. Now, the other thing is to get more release, what we usually do is the suprahyoid release. There are other manuals that are described, but I would restrict to this. So we do the Montgomery suprahyoid release, described way back in the early 1970s, and you release the suprahyoid muscle between the two lesser horns and the attachment of the posterior belly of digastric, and that gives you a good amount of release of up to 2.5 centimeters. And that's what we'll be doing here. It's slightly not very clear, but it would be clear as we get the release. And we are just exposing the hyoid here between the two lesser horns. And we would be, you have to be careful that you don't go way too laterally, because as you all know that if you go laterally, you might end up damaging the nerve, the superior laryngeal nerve, and also the lingual artery might be at risk. So just restrict yourselves to the lesser horn on either side and not to go beyond that. And that should help you achieve the amount of laryngeal drop that you desire. With the neck flexion, with the pretracheal release and the laryngeal drop, you should be able to get a tension-free closure at the anastomotic site. There you go. Now you can see it better. And now once that is done, we take the sutures. We usually use the PDS sutures 3-0. And we the posterior walls are sutured. We take all the sutures up front, and you should remember to intermittently keep ventilating the patient. That is very important. And you take all the sutures up front, the posterior layer, starting from the lateral, and then we tie the sutures of the posterior layer first. And then once that is done, you have to be careful, because you have to identify what are the different, because you take the stitch and put it laterally and put them in correct place. Otherwise it will be messy, because you have quite a lot of them as you take the sutures first. And intermittently keep ventilating the patient, and then take the tube off and keep ligating the knots. So once the posterior part is sutured and ligated, sutured well, then now you go. Now we close the rest of the trachea anteriorly. You can see the recurrent laryngeal nerve. It's always in your vision. It should be kept under vision, because it should not be injured. Otherwise, throughout your anastomosis, we see. And here it's very important. Here you see, before closing the anterior wall, you see to that the tube goes beyond your site of the anastomosis, and make sure that the cuff of the endotracheal tube is well beyond the anastomotic area. Otherwise, if it is against the anastomotic area, that could again be it could impose problem in the postoperative period. So you make sure that it is well beyond the anastomotic area, and we suture it. And at all point, we have to keep the recurrent laryngeal nerve inside and make sure it's all well preserved. We usually tend to use a intraoperative nerve monitor, but off late we have started using them in most of our cases. And you could also confirm the functioning before you come out as well. So once you just ligate all around, and make sure the knots are not loose. Otherwise, that could give rise to not to mention, it will be one of the contributing factors for the postoperative morbidity. So make sure the approximation is good, and not the cartilages are not overriding. So once you have taken all the sutures, then we just instill saline and do a Valsalva and just see if there's any space that is still left uncovered. And there was nothing that was, and look for air bubbles, and there was nothing of that sort. So we had achieved a proper anastomosis. We can see the nerve in its entirety, and in this case we used the fibrin glue, but it's not always necessary to use it. And the histopathology revealed that the patient had a tall cell variant of the papillary thyroid carcinoma, and the nodal metastasis, high risk as per the ATA stratification. And this is the in the post-operative period, the fiber optic laryngoscopy. The patient required good amount of rehabilitation, and we can see the cord on the left side is functioning. The patient here is trying to phonate. And you can see the cord mobile here on the left side. The right side is understandably fixed. And this is the virtual bronchoscopy of the CT scan done subsequently during the follow-up in the post-op. The anastomotic area is not stenosed, and it's nice and good out there. So this is the follow-up of the patient. The patient received radioactive iodine of 200 millicuries. We also gave adjuvant radiotherapy because of the gross extrathyroidal extension, and because we had to shave off from the adjacent areas. The last we saw the patient was recently in September 2020. The patient was on oral feeds. She was on suppressive therapy, and calcium was pretty good without supplements. I'd like to acknowledge the team that helped us put up the video together, and thank you for the patient listening. I'll stop sharing the screen, and I can take questions if there are any.
Thank you, Dr. Shivkumar. Wonderful demonstration. So we'll move on to the questions.
Yeah.
The first question is, what type of anesthesia did you use in tracheostomy in this case? So did you do a high tracheostomy?
So this tracheostomy was not done at our center. The patient was already tracheostomized when she came to us. And if at all you end up doing a tracheostomy prior to the tracheal resection, it will be better to do a high tracheostomy, so that you don't end up losing that segment of the trachea as well.
Yes. So there's another question by Dr. Siddharth Shah.
Yeah.
How long the patient is kept intubated, or when do you extubate?
We keep the patient intubated overnight. And as a protocol, we also do a chest X-ray to just check the position of the tracheostomy tubes. Because what happens is, you have removed the segment of the trachea, you keep the neck under flexion. So sometimes you might end up having the endotracheal tube going onto the right side of the bronchi. So you want to make sure that the endotracheal tube is not ventilating only the right side, because that could be counterproductive and could give rise to a lot of problems in the post-op.
So, Dr. Akshay,
morning, after the next day morning, we usually plan extubation.
Yes. So before extubation, do you do a check scopy or anything?
You could do that, but depending on the case, if there is any clinically, if the X-ray is normal, the X-ray that if the tube is in position, then you could do a check, check scopy. But a check scopy in the sense fiber optic bronchoscopy, you're saying?
Yes.
But
fiber optic through the tube.
Routinely. No, the patient is extubated with a tube exchanger, and if required, if there is a problem that we anticipate, then we do a fiber optic bronchoscopy, check bronchoscopy. Otherwise, not routinely.
Fair enough. So, how many resected tracheal rings can be closed primarily?
Up to 5 rings is what is being said, without much tension, and it can be more than that once you do all the release. If it's all in literature, it's mentioned. I've not done it though, but if you release the pericardial, ligaments and the tissue in the mediastinum, you can release even beyond more than 5 to 7 rings, tracheal rings. But that would be quite a bit of.
Okay. Do you keep the patient in a neck flexion position? You put a cast or anything?
Yeah. So this is always so you take what is known as the guardian stitch or the Grillo stitch from the mentum to the manubrium sterni, but that is what is described in literature. We used to take that, but our thoracic surgeons or some of us didn't like it. So what we do is we also give the soft collar in the reverse direction so that it keeps the neck in the flexed position. That is another way to do it. So some of us do it, some of us don't do it. So it's just a matter of preference, I guess.
Yes. Okay. So Dr. Mayuri congratulates you on your presentation, and she wants you to elaborate on suturing of the posterior wall. regarding the extraluminal placing of knots?
So it's just the inside out technique that you would see, so that the knot goes on the outside and not on the inside.
So on the posterior wall, it's on the extraluminal.
Yes, yes. So that's the way it is. We use a PDS, so it's an absorbable suture that you would use. So it wouldn't. It would take care of that as well.
Would you give a strap muscle cover over the suture line
In this
of
case, we did
vascularized tissue?
Yes, the strap muscles of the opposite side that was kept intact was brought anterior to the resected part of the anastomotic area and covered well with that.
Preoperatively, can you elaborate on imaging, particularly for evaluation of esophagus? You rely on CT or MR or any contrast-based barium studies?
So what routinely is done is a contrast-enhanced CT scan for sure. If you want to study the esophageal involvement, in literature it says that the MRI is better to study the esophageal infiltration. And of late, what we have also started doing is to do an endoscopic ultrasound of the esophagus. We do an upper GI endoscopy, and through that, an endoscopic ultrasound to study as to what are the layers of the esophagus that is involved. So that also gives us some amount of idea. So if you have that facility, you can do that. But a CT complemented with an MRI for the esophagus is good enough.
Yes, yes. So there's another question by Dr. Joshna. How do we manage esophageal injury intraoperatively?
So that's what it's better. It can be closed primarily, but if you damage the esophagus intraoperatively, then that's good. That may predispose to a lot of problems in the post-op. So that's a big no-no. So you have to take all precautions of so that you do not end up in that situation. Because once you damage the esophagus, even if you do a closure, you augment it with some muscle. So many times we have done it with the PMMF. Sternocleidomastoid mastoid may not be always sufficient there, so it's going to be a problem. It has to be closed in layers, but as you know, it's going to be a problem, and the saliva can slip out, and the patient has to be kept under close monitoring for any leak in the post-op. And the patient may have a stormy post-operative period. So we have to do everything possible to avoid an esophageal injury.
Yes. So Dr. Siddharth Shah asks, if you had to remove more than 5 rings, would you consider doing tracheostomy?
So meaning to say before or after? I don't understand this question. So
yeah, he's not clarified it.
It's always better to avoid a tracheostomy if possible. So after the procedure, again, it's always better to avoid a tracheostomy as much as possible. I mean, that's why it was so crucial that we preserve the opposite recurrent laryngeal nerve for us, which we could, and it's always better to avoid a tracheostomy. But if you end up in a situation where you have to do a tracheostomy, then it has to be closer to the anastomotic site, I guess, because just in case you have to do a re-anastomosis, because the lower you do, already the trachea has come up, so it might slip down. So it's a difficult situation to be in again. So you don't have to do a tracheostomy again. You'll have to just weigh the pros and cons. Intubation is definitely not considered, because after the anastomotic site, you may have a false entry, so you might end up doing a tracheostomy. Yes. But you don't want to be in that situation, for sure.
No, he clarifies it's for after the procedure.
Yeah, I just saw that.
Yeah. Okay. So there's another question by Dr. Yusu. What are the post-operative complications in such cases?
Well, of course, the most common thing could be, a subcutaneous emphysema that tells us that there is a leak from the anastomotic side. If it is not too much, it's not going down into the mediastinum or way up into the, till the zygoma, then we can conservatively manage this patient. And the other thing is, if the tube goes into you end up doing a one-sided ventilation, as I was just mentioning, if you do not make sure that if you're keeping the patient intubated overnight, and if you're not sure of whether the tube is well above or gone into on the right bronchi, then that may collapse the left lung, and there might be a mucus plug, and that could just be a vicious cycle, and it can be a problem. So, and you can end up having an atelectasis, a pneumonia, and all sorts of complications will just come over and over again. So that's why I mentioned, as a protocol, we do a check X-ray, and you make sure that the tube is not in one of the bronchi, make sure it is well above. So that, and also not so much above that it's at the anastomotic side. So it has to be managed appropriately.
Yes. Yes. So when would you consider to proceed with laryngectomy intraoperatively, apart from bilateral nerve getting involved?
So if, for example, maybe if you could not shave off the disease of the esophagus adequately, as much as you're leaving behind gross disease onto the esophagus, or you end up removing, a bigger part of the esophagus, maybe that might be a situation. Of course, the nerve, when both the nerves are involved, that is definitely one of the situations where you will convert it into a total laryngectomy. I'm not sure if there will be any other situation where I would end up doing a total laryngectomy. But I think if the esophageal injury is far beyond repair, then I think that will be one situation where we'll be forced to do a total laryngectomy.
Agreed. I think saving the recurrent laryngeal nerve and avoiding extensive paratracheal dissection are key factors in this surgery.
Yes, absolutely.
Okay. So I think we are done with the questions. Thank you, Dr. Shivkumar, for joining us and for a wonderful presentation.
Thank you once again, and I'd like to thank Akshay and HCG for the opportunity. Thank you.
Thank you. So we'll move on to our next talk by Dr. Siddharth Shah. It will be a surgical video presentation on parathyroid surgery. So Dr. Siddharth Shah is a robotic head and neck surgeon in Zydus Cancer Center in Ahmedabad, Gujarat, with over 14 years of experience. His special areas of interest is skull base and airway reconstruction. Dr. Siddharth Shah, we welcome you and over to you. Dr. Siddharth? Dr. Siddharth, are we audible?
Just checking, is Siddharth there? He's muted.
He's muted, yeah.
So I'll just ring him once again.
Yeah.
Yeah, I'm sorry. Hi, very good evening to all. Am I audible now?
Yes, sir, you're audible.
Yeah, so very good evening to all. I thank Akshay and the entire team for an excellent academic feast over last 2 weeks. And thank you for this opportunity for presenting this video on parathyroid adenoma and excision. So parathyroid adenoma as a primary hyperparathyroid disease is a very common condition that we encounter. And the recent trend is towards minimal access surgeries. And so here I'm going to present a video on minimal access parathyroidectomy. And this case I have done under a local cervical block. So we often we help to do this surgery in a high risk patients who are not that GA suitable, and they have raised creatinine levels which make them maybe a very hypertensive patient who maybe has a very high risk for general anesthesia procedure. So taking up this challenge at our place, I decided to explore the possibility of doing it under a local cervical block. So I'll be sharing with you the video. So the patient is a male, 58 years, with history of recurrent renal stones.
Sorry,
and
Dr. Siddharth.
Yes.
Have you shared the screen? We are not able to see your screen.
Oh, I'm sorry. Let me do that first. Sorry.
That's okay.
So is it seen now?
Yes, sir, it's seen.
Okay. So present case is a male, 58 years, who is a known hypertensive and a history of recurrent renal stones. and he had a grossly
generally
abnormal
performed under
create
general
levels
anesthesia,
and
but in
parathyroid
high-risk
hormone
cases, a
levels,
local
and
cervical
also
block is used.
the calcium
The
levels were
present
raised.
case is a male,
So
58
this
years,
patient
hypertensive
required
with
was a
history
very
of
high
recurrent
risk for
renal
under
stones.
general anesthesia, and so the nephrologist requested to do it under local. So the patient
Grossly
had
altered
a right inferior
calcium
parathyroid
levels,
adenoma,
parathyroid
which was
hormone levels
localized on
became
the
unbalanced.
ultrasonography as well as on the parathyroid scan.
Ultrasound of the neck
So the
showed
ultrasonography
right
shows a right inferior parathyroid adenoma, which is quite adjacent to the lower pole of the thyroid gland, and this is the sternocleidomastoid muscle. So this very typically tells me that the moment I track the anterior border of the sternocleidomastoid, I'll be able to identify the parathyroid adenoma. So ultrasonographic preoperatively is a very good tool for localization of the adenoma. At the same time, it also gives you the treatment plan of where you will be finding the adenoma
inferior
in location
parathyroid
to the
adenoma,
external
closely
approach, I
abutting the
mean the
lower pole of
surface
the
lead
thyroid
marking.
gland.
So I routinely do this ultrasound for every patient,
The
and I
ultrasound is
sit
learned
with the
in a surgical
radiologist
position, that
and
is
try to
extended
identify
neck
the
with head
overlying
turned
skin
slightly onto
crease,
the right
which
side.
will
The
give me a
surface
direct
lead marking
access to
is
the
done.
adenoma once I open up this. And this is the key point towards the
Parathyroid
minimal access approach. So the parathyroid scan was also done, which also confirmed that there is a single adenoma present, and so it is a primary hyperparathyroidism.
scan confirms the presence of a single adenoma on the right
So
side.
first of all, is most important thing is counseling of the patient. The patient has to be counseled about the procedure. The compliance and the cooperation of the patient on table is very important. They are already apprehensive for the procedure, and a thorough counseling of this patient that you will need to be placed in the extended neck position with a turn on the opposite side, which is kind of an aching for them. So you allow them intermittent relaxation as and when they feel, and to guide us whether they are any discomfort during the procedure. One point I just forgot to mention is whenever we do an ultrasound, it has to be in the surgical position. So I keep the patient in the slightly extended and head turned to the opposite side. That will be the surgical position, so that I can exactly mark the skin crease wherein I will be able to locate the
cervical block
adenoma.
is given
Now,
along the
deciding the
posterior
site for the
border of the
cervical block, it is
sternocleidomastoid
generally the
muscle at the
upper
junction
two-third
of
and the
upper
middle third
one-third and
junction,
lower
upper
two-third
one-third and middle
fibers,
third
that is the
junction.
ups point.
And we use a solution of
A solution
2%
of 2%
lignocaine and
lignocaine
0.5%
and 0.5%
bupivacaine in 1:1
1:1
dilation.
dilation is
And it is
injected
generally
at the
injected along the posterior border of the sternocleidomastoid in a fan-shaped fashion for this. This is for the deep cervical block.
ups
And
point in a
also the
fan-shaped
surgical site
fashion.
incision is also infiltrated for the local
The
anesthetic
superior
effect.
block is given
After we
along the
confirm
surgical
that the
site
patient has
incision.
adequate
At this
anesthesia achieved, we send a baseline parathyroid hormone levels before we start the procedure, which will give us an landmark or maybe a baseline reading of the parathyroid hormone. So
stage,
once
a
the adequate
baseline
anesthesia is
parathyroid hormone
confirmed, the
levels
skin
are sent.
subcutaneous and the
The
platysma is
skin and
cut,
platysma is
and
cut,
we try to mobilize
flaps are
minimally
mobilized, and the
the
sternocleidomastoid
subplatysmal flap
muscle
and
anterior
identify
border
the
is
anterior border of the
identified.
sternocleidomastoid muscle.
The muscle is
And
retracted
once you
laterally,
identify the
and
sternocleidomastoid,
the
this
superior
immediately here
belly of the
is the
omohyoid
parathyroid
muscle
adenoma.
is retracted medially.
So you retract the laterally the sternocleidomastoid muscle, and
This exposes the
medially
parathyroid
the
adenoma.
superior belly of the omohyoid, which will expose us the adenoma. And then
The
a gentle
adenoma is
subcapsular
gently pulled,
dissection is
and a
done
subcapsular
with
dissection
handling the
is
parathyroid adenoma
performed
very gently.
so that there is
Yes.
no bleeding.
Sir,
The
there are
pedicle
double voices heard
is
because there is volume on your video. Could you please?
What should I do? Should I minimize it? Is it okay now? Just tell me.
Sir, you can just
It is
mute the video coming.
Is it coming?
You can mute
Yes, sir,
the
it is still audible.
video. Just mute the video and you can speak.
Okay. I'm just trying to locate where to mute.
I can just decrease the volume from the video.
Yeah, I'll do that. Is it okay?
And is thoroughly
Or is it
coagulated
still coming?
using a bipolar
It's still coming.
A bipolar cauterization is preferred in this.
Just for a second, please pardon me. I've kind of almost minimized the volume, but that mutes me as well. Am I audible?
Yes, sir, you are audible.
Okay, I'm audible. Fine. So just confirm me whether it is still
Region
coming.
to prevent any
Yeah, it's
thermal
still
damage.
I think, sir, you can go ahead with the video commentary and then discuss probably in the end.
Okay,
To the
fine,
underlying
fine.
recurrent
Commentary is
So
very
the
good.
video commentary is okay, the volume wise?
A proper coagulation of the
Yes,
entire
sir.
pedicle is important to prevent any bleeding in this region.
So at this stage, most important thing is a bipolar dissection, so as to have an adequate coagulation without damaging or injuring the recurrent laryngeal nerve underlying.
After ensuring adequate cauterization, the pedicle is cut with scissors. The adenoma is held at the pedicle and a gentle subcapsular dissection is continued to prevent any injury or damage or settling of the adenoma in the tissues. As the adenoma is gradually removed and delivered, the time is noted of its removal. After around a wait of 15 to 20 minutes, a repeat blood sample for the evaluation of the parathyroid hormone is sent. A minimum drop of 50% is expected for an adequate removal of the adenoma. In certain instances, the adenoma may be sent for frozen evaluation to confirm the presence of parathyroid tissue in the removed specimen. Adequate hemostasis is achieved and confirmed in the bed of the parathyroid tissue before the closure is done. The wound is closed in layers and the patient is shifted into the post-op recovery. Post-operatively, serum calcium levels are monitored to early diagnose hypocalcemia and the resultant tetany. On the next post-operative day, serum calcium levels and parathyroid hormone levels are ensured before the patient is discharged. Thank you for watching.
So, thank you. Thank you for this video watching. Do you have any questions?
Thank you very much, sir, for excellent demonstration. So,
yeah.
So if Dr. Akshay asks, would you change the extent of surgery if frozen comes positive?
So positive in terms of what? I mean, for malignancy. Yeah, so Akshay has clarified for malignancy. So I think parathyroid, if it is C, I mean, probably you will be having some clinical insights before you're planning for the surgery, the size of the gland, its association or relation with the thyroid gland. Now, if there is a surprise that it is a parathyroid carcinoma, now during my dissection, if I found that the planes with the thyroid gland are not very bad, or maybe it's a very easily dissectable, probably I may not go back and do a hemithyroidectomy. But in certain instances where I have found that we have done 2 cases of parathyroid carcinoma, and so the entire thyroid gland was kind of almost infiltrated or maybe adherent closely. So we went back and during the surgery only we realized that it is a parathyroid carcinoma probably, and so we did a thyroidectomy, hemithyroidectomy simultaneously. So frozen is primarily to confirm that the removed tissue is a parathyroid as a documentation, and the parathyroid hormone drop gives us a indirect evidence maybe or a direct evidence that the adenoma, which was the culprit, has been removed.
Yeah, would you proceed central compartment dissection also?
So in the case of parathyroid carcinoma, not as a dissection, but if I find any abnormal looking node, probably I'll pick it up and send it for frozen to confirm first.
Okay. Okay. So there's another question by Dr. Rakesh. What do you recommend to curb hungry bone syndrome?
Sir, it's a biochemical thing. So definitely a clinical diagnosis, like the levels of the calcium in the preoperative, will give you a guide that the patient is going to enter into a hungry bone syndrome. So raised serum calcium levels of more than 13 or 12, more than 12, will give you some clue about the long-standingness. At the same time, if there is a radiological evidence done and you see the bone porosity, you realize that this patient is going to go into hungry bone syndrome. So these patients for post-operative are monitored very closely for the serum calcium levels, and for these patients, a prophylactic supplementation, IV supplementation is started so as the patient's serum calcium levels doesn't grow very sharply down. So they are monitored in ICU for at least 24 hours so that we do not develop in any medical emergency.
Yes. So Dr. Mayuri asks, with such a patient with advanced renal disease making GA unsuitable, there is a high chance of hyperplasia in other glands. Would you recommend a threshold of 80% drop instead of 50% drop in PTH value, intra-PTH value?
Well taken point. First of all, I'll also compare the imaging findings. So the imaging was classically showing a major involvement of one parathyroid. The parathyroid scan was also able to identify, but I agree that because it's one of the enlarged gland, it may take up the entire isotope. So yes, considering these facts, probably we may explain to the patient that he may not have an adequate drop in the parathyroid, but not at the same sitting that I'll be exploring the other parathyroid glands. We'll wait. As this case, you see, the next day the parathyroid drop was almost within the normal range. So if required, the patient is counseled preoperatively that if we do not have a satisfactory drop in the parathyroid in the next few weeks, probably we may consider for exploring the other glands.
So we don't go for a 4-gland exploration in the same setting. That's what you meant to say.
Yeah.
Okay. So do we use gamma probe to localization?
I haven't used ever.
There's another question by Dr. Yusuf. Does it need to take post-operative ultrasound or any other imaging?
So for what purpose we want to do post-operative imaging is important. So once we are sure in preoperatively we have located the adenoma and we have identified it and confirmed it post-operatively, like in frozen section also, and we have confirmed the drop. As such, there is no need to do any post-operative imaging. I mean, at least for this, unless you are anticipating some hematoma or clot formation at the thyroid bed, or you are seeing some swelling in the region, probably in that situation, probably you might do post-operative imaging.
What's your take on intrathyroidal parathyroid?
Yeah, so that's a difficult situation. So in that case, first of all, you will have to kind of be prepared that the adenoma could be an intrathyroid. So clue could be one on ultrasound, preoperative ultrasound, you are not able to kind of distinctively identify the adenoma. Second is when you are not able to distinctly do that and the parathyroid scan still shows that there is a likelihood of an adenoma, we may do a 4D scan which is specific for a parathyroid adenoma and try to identify if there is a separate adenoma or it is very closely in relation to the thyroid gland or part of the thyroid gland itself. And intraoperatively, you try to look for the parathyroid location, and if probably you see that it is still not being isolatedly identified, you may consider doing an hemithyroidectomy for that.
I think we are done with the questions. So thank you very much, Dr. Siddharth, for the wonderful discussion.
Thank you all. Thank you, Akshay and Vishal and the entire team, Dr. All the team at the HCG Academics for this excellent event. Have a great week.
Thank you.
Night.
Thank you, everyone. So on behalf of the organizing committee, I would like to thank Bhushan for the beautiful moderation session and all the speakers, especially for Kapre sir for sharing his huge experience on such a difficult topic and making it very simple. For Vishal sir, as always, takes up complex topics, simplifies things, and makes us understand better. Shiva for a wonderful demonstration, breaking resection, and Siddharth, Dr. Siddharth Shah for a beautiful demonstration of the parathyroid adenoma. So Vishal sir, any final comments? I guess so. Finally, thank you all participants. We look forward for our future meetings. We will keep you posted on the future meetings which we'll be going to have. And for today, it's goodbye from the HCG Academics team. Bye.
Thank you, Dr. Akshay. Thank you, everyone.